gaining more and more prominence. They are even reconstructing the acetabular nowadays. And tension and strength of the ligaments, yes. This, as Dr. Akash highlighted, the highest anteriorly, the pubofemoral ligament is the strongest. That's, I'll tell you why that has become strongest during the time of evolution. Surrounding stronger muscles are necessary. These are muscles very necessary because hip is the one which supports almost like half of our body weight, almost like full body weight. It transmits more, and to balance that, bones are not sufficient alone. To balance the bone on the body, the joint on the body, you require very strong muscles. And length and obliquity of the femur is the one which we'll be discussing more on details of the ligaments, and plenty of them, as Dr. Akash told. I don't want to go through this. Yes, the angulations of femur coming here. First, this is the head and neck angulation, which is most commonly we always see has been noted up to around 120 to 130 degrees. And you should always wonder why it was 120 to 130. Why not more? Why not less? When I tried to find out why this is 120, why this evolution has made it 120, this is because considering the obliquity of your acetabulum, the way it is placed, even this angle as well as that angle of antiversion, the angle, this antitorsion or antiversion, some people refer it as an antitorsion. So these two angles are evolved over a period of time in humans to give us the maximum amount of movements possible with this amount of angulation of acetabulum. So if you alter these angles, as you always know, when you do a varus derotation osteotomy or a valgus osteotomy, you lose some amount of moment. So this is the optimal angle which God has created, or evolution, if people who don't believe in God. Yes, because without these two angles being proper, you cannot have the range of movements which are possible in a hip joint. And coming to the antiversion angle, giving this antiversion angle, you can see that you are trying to get the center of your body weight is in front of S1 here, which is in line with your line of femur. And without this antiversion, your femur will not come back to that line. And that is why the antiversion is responsible. And getting this angle, once you have this angle, then your acetabulum in the front becomes uncovered. And there are no stronger muscles. The posterior muscles are very strong, anti-gravity muscles. So that is why the iliofemoral ligament becomes strongest ligament in the body to prevent your hyperextension. So that is how it is developed over a period of time. As quadripods to bipedal gait, and this is how it developed. So hip motion and hip and pelvis motion during the gait, it varies. So the maximum amount of flexion in a normal gait cycle is around 30 degrees, and 10 degrees of extension is required in the sagittal plane. 5 to 10 degrees of adduction and abduction, and 5 to 10 degrees of interrotation are always part of your normal motion. And this is with regard only to the hip joint. And now coming back to the pelvis, it also not only moves in this plane, not only moves in the adduction, there is a rotation of pelvis which is happening. This is at the initial stance phase, and then when you start moving the other hip, and this is in a swing phase, you go and step it here and then go forward. So pelvis rotates. This is called the left forward rotation, because the left side is moving forward, and then the left backward rotation, depending upon which leg is at stance phase. And in the coronal plane, there is some amount of adduction. You can consider this, you're all correlating, take out this term. So in the bipedal stance, your pelvis is neutral, and then once you have a mid stance, the other leg is off the ground. The which one is off the ground is the pelvis drops down. So automatically the other pelvis, the foot which is landed, there is an adduction happening here, which is around 5 degrees. And again, there is a bipedal stance, neutral, and then the opposite hip lands and this hip goes up. So when the opposite hip lands, there is an adduction on that side, abduction on this side. So it's a coordinated movement of pelvis, not only in the coronal plane, even in the sagittal plane also there is a pelvic tilt which happens, but most nicely compensates with a good hip joint. If the hip is stiff, then spinopelvic movements comes into picture. And similarly, as this picture shows here, once the right foot is on stance phase, there is an adduction happening, and there is an abduction in the opposite side. So what are the normal movements of hip in our day-to-day activities? So what we do usually, like tying the shoe and try to bend and tie the shoes, there are 124 degrees of motion. This is the highest which we can have. Even squatting gives us only 122. This is all documented and studied with respect to the 3D motion analysis figures. So the frontal and the transverse plane movements are maximum around 20 degrees, and the transverse means the rotations, which is being highest being around 30 degrees in our day-to-day activities. So coming to the measurements or the points which are necessary to calculate the forces around the hip are, first is the center of your femoral head called the C, the center of your body, which helps in calculating the body weight transmission angle. This point T is a very important point wherein you cannot arbitrarily take it. It is the insertion of your abductors. You can't take a line which comes from the shaft and which at the piriform fossa. No, it is more lateral. Even some of the authors who have studied the biomechanics, they even say this is more lateral because you have tensor fascia lata as the most important abductor of the hip joint. So more lateral the abductor is, the longer the lever arm, less force necessary. And obviously the loading response is also calculated with regard to the center edge angle. So coming to calculating of a joint reaction force, of how normally you might have understood all these joint reaction forces in the hip joint. So what is the joint reaction force? As you know about the third law of Newton's, when every force has equal and opposite reaction, there is a lot of force which is happening at the hip joint. One which is coming down is like the body weight. And to counterbalance this, the abductor is pulling here. If the body weight falls on this, your pelvis tries to tilt on the opposite side. To prevent that, the abductor mechanism is pulling and causing an abductor force here. And both these forces are in such a way that they are pushing the femoral head. So the joint reaction force is the equal and opposite force which is happening in the opposite direction. And it is always more than either of these two forces, the abductor force or the weight bearing force. So how the joint reaction forces which are being calculated, most of the times it has been slight changes have occurred by different authors, but consensus is it's around 2%, 2 times your body weight during an SLR, 3 times your body weight in a single leg stance, 5 times in walking, and 10 times in running. I will give you another picture of what are the joint reaction forces which have been properly studied. As you can note here, there is 2 times the body weight during an SLR, and this is why some people it is recommended whenever you fix a hip, it's a very delicate fixation, you teach the patient to walk putting weight on the operated hip, you are putting less load on the joint, but it is actually opposite. The load on the joint is going more if you don't do a toe touch. And usually these forces or whatever this diagram also I have discussed, it's something called as free body analysis. They always consider one plane to simplify, but there are many planes. So in a bipedal stance, the forces calculated by different authors, the least whichever force is calculated is 1/3 on each hip in a bipedal stance. But few authors argue that the muscles are always acting. Though you are trying to stand on both the hips, the muscles are acting, and each hip they have shown to have around 3 times the body weight even in a bipedal stance. In coming to a single leg stance, you have, whenever this is the hip which is shown as loaded on the ground, the opposite hip is free. So the body weight tends to go out, and hence you have an increased lever arm here. And to counterbalance this lever arm, the body weight is the same, but the lever arm increased. So W into D should be equal to the abductor force into the length here, the perpendicular length between this point and the abductors, which is around I. Okay, so and then that is why your abductor forces or the joint reaction forces will increase in a single leg standing, basically because your weight is going on that side. So what happens in a painful hip? When you have like this, and if you have a painful hip without any assistance, what will you do? Patient usually tries to lean on the same side. You might be wondering why is it happening. But when you can see this single leg stance without leaning, the body weight goes some of the center. When the patient leans on the same side in the infected or the painful leg, the lever arm of the body weight gets reduced. Once the lever arm of the body weight gets reduced, the forces generated by the abductors are also less. And both these becoming less will generate less joint reaction forces, less pain in the hip joint. So that is why whenever the patient leans on the same side, it means that he is trying to reduce the pain on the hip. The same cannot be said to knee joint. In the knee joint, when you have an antalgic gait, you can always see that the stance phase on that leg is very well reduced. That is because the whole body weight goes into a single area. There is no abductor mechanism in the knee joint. Now, coming to use of cane. In our understanding in our earlier postgraduate days, we were thinking why the doctor is mentioning, or consultant is mentioning to have hold the cane in the opposite hand, and then we went to the biomechanics. The cane gives opposite reaction force and a long lever arm. So this compensates, reduces the abductor lever arm on the opposite side. The body weight also goes through the cane. It has been shown that if 15% of the body weight goes through the cane, 50% of the joint reaction forces are reduced. 5% goes through the cane, 50% of body weight, joint reaction forces are reduced into the joint. So holding the cane is by increasing the lever arm of the opposite hip. So forces are always measured directly in orthoplasty. This was done by Bergman. He had counseled some patients and he implanted special arthroplasty implants in his patients which had force transducers, and he measured it. So he showed that level walking, the forces had peaking at 2 times in a stance. One is at the time of heel strike, another peak was just before the toe off. So, but the muscles responsible were different at both the times. Initial muscles are different when your toe off is different, but there are 2 peaks in one single stance. And this in early stance and second peak in the late stance. And the normal speed, the body weight is around 240%, that is 2.4 times the body weight, and which is more than standing in a single leg stance. Going upstairs is around 250%, going downstairs is around 260%. Most importantly, what he noticed was when a patient stumbles unexpectedly on something, the forces in the joints were very, very high, at around 870%. This he also measured in jogging because it was a replaced joint. He couldn't measure in like a sprinting. He measured in a light jog and he got it around 550% only. So he mentioned that the stumbling, which was unanticipated, created the highest forces in a joint. Again, reviewers will say that this was a replaced joint, not a native joint, and cannot be applied to a native joint because the forces, the muscles also would have been disturbed. They may or may not be acting. So considering this can be a guideline for you to understand what are the forces generated in the hip. So clinical approaches of these, as you go and try to study biomechanics, most of them are discussed with regard to arthroplasty, and they will tell you how to medialize the center, how to lateralize the trochanter. But you also, this being a hip preservation CME, we have to try to understand with regard to the hip preservation. So stresses on the proximal femur are also important. As I have mentioned, the normal angle around 120 degrees, 175% of load, 175 weight when is applied. There is a compression force on this side, and there is the opposite hip you will have amount of tensile weight. It's a good break for everyone.
In between, I have questions, sir.
Yes, please.
Yeah. So most of the patients have to put the cane on the same side of the window.
See, it is their mentality. That is because you are not trying to teach them when to put the cane. See, if you give it to the opposite hand, you have to teach them that it has to go with the normal opposite limb, which is your operated limb. If they give that cane and ask them to walk, they will put this cane when the normal limb is going in front. That is not the case. You have to give the cane to go with this limb. If your left is operated and right hand is your cane, you should ask them to put the cane and the leg together. If they put it opposite, like for example, if you ask them, they'll put it like this and they'll walk. So that is not a useful. you saw that painful limb, no, you were trying to lurch on the same side, you're trying to reduce. So what happens here is you are preventing this lurch by giving support on the opposite. That is what you are able to do.
But that will increase the joint reaction forces.
Which one?
If you put the cane on the opposite side.
No, it will reduce the joint reaction forces. The lever arm of the body weight gets transmitted that side. Along with it, as I told you, there is an equal and opposite force. So this abductor mechanism reduces. The cane force is coming up, not in the going down. Thanks, okay. Coming to the stresses on the proximal femur, they all depend upon the angulation of your femur. So, as you see here, this is the normal angle here, and you can see a long trabeculae which are the compressive forces. And in the normal angle, neck shaft angle, compression forces are more than the tensile forces. So the tensile trabeculae are there, but they are not very strong. The compressive trabeculae are stronger. As you increase, as it goes in for varus, the compressive trabeculae are a little less, more of tensile trabeculae. And if the valgus increases, there are no tensile trabeculae. All the forces are going into the compression mode. So this diagram helps us to understand how to fix a neck of femur and how this is actually a Powell's old work, and this has been taken from his work. So if you increase your compressive forces more by making it more valgus, the tensile trabeculae are reduced so that your fracture line gets more compression than tension or shear forces. So there is one more interesting hypothesis by something called by Mr. Von Lans. This is a very old work, and he tried to determine not only the angulation of femur but also how much of force is transmitted through what angle from the femoral head to the acetabulum. And this X-ray or this imaging he did with the help of something as we do an inlet pelvic view, tilting the pelvis anteriorly by 30 degrees so that the pelvic brim is in line with your cassette and X-rays are going perpendicular to that. So in that plane, when you take an X-ray and you see that normally there is something that he measures it as a joint congruency angle or angle of entry. This is angle of entry of Von Lans, and he says at normally there is around 90 degrees of the arc of the femoral head which transmits the weight. If you increase it, if you give a varus osteotomy, the forces are distributed over a wider area. If you give a valgus, the forces are distributed a lesser area. And if there is an acetabular inclination which is more vertical than normal, and there is also a valgus, then there is a very small amount of femur which transmits the weight, causing loading of the femur. So biomechanics in the neck deformities, same thing. So in valga, increased neck shaft angle, GT is at a lower level. So this is a shortened abductor lever arm but increased abductor tension. Body weight and arm remains the same. So increased joint reaction forces during one leg stance. Because the abductor forces will be more. Same amount of force has to be created by the shorter arm, so forces are more. And higher muscular force is required to keep the pelvis horizontal. In a coxa vara, there is a GT is at a higher than normal and increased abductor lever arm. So this abductor lever arm is more. That is why the forces generated in the abductor musculature are less, and hence there is a decreased joint reaction force. But again, this is again we are calculating in only one plane. More factors are actually determined to know the actual load. So coming back to how much loading of the femoral head and acetabulum are happening, this is indicated in our routine practice by seeing something called a Sorsel sign on the acetabulum. If you see a dense bone which is equally distributed like this, there is an uniform loading happening into the acetabulum, normal weight bearing is happening. And in a valgus, more neck angle being more valgus, there is an edge loading happening a little. As the hip becomes more dysplastic, the loading of the acetabulum is only very little rather than being complete. So these are necessary things when you see a pelvis X-ray normally and try to calculate your angles, because even the center edge angle which was initially described was not described by the bony extent, but by the amount of sorsal which was present. Sorsal is a thick condensation of the bone. So you have to calculate at that particular angle the center edge angle. So that is how it is described here. So initially the sorsal is only so much, but the edge coverage is here. This is a dysplastic hip. If you measure the center edge angle with regard to only to the sorsal, this hip becomes dysplastic. But if you measure with regard to the bone, it becomes normal. But ideally, you have to see how much loading is happening, and that is how it is measured. Even the picture which I have taken from as a recent review article, they have mentioned that initially the center edge angle was measured by GANs with regard to the sorsal, not with the help of the total bony coverage. So looking into the finer details of your pelvis X-ray is more important than deciding immediately. So summary of essential: smaller changes in the lever arms makes a large difference in joint reaction forces. So try to make some adjustments there when you are doing it in preserving surgery or giving a walking aid or something like that. Human hip joint forces can be altered by various methods. A simple way to reduce this process are like trying to patient to lean over the affected hip. This is how the patient adjusts. You try to give by preventing the limb, by giving a cane and all, as I told you. And take home messages: understanding different parameters is important, because considering only the neck shaft angle is not essential. Assessing the cause and effect individually in each case is also very important. And considering and planning treatment, taking the whole patient into account, not considering only the hip joint. The patient may have some other deformities in the upper body, or he may have a scoliosis, or he may not be able to hold a aid because he might be a hemiplegic patient, or all those things you need to consider and plan accordingly, and don't take only the hip into account. Thank you.
Quite an excellent talk, Dr. Santosh. Thank you. Now I invite Dr. Srikanth to deliver his address on clinical and radiological assessments. We are progressing stage by stage. Thank you, sir. Come, Dr. Harish. Dr. Harish is also one of our faculty here. He is a pediatric orthopedic surgeon. Came all the way driving. What time you got up in the morning? 5:30. So 5:30. He's here. Hope drive was okay.
Yeah.
Warm welcome to you.
Thanks, everyone. Thanks for inviting me. It's a pleasure being here, the Orthopaedic Hospital and this hip preservation CME. And I'm here to learn as well as share my knowledge from all of you. Thank you.
Good morning, everyone. At the outset, let me first thank the organizing team and especially Dr. Praveen for inviting me. It's a great pleasure to I want to learn more from Professor Mahu sir, very keen. Yeah. Clinical and radiological assessment. Like on all in any clinical case, it starts with history. I'll try to keep everything as brief as possible. Usually the patient complains pain, usually in the groin or front of the thigh, anterior hip pain, the so-called C sign. If the patient complains at the back of the hip, it's usually seldom away, not from the joint and usually from the lumbar sacral spine. That is anterior hip pain or groin pain, posterior hip pain or buttock pain, lateral hip pain. These are the three areas the patient shows. Anterior hip pain, the causes what we should think of are arthritis, hip flexor strain, iliopsoas bursitis in labral tears. Lateral hip pain is usually because of greater contract bursitis, gluteus medius tear, iliotibial band syndrome usually in athletes, neuralgia parasitica, which is an entrapment of LFC and lateral femoral cutaneous nerve. The posterior hip pain, hip extensor pathology or external rotator pathology, and degenerative disc disease, spine stenosis problems also, they usually complain with the posterior aspect of the hip. And like previously also said, knee pain. Lot of pediatric patients is not at all uncommon for them to present with knee. And look, we all know we have missed a lot of these cases by taking knee X-rays. That happens because we fail to realize that the pathology in the hip. In pediatric population, there is a clinical maxim that knee pain equals hip pain. Even if we don't have doubt, it is cursorily mandatory to examine the hip. That is because of the referred pain nerve supply both the obturator and femoral nerve. Another common reason that is cited is Hilton's law. A nerve which passes over the joint sends the fibers to the hip joint per se. So the same femoral nerve which crosses the joint also has a terminal branch of blood supply to the terminal branch of supply to the middle aspect of the knee, thigh and knee. That is the reason. And after pain, the next predominant symptom is limp. And many cases, limp is the predominant symptom rather than the pain. Like again, the example of Pathis is the painless limp. Patient or child comes with limp. Limp is the predominant symptom. And limp actually can be a way of coping with the pain. If the patient is antalgic gait, he tries to take up the weight from the painful limp. That is the reason he is limping. You should observe how he is working and why he is working like that. And there is limb length disturbancy. When there is limb length disturbancy, obviously the patient will have walk with equal cadence. Equal cadence means equal time spent on both sides. But obvious limb length disturbancy because of the limb is because of the limb length discrepancy. And there is weak hip abductors or instability, like previously described. There will be instability in the hip or abductor mechanism might be weak. Snapping or clicking might be the clinical presentation. Not very common, but slipping of Gmax, gluteus maximus tendon back and forth over the edge of the pattern, or psoas bursitis, and very rarely detachment of the acetabular labrum. And stiffness or deformity. Patient comes with stiffness or deformity as a predominant complaint only in late stages. Only in late stages. That is one of the reasons is the neighboring joint compensates usually. Like I always give this example, when there is knee flexion deformity, the neighboring joint ankle will compensate by going into plantar flexion. Like that, if there is a hip deformity, that usually gets compensated by the exerted lumbar lordosis or flexibility in the neighboring joint. That is why deformity per se or stiffness are late presentation. Then functional activity. What part the patient is coming to you? What are his functional limitations? That is what we want to assess. After all, we are here to treat the patient and not the X-ray. So he may say like walking has come down, he is slow and tiresome, and there is difficulty in climbing stairs, difficulty in sitting down and standing up, and decrease the distance of walking. These are what the patient comes with. We have to understand what his complaints basically are. Then examination, like inspection, palpation, and movements. If we say the artery is classical, look, feel, move. First look, then examine, then feel, and lastly range of motion. We have to examine patient in upright position, sometimes in the sitting position, and mostly in the lying position. As the patient enters itself, you can see that how he is walking, his limb is working with aid or without aid, and how he is holding this working aid, and then is it a painful limb or a painless limb. With the patient upright, we have to see the obvious limb length discrepancy. Is the limb shorter? Is there any wasting of the muscles? Or is it short or lengthened? Usually shortening is there. And is the pelvis straight? Is the spine straight? These are the points which should run at the back of the mind while you are seeing the patient. Are there any scars, swelling or sinuses? And then a tender bursitis like previously described. Gait. Most importantly, usually these three is this short leg gait or antalgic gait or tender lunge. Short leg gait, as I already said, the patient spends equal time on both the legs, obviously bobbing up from one side to the other, but the cadence or the stride are equal. But in antalgic gait, it tries to take the limb weight away from the painful hip painful side, and he lunges towards the unaffected side. And like in a trend lunge, where, as you can see there, previously very well described in hip biomechanics, when the patient is standing on the normal limb, the abductor mechanism tries to keep the pelvis upright, not on the opposite side of the pelvis to fall down. But when he is standing on the affected hip, obviously, he has to lunge to the same side to bring to the bring the center of gravity towards the affected side, opposite to the anterior gate. Then waddling gait. I think this child is refusing to walk. Is a bilateral waddling gait is nothing but bilateral trend in the gait, commonly seen in bilateral DH, where body is placed from side to side. Some problem with the software application. Yeah. If at all there is any specific thing which we can see with the patient in sitting position, they say it is iliopsoas function, because in the sitting position, if you flex the hip and thigh and test, we are testing specifically iliopsoas, other hip flexors are relaxed in that position. Most importantly, patient is examined in lying down position. We have all been taught this attitude, apparent limb lengthening, bombarded as a postgraduate, and I don't want to go through all that again, but briefly, yes, we have to see how the patient is lying, how his attitude, like usually hip synovitis, patient will be, leg will be in flexion, abduction, external rotation. As we have seen in the first talk, the main reason being the ligaments in the capsule which are blended with the capsule give more room when the limb is in abduction, external rotation. That's a common cause. Patient will keep the limb in flexion, abduction, external rotation. And is the pelvis horizontal, is the pelvis squared, or both the ASS at the same level, or then we can think of any abduction or adduction deformity. Then limb length discrepancy and apparent lengthening and true lengthening. We all know apparent length is measured from the sternum and true length from the ASS. If possible, we have to measure from the head of the femur. Is not possible, so we take ASS as the landmark. And ROM and Thomas test. Yeah, Thomas test very well known from our PG days, like previously described. It is the neighboring joint which compensates. Right. We flex the opposite hip and obliterate the lumbar lordosis and reveal the fixed flexion deformity. Coming to the ROM, range of motion, the thigh should in a normal limb should be almost as the abdomen, 0 to 40 degrees. Extension 10 degrees, and extension usually measured on the lateral position. You can extend the hip and see. And abduction and interrotation. Abduction around 45 degrees, around 30 degrees of adduction, and interrotation. Interrotation is important to examine in both in hip flexion. And a better way to assess is by making the patient or child prone. You can make the patient like a dial test. You can examine the interrotation. Abduction, while measuring abduction, you have to stabilize the pelvis and abduct the hip, and we'll know whether the hip is moving, either a fixed deformity or not. A custodial way of examining is you can ask the child to move abduct both his legs. He'll be, if he is able to do comfortably without lurching to one or side, then it is abduction is normal. And we can ask him to just sit down, squat, and get up. Here you can see that he is having limitation in abduction, external rotation. And abduction should be measured both in extension and also in flexion. This is the frog-like position. And this is the so-called Drehman sign, classical case of slip capital femoral epiphysis. We know that the slip occurs at the femoral neck, and the epiphysis goes posteriorly, inferiorly. So the limb will be in abduction and external rotation. And when you try to flex the hip, the more you flex, it automatically goes into abduction and external rotation. So-called classical Drehman sign in slip capital femoral epiphysis. And shortening, very small pediatric age group. Best way to assess shortening is by flexing both hips and knees, so-called Alice test or Gedizi sign. You can even make the patient prone and compare both legs, whether the shortening is in the thigh segment or the leg segment. Then some important tests, log-roll test, the passive supination, also called Freiberg test. Usually any child usually described for piriformis syndrome or slip capital femoral epiphysis, because we cannot do internal rotation. But any hip, it is if it is painful or not, do a simple log-roll test. And Stinchfield test. Stinchfield test is nothing but SLR against resistance. Many physicians use this as to rule out any gross pathology in the hip, but it is usually tested for labral tear again and any deep hip pathology. And another is Faber test or Bacteria test, flexion of extension rotation with the knee on the contralateral, ankle on the contralateral leg, and give pressure on the knee. Usually for the SI joint pathologies and posterior hip pain and posterior lateral tears, this is sensitive. Also for deep hip pathology and arthritic pain, it is sensitive. Then Faber test, flexion, adduction, interrotation test or engagement test. Tomorrow I will talk a lot about FAI. And flex the hip to 90 degrees and need to maintain interrotation. FIR, FIR means interrotation in 90 degree of flexion. In every case we need to document this FIR because in femoroacetabular impingement this is where we exactly know whether pathology is in the anterior labral tears or not. Then radiography, AP view, most common view we know very well. But when it comes to lateral view, there are a lot of other views described like cross table lateral view, frog leg lateral view, duck view, false profile view, and this is more in relation to FAI, femoroacetabular impingement. AP view, the ideal AP view, both the pelvis should be symmetrical, and the distance, the sacrum, midline of the sacrum and midline of the symphysis pubis should be in one line. The obturator foramina should be identical. The ischial spine septal, they are visible. It may or may not be visible. They should be identical. And the distance from the pubic symphysis to the tip of the coccyx should be 3 centimeters. Though I am not depicted here, sometimes we get a view as if it is a pelvic inlet view. Patient has a fixed flexion deformity of the hip, and AP view appears to be an inlet view. That means in AP view itself we can say that he is having fixed flexion deformity of the hip. That's the importance of getting a true AP view. And it is not always easy to get true AP view because of some hip pathology. But if at all, this is the true description of AP view, where you can draw all the lines and be confident of your measurements. What to see? Look at the AP view. Our mind cannot see what your mind does not know, our eyes cannot see. So we need to have a structured thinking like what to see. First we can look at depth of the acetabulum. This is the ilioischial line or Kohler's line, and if the floor of the acetabulum it is medial to the Kohler's line, if it touches or it is medial to the Kohler's line, octa profunda. Or sometimes what happens, not just it is very deep that even the femoral head is touching the Kohler's line or medial to the Kohler's line. That is protrusio acetabulae, higher version of octa profunda. Acetabular inclination. How to measure the inclination? The first line we draw is the interteardrop line at the base of the teardrop. This is the teardrop here, interteardrop line. And the acetabulum inclination is this is Tony's angle of measurement, this is lateral central angle. While measuring Tony's angle, it is the, we just now heard this sourcil. Sourcil is the weight bearing dome of the acetabulum. From the inferiormost part of the sourcil to the lateralmost part of the sourcil, the angle which this line makes to the line perpendicular to the interteardrop line is the Tony's angle. Or a draw line from the center of the head to the vertical and center of the head to the lateral edge of the sourcil. That is called the lateral central edge angle or the central edge angle of Weber. Less than 25 is normal, Tony's angle 0 to 10 degrees is normal. Then acetabular version. The native acetabulum is anteverted. Sometimes it may be retroverted, but how to guess it on AP view is very difficult. But for a trained eye, it's easy. This is the posterior edge of the acetabulum. Posterior edge of the acetabulum or posterior wall, you can say. How to trace it? Go to the lateral edge of the acetabulum and see a thin line coming towards the ischial. That is the posterior edge of the posterior wall or posterior edge of the acetabulum. Anterior edge of the acetabulum, from the same line, which a faint line which comes towards the pubic symphysis or towards the pubic ramus is the anterior edge of the acetabulum. This is what is natural. In native acetabulum, posterior is behind and anterior is medial. But in a retroverted acetabulum, we see this crossover sign. When you trace those lines, there will be a crossover or figure of 8 at the proximal end. This is a sign of retroverted acetabulum on an AP view. and head sphericity. This is the same patient X-ray. Both hips look okay, but in lateral hip you can see there is femoral head offset. I have not depicted classical gun stock or pistol grip deformity that we will see in FAI. That is what to say, is the head spherical or not? If at all, then what is the head neck ratio? That we will assess like this. Is the hip in the center? That means what is the distance from the teardrop? That says that's a subtle sign that if there is hip effusion or if the hip is dysplastic, the hip may be slightly lateralized. More than 10 mm distance from the teardrop is said to be a lateralized femoral head. Femoral head neck offset ratio. We have to get a true lateral view like this or a lateral profile view like this, where alpha angle is usually described actually in MRIs, but if you can get a very good X-ray, it can be interpreted on a radiograph also. A line drawn from the in the center of the head and the neck center line, and the other point on the head where it loses its sphericity. If you trace the head, at some point it loses its sphericity. That angle is called the alpha angle. Another angle is head neck offset ratio. The ratio between head and tangent to the femoral head parallel to the long axis of neck and tangent to the anterior aspect of the neck again parallel to this line. This ratio distance is the head neck offset ratio. If it is less than 0.17, it is cam deformity is there. If this angle is more than 42, it is head neck offset deformity. And congruence. How is the hip congruent? You have to see the acetabular articular margins of the femoral head and acetabulum. Are they congruent or not? Sometimes there may be mild incongruency, and sometimes maybe it is grossly incongruent. That the femoral head shape itself is lost. Subtle collapse of the femoral head. That is incongruent hip. More than reading a normal X-ray by standard views or lines, sometimes we need to see that we need to know the disease per se, and if we keep on looking at radiographs, we can stay with just see the X-ray and we know this is Parkinson. That means what I want to say is we need to know the different stages of the disease. What are the classical radiological appearance of each hip? This example is it is in fragmentation stage, and after treatment there is healed. How a head X-ray looks like a healed Parkinson, and how it presents in a classical presentation. It's another example to show that the Partis is in this is a Partis hip. Here the radiology is collapse of the femoral epiphysis and sclerosis of the epiphysis. This is in the early stage, and fragmentation of the epiphysis. This is in the late stage or second stage. This is again just to give an example of the condition and the radiological typical radiological evidence which we should know. Slip coupled femoral epiphysis. Here the patient cannot even attempt to get a proper view because the head is slipped anteriorly and proximally, and relatively this epiphysis is slipped inferiorly and posteriorly. An example of slip capital femoral epiphysis. Then we should not forget the Shenton's line, very well described, but we don't follow. This is a classic Shenton's line, you know. And this is the break in Shenton's line is seen in dysplastic hip or any fracture. Subtle sign, though subtle, it is useful to pick up mild cases. Then let's look at DDH. We know the standard two lines called Hilger-Reger line and Perkins line. Just two lines divided into four quadrants. Initially we used to say up and out the hip is dislocated, but of late ISDA classification, International Hip Dysplasia Institute classification, where apart from the horizontal Hilger-Reger and vertical Perkins line, Hilger-Reger line is drawn from between the two trilateral cartilage, and Perkins line is drawn at the edge of the acetabulum. Another two small quadrants are created by doing a D line, which is the diagonal line in this quadrant, because we cannot see the femoral epiphysis in all the time. In very young immature children, we cannot see the femoral ossific nucleus. All we see is the metaphysis. So put a point in the midpoint of the metaphysis. If this metaphysis in grade 1 it falls medial to the Perkins line, in grade 4 it is up and out of the Perkins line and above the Hilger-Reger line. In 3 and 4 grades, the midpoint of the metaphysis is in this triangular area and up and out in this triangular area. This is the recent classification for DDH radiology. And orthography. In a pediatric hip, orthography is almost an extension of, we should say, clinical examination, where extension of clinical radiological examination. What do I say extension of clinical radiological examination? In radiology of the hip, we do not see the cartilage in a pediatric hip. All we see is only the ossific nucleus. This is how the heel is appeared, but intraoperatively, if you see this is the amount of the cam deformity he has. This we cannot see. If at all we want, we have to get an MRI to appreciate this picture, or otherwise we can just do a simple orthograph. MRI. Just to conclude and for the completion sake, is a MRI is useful for occult hip fractures and stress fractures. An MRI we know is essential and a must for if you are suspecting osteonecrosis or avascular necrosis of femoral head. Ultrasonography. If you suspect bursitis or any hip joint diffusion, I think we should first go for ultrasonography if you have a good radiologist, because it is much cheaper than an MRI, and you can even do a therapeutic. You can even aspirate the hip and send it for culture and look if it is just a synovitis, transient synovitis or infection or anything. And later, then you can go for MRI probably. I would place this earlier than MRI. Yeah. So to conclude, just a methodical clinical examination and approach is essential for diagnosing conditions, and we should never forget this part of examining the hip, especially in a child who comes with a vague knee pain. Then a systematic approach to the routine radiographic examination helps in diagnosing common hip conditions. Thank you very much. Thank you for your kind attention.
In Janaba gate,
Sir.
as well as in Delta gate, patient bends on the same side. In indulgent gait, as well as Tanama gait, patient bends on the same side. In Tanama gait, to prevent the fall of pelvis on the healthy side.
Yeah, got it.
And in Tanama gait, in indulgent gait, to bring center of gravity on the head of the femur, to decrease that horizontal limb, so that the pain is less. That is one of my points.
Probably what I wanted to say was the stance phase is decreased.
Yes,
Yeah.
stance phase is decreased.
Stance phase
Is
on the painful
decreased
phase is
in the
decreased.
indulgent gait. Steps are short.
Thank you.
That brings us to the end of the first session. I would invite the speakers to come over to the dais here and address the delegates if there are queries for them. I would request the attendees to quiz the faculty and learn from them about the basics that we have. Santosh? Srikant? Where is Akash? Huh? So let me kick the discussion. So for any human movement, stability and mobility are the two important things. Yes. So if we want to sacrifice anything, in some clinical scenario, want to sacrifice stability or sacrifice mobility, what do you think, what do you prefer to sacrifice? Of course, we want to have both stability and mobility together for an ideal scenario. If we want to sacrifice one at a stage, what do you think is the best way to?
In a younger individual, if he's a manual laborer, I would like to sacrifice his mobility a little bit, because it can be given by the spine as well as the pelvis to some extent in the hip joint. There are compensatory mechanisms which can work. And yes, and if he's like a patient which is a very low grade, non-manual laborer, doesn't have a chair to sit and sits at home, there is nothing, then something like I'll try to sacrifice his stability and give little stability, body will give it, and give him more mobility with something like a girdle stone or pelvic arthroplasty.
Sir, your views on that?
True, he is very nicely explained. For a lady, the mobility is more important. To be a children, to sit on the floor, for cleaning. And for a laborer, the stability is more important. So even in those people, we fuse the hip. So stability is, because of stability, we fuse the hip.
So even girdlestone has got a clinical role.
Yes, it will continue to have.
So even that also can be considered as hip preservation.
In arthroplasty, you do first do girdlestone.
Yeah, of course. Yeah, Harish.
Can I just add, sir?
Yeah.
So one aspect is their work and their vocation. Other thing is the age. The age also plays a very important role. Maybe in late, middle age, or you try to probably do arthroplasties and fusing the hip. I think that also has to be considered. So then there are multiple factors which we need to consider while deciding stability versus mobility. So in a younger child, as I said, you need to think of future replacement and give more years. If it's a very young patient, I just want to ask, in your experience, like if you fuse a hip in a very young patient, what will it have an effect on the spine? Will it have a long-term effect on the spine?
Yeah,
His mobility.
it will have long-term effect on spine, definitely. Secondary effects. So because a fused hip, you always shorten also, and for clearance, some flexion at the hip and some flexion at the knee is essential. So it is going to have secondary effects on the spine. Fusion, of course, these days,
Yeah, fusion has been sidelined completely.
completely.
With the advancement of so many technical sciences.
I have seen only my teachers
Yeah.
doing, and I might have done one or two, but not there.
Yeah, PSO. PSO has
Pelvic sport has taught me, Gishans has taught me, or American has taught me, all these has taught me are very important. And as you said, age, yes, age is very important. You do Shans has taught me for a poor patient when he is say 12, 15 or 20. Later on you can convert this angular osteotomy into a straight one to do arthroplasty. There are quite a number of articles these days. It's really difficult procedure also, because you first do angulation osteotomy, then you do a corrective osteotomy, and then you do arthroplasty.
Now, having done this conversion of an angulation to arthroplasty, what happened in angulation? We have completely changed the biomechanics of the hip.
Yes.
So arthroplasty is a near normal, bringing biomechanics to the hip. So is the stretching of the abductors and stretching of the other structures like sciatic nerve, vessels, will have a bearing in conversion of an PS4 to a. Probably we may have to do some more shortening and then get it back into hip arthroplasty. Looks like that.
Did you want to say something special for that in a fused hip?
No, I was just, especially because I was always worried, like in a fused hip in a very young patient, it will definitely have an impact on the lumbar spine, not pelvis. So that in the early degenerative changes.
Some lordosis will occur there and some tilt will
Because
occur.
all the stress will be transferred to the adjacent joint, that's the lumbar spine. So I'm not like, I don't have so much of experience in swallowing of a fused hip. So just asking your experience.
Second, what do you think the first clinical sign or symptom that we have to say that this patient has a hip disease? Hip disease, hip pathology. The basic understanding. What is the first important symptom or important sign the patient has a hip problem? Because what happens is, I have seen many patients who have undergone knee arthroscopy. Even I have seen a patient who has undergone the meniscectomy.
I would say it's limb, sir. I think it's limb. Because a lot of patients come with late stages of the disease because pain, it is subject. It is subject to the patient's threshold. Okay. So, but limb we can notice. That is why the parents telling that the child something is wrong with the child, he is limping. That I will take into more consideration than. Because child will be normal and even adults will be normal, but limp is noticed.
Cardiologist will guide you better. The hip may be diseased, but patient is asymptomatic. He will tell the parents he has something like or it is subluxating hip, or there is the the angle of Weber is not normal. So this is the radiologist who comes to our help.
But in the end, always he says correlate clinically.
But yes, you're right. He will always at the end, and pathologists also
Yeah.
correlate clinically. What specific in investigation you will advise to a patient with hip pathology, depending upon the age, other things? Yes, you do this now, or you ask for a specific investigations. X is not helpful.
X-ray is not good. I will said I will first go for ultrasound, sir.
Which conditions I'm talking to you? You try to think.
Yeah,
You do this.
it depends on the condition what we are suspecting.
Again, it is dysplasia. In childhood, you will ask for ultrasound examination.
Yeah.
To a fetus, you can ask for ultrasound examination. That is probably the best investigation for DDH, early diagnosis.
This is pertaining to Dr. Srikanth. You have nicely narrated everything regarding clinical radiological diagnosis. But this talk is pertaining to hip preservation. You would have talked about curve balls and more modified curve balls angles, which is more essential nowadays for hip preservation. Regarding the limp, you are telling for each condition, one particular symptom may be it is not pertaining to limp, is not pertaining to the hip pathology. Even a pinprick, a thorn prick in the heel, the patient may limp. It is not.
One thing we can't decide, we have to take it in.
Even a bad shoe. Bad slipper also makes it. Yeah, that's.
The question is to Dr. Santosh. You had nicely explained about the forces across the hip joint, and you said it is better to have a touchdown weight bearing when you are doing a fixation. So let us say I have fixed a comminuted trochanter, and most of the times conventionally we keep the patient non-weight bearing. So what is your take on that? Should we ask them to have a touchdown, or should we ask them to be totally non-weight bearing?
Sir, again, that comminuted trochanter most probably would have happened in a very elderly patient. And even as a junior surgeon, as a young budding surgeon, I was keeping them in bed basically, and from bed to chair only. But with experience of Dr. Vasiki sir being with me and Dr. Niranjan, who is also there with us, even we had a little good hold and we have a valgus fixation in we do more of PFM fixations. We don't do the plates or anything. So it being a better biomechanically stable implant, giving more valgus by fixing, we ask them to walk to chair, from bed to chair, as much as they can put the weight of that chair, as much as they're comfortable.
So you will better advise partial weight.
Partial weight bearing, sir. Definitely not will be not be possible because they can't hop with a walker. They're very elderly. Any 70-year-old person also can't hop. Sometimes we operate at 90-year-old. By the time the screws sink in or collapses, they will unite more often rather than having a failure in a PFA. That's what we have seen. And being a valgus fixation, it is more advisable to have a valgus because the moment you bear the weight, it will not cut out or anything, it will collapse basically a little.
One more thing, my observation regarding valgus fixation is valgus fixation, late presentation of segmental collapse. Even after the removal of the implant also collapse. Not after 2 years. It may be delayed 5-6 years. Yes, superior lateral fragment is there is a collapse, which has not caused much problem to the patient, but a little
yes.
discomfort.
That's right. Valgus fixation leads to collapse. Varus fixation leads to hernia. It's simple. On that side, you want to say something?
No, one thing I want to say is about, I'm a big proponent of your pelvic support osteotomies. Now, a lot of young patients say, I'm having to limp. You're given sufficient stability. So what I would suggest is, do your pelvic support osteotomy. Don't use that limp part as an excuse for doing an orthoplasty. So lengthen the tibia. You use an Elizera and lengthen tibia because lengthening femur has a lot of problems. So we have done a lot of cases where you do the pelvic support, let the guy walk, stabilize, and then lengthen the tibia.
Okay.
So his limp is gone, he is comfortable, cosmetically it's fine, you give him stability. So that is my take on that.
What about
And even the spine problem you mentioned, sir, That also is partly taken care of.
No, that's right. What you said is the knee, one knee is being down. That should not be a problem.
It's better go for the other side. I mean,
Pediatrics.
Yeah, skeletal immature we can wait for some time, and once it gets close to maturity, you do a lengthening which is much easier. You get a very good region rate and the tibia lengthens.
you don't have any problems with the unequal knee length.
That's the one thing you have to counsel the patient. That's only seen when he's sitting or something.
Yeah.
See, at the most you are getting an inch and a half shortening. That inch and a half you mentioned, and the limp is almost gone. So we found very good results with that.
That's right. Thank you, sir. So another last thing that I want to.
Sir, I have one.
Yeah, sure. Go ahead.
Sir, one question regarding the biomechanics. One thing I learned from your talk is the anteversion is to balance the center of weight at the S2. So can we explain the same? At birth it's 40 degrees. Yes. Now it comes to 15 to 12 degrees. How can we explain that?
See, that's again because the patient is not bearing weight at that time, and stability of the posterior muscles are more important. So you try to get it more posteriorly, and so that they are still crawling in the front. As they strengthen their muscles, it gets adjusted. The muscular imbalance also is important when the child grows, and that is how the biomechanics of hip is initially, as you say, when child starts walking broad-based gait. This is because again the muscular forces are not there. It starts to balance basically on your skeleton, and then the able to walk straight and all. The hip adjusts and the muscles adjust accordingly.
So what is the anteversion in others apart from human beings?
See, in the quadrupeds and all, sometimes you have a completely retroverted femur, actually, not even anteverted. If you see the quadruped, the big runners like the cats, all those, they are almost retroverted, so that they have more stability. They have more stability, and their hamstrings are the gravity muscles. Quadriceps are not almost nothing there. That is why you have the flexed attitude in the knee joint also. Yeah, extremely.
What's the main arthritic? Instead is
It is the opposite side. We discussed that. Thanks, Satish.
So of course the structure and is also very important. Osteoporosis plays a great role in hip preservation. Even though he is a young patient, for example, an ankylosing spondylitis, okay, having a fair degree of hip motions. So we may not prefer the hip preservation. Probably we go into a salvage procedure. So what is your take or home message on this osteoporosis, and is there any cutoff age that we can recommend that this is a hip preservation thing like that? We can't do hip preservation in a 60-year-old, even though with a strong bone.
I think just more than age, we have to see his physiological age.
So the functionality, whatever it depends. It may basically, what is this? I was just discussing with Akash also. Nowadays the concepts are changing. Initially the reverse shoulder arthroplasty, they were telling do it after 65 years only because there is nothing else after that if it fails. But few doctors who are especially around the Western world, they are saying if you have an irreparable tear at 50 years and your tendon transfers are not working, he is in his productive life. The next 10 years are productive for him. Give him a good stable shoulder, a reverse shoulder. Similarly, in this scenarios also, depending upon each patient's demands, if he is an young person, even osteoporotic, he is having this, you can go and do rather than preservation and trying to have a long morbidity, you can do a plastic because his overall survival also we don't know. Whatever is surviving, we can achieve and give him a better functional outcome during this time. That is what I feel sometimes.
So I think that was a wonderful discussion. So now let's go on to the second session. Yeah. Where is Sir? Dr. Malu. So today we have a live demonstration of valgus osteotomy. Okay. Maybe after the inaugural program, we'll assemble in the operation room. Live thing will be streamed over there. So I think you all should be prepared, well prepared with the questions and things like that to take the maximum out of this. I think Professor Magu is on phone. Let him come for a while. So you also relax.
there was a call from Australia.
No problem, no problem. Take your time. Sir, hands. Planning. Okay. Discussion. Yeah. Planning. First year. Are we ready, sir? Right on.
Am I audible? No, it's okay. See, actually, not much planning is required as far as fracture neck of femur is concerned. All of us know what is power angle. All of us know what is forces are, resultant of body weight forces, and how to convert the shearing forces into compression forces. But little bit of planning we must know, and we must play on tracings because that gives you a dynamic sense. You should have a quality X-ray always. Knowledge of implants. Pediatric surgeons use pediatric plates these days. Earlier there were plates even for small children. Surgical tactic we all must be aware for any surgical procedure, and intensifier is very essential. 3 types of blade pits are there because this is the best implant. It's a bone preserving implant. You can use DHS also. With DHS you remove bone. That destroys bone. So 110, 120, 130 degree blade. Each implant has 65, 75, 85 blade length. So this is the blade length. This is plate, always 4 hole. And this is the elbow. Most common, we use 120 degree double angle blade plates, most commonly. And that is the best implant. Easy to use. Most commonly, blade length used is 75 for ladies and 85 for males. You can also use a chondroblade plate as you get more of experience. DHS is easy to use. Double angle I have innovated. I call it Manny's barrel plates. You can use 1/3 plate because you can contour it to 120 degrees. So that is what is published in Campbell. This article is published with full technique in Campbell Operative Orthopaedics by Magu et al. You can use 3.5 DCP also. With this 2/3 plate, you have to use spica. So in children we can use it. Sorry. Can you put it off? Yeah. Sorry. So this is the chisel. Can somebody ask that fellow Naveen Joshi to bring few tools, plate holding forceps, chisel, the templates, and this slotted hammer, plate holding for forceps. So same tools with slotted hammer, you all must be aware. Plate holding forceps. This is the chisel, very important. It is U profile. It has got a U profile here, and these are the templates. You can use osteotome, a sharp osteotome also if you don't have this. Tracing good quality X-rays. And you should learn to reduce the tracing of these two fragments within the contour of the normal hip. So always get the X as a normal hip. So that is the tracing of the proximal femur, this is the distal femur. Draw the power angle and always draw the power angle from the distal fragment, fracture line with hip in internal rotation, otherwise the angle will change. So here the power angle is 45 and you convert it to 25 so that it is at right angle to the resultant body weight forces. These are the forces R. It should be horizontal. So convert 45 to 25. So at size of edge of 20 degrees. That is the normal hip. And measure the length with the templates. These are available with the preoperative planner which you people have. They gave me complimentary about 30 years back. So here, from the normal side, we can say the blade length used is 65. The blade should be seated in the inferior quadrant of the head of the femur. That is the strongest part. You can seat it here also. You see the blade length is 65 blades. With experience you will learn. I did 75, I did 65. So this patient was a child, my first patient, of non-human neck of femur, 9, 10 years old. She is living today, and I have 33 years follow-up with lady. So 65 is the blade length, and since we are excising a wedge of 20 degree, the plate must form an angle of 20 degree with the shaft of the femur. Otherwise there will be error. So this is how you have to play your design, your trick, place your instruments. That when you, after osteotomy, abduct the distal fragment, it lies against the plate. Or the plate lies against the longitudinal axis of the femur. Discrepancy will lead to discrepancy, mal-displacement, and your procedure will fail. So if it is say 30 degrees, then you will not be able to approximate the plate to the femur, and this implant will cut through above. So that is very important. The plate must form an angle with the femur equal to the size of the blade or the wedge you have defined. So this is 20, again this is 20. So this is the distal fragment which is cut, and you align it against this plate which is 20 degrees already, it is this, and when you bring it into neutral position, so this was the longitudinal axis, now this is the axis of femur. So this should also make an angle of 20 degrees. When you bring it neutral position, this becomes at 25 degrees. See here. So this 45 degrees is converted to 25 degrees. And this axis and this axis, this is the new axis of the anatomical axis of the femur now. So you have done the vulgarization of the proximal femur. You have placed the fracture line at right angle to the body weight forces R. You have converted varus into valgus. You have corrected the shearing forces into no compression forces. And that is what is the power angle based on biomechanics. Now I say it is not only a biomechanical principle, it is a biological too. New bone is formed. The bone is formed along the track which you have made it. The bone, the mesenchymal cells start reversing along the calcar or along the axis of the femur to lay down bone to cause healing. And in various conditions I have seen it's a biological. Other trick which you have to always define, does this plate, say 120 degree, has a supplementary angle? So for a 120 degree plate, this is not difficult, just concentrate. 60 degree is the rest of the angle. It's called supplementary angle. And whatever wedge of bone you have decided, say 10 degree, 20 degree, 30 degree, you add to this so that the plate ultimately rests against the shaft of the femur. So here it is 20 degree, so supplementary angle is 80 degree. So this 80 degree, this flap must make an angle of 80 degree with the rest of the chisel, because this is the addition to the plate angle. The plate has 60 degree supplementary angle, and after correction it should be 80 degree totally with the rest of the chisel. This must make an angle of 80 degree if you want to excise a wedge of 20 degree. This must make an angle of 90 degree if you want to excise a wedge of 30 degree. And it must make an angle of 70 degree if you want to excise a wedge of 10 degree. And this has to be parallel to the shaft of the femur when you do your procedure. See this. So this is the 60 degree angle of the plate, supplementary angle. This is the flap, we want to excise a wedge of 20 degrees, so this is 80 degree. This is 20 degree which is forming with the shaft of the femur. So the whole angle is 80 degree. So this rest of the chisel, this flap must make an angle of 80 degree, and then it will be parallel to the shaft. So this is parallel to the shaft axis. Once it makes an angle of 80 degree, this is parallel to the shaft axis, and ultimately the plate will rest against the shaft of femur. So no error, no error. So patient on conventional table. You can ask me a question now, so that things are clear. You consider it as part of workshop. In this Bangalore, the medical college Bangalore, they have a cadaveric laboratory. Where we did a workshop on tracing papers and all that. Yeah, please. Dr. Harish, please, your question?
No, you are talking about 120 plate. Sometimes we don't have 120, we have 110, or maybe we have 130.
Yeah.
Of that length.
Yeah.
So
for a 170 degree, 130 degree plate, the supplementary angle is 50. So at 20 to 50. So your flap must make an angle of 50 plus 20, 70 degrees. Yeah. If you have plate of 110 degree, the supplementary angle is 70 degrees. Because 80 minus 110 is 110 into 70 degree supplement. So add this angle of wedge to 70 degrees.
This always was a confusion. You cleared my thoughts.
You will never add. Here you add.
You are very
People
simplified.
put so many plates. Put one plate, oh yeah, fit nahi ho raha. Put second plate, oh yeah, ye bhi fit nahi ho raha. And they forcibly try to fit the plate and the femur, and the implant cuts through. Or it is medialized or lateralized. That's again a problem. If the angle between the plate and femur is more, then you define wedge. And if you want to put it, so either it will cut through from above, or this fragment will be medialized. It will come to lie under the head of the femur. You say, यार ये क्या हो गया? ये तो मैंने सोचा नहीं था.
Sometimes in intraoperative what we calculate say 65 or maybe 75.
5 degree doesn't
No,
matter.
what happens is the blade length, what we calculated, might be long.
That is why you make tracing.
Yeah, no, for some reason, sir. And we don't have that length plate. You already made the angle for a 120 angle plate. So, and for a shorter plate, you don't have the same 120.
Shorter blade.
Yeah, shorter blade.
Yeah.
You don't have the same angle plate. How do you do the adjustments? Like suppose
See,
you
angle
calculated for
will
165.
be the same, 110, 120, 130. You have already seen a day before. You do this planning a day before, unless you are experienced.
Yes, sir.
If for that matter say your blade length is short, I'm talking of blade length.
Yeah, blade length.
Rest of everything is okay.
Yes.
You find it's an unstable situation. So you push the blade inside, more. In small head, what I do, I take the tip of the blade up to the subchondral level. Your head is very small, so you need better stability. If head size is very good, it's okay. You will give him early weight bearing also. If proximal fragment is very small and you want to do a short and to preserve the hip, stability is very important. So push the blade. In other words, push the blade slightly inside, so that blade tip reaches here. But then this will be slightly medial. Blade will push the head, the femur slightly medial. So there will be medialization of the construct. And if your blade length is more, say it comes here, it will lateralize the fragment. So lateralize is good. We should preferably lateralize it. Am I clear to you?
So is there any minimum length for the subchondral bone?
10 millimeter.
10 millimeters.
10
usual.
This should be 10 millimeter, 1 centimeter short.
So pushing it inside, pushing the plate inside, as you said, what should be the minimum? At least 5 mm minimum, or we can go up to the subchondral bone, sir?
That depends upon a particular case. You are in trouble sometimes.
That's what.
One is that you give additional stability from a screw from above. Additional stability from a screw from above. It should be longer one. You can also put a screw below also. Yeah.
Thank you, Professor. Just to ask a few questions. One is, what is the advantage of double angle over single angle?
Yes, you can do a single also, but it is easy to insert.
Yeah.
Single angle is difficult to insert. And mostly the single angle implants are available in 135 and 130. Of the various blade double angle, 120 is best, easy to insert. It is easy to insert from here. A 130, it will slightly oblique. It's for the ease of surgeon. You can use other implants.
Otherwise, we can use it interchangeably. Both.
You can use 130 also. But lateralization, for lateralization, you have to keep the blade out. Here it is easy. Here it is easy because of the double angle.
In the other, some surgeons, in addition to doing osteotomy alone, they use also fibular strut graft.
Yeah, that is it.
Fibular strut graft.
Fibular strut graft is other biological procedure.
Yeah.
There is, you don't do a strut, you just make a track and put the fibula inside. That is another biological procedure. So many biological procedures are there. Okay?
So instead of additional screw, would you use a fibula, sir?
You can put a fibula also, yes. But in a osteotomy, I generally don't put fibula. Unless it is a redo surgery, failed osteosynthesis, or very osteoporotic, or there is a track already made for the sake of stability. And of course, it is considered biological one also. Additionally, At times I put fibula in these conditions I have mentioned. Failed osteosynthesis or osteoporotic fractures.
Basically for bone support.
Bone support.
Basically for bone support.
For stability.
Sir, if you put in fibular strut, would you put the blade above or below? Because
blade is below.
I mean, the fibular strut will be
blade is here.
Here. Fibular strut will be above the blade.
Yes.
Because fibular strut also is fairly big in size, so to get it into the neck is
you use half
the
make drill holes so that keeping substitution is good. Whole fibula is not good. Half. Can I have water? So supine conventional table. We will use fracture table also for sake of easy. Watson Jones approach. 3 osteotomies. So we'll talk of 3 osteotomies here. V, Y, extended Y. This is V. It's making V. This is Y. Proximal, distal, making Y. Y length. This is extended Y. Going further ahead. Here you see, it's going up to here and it has me buttress the proximal fragment. When the proximal fragment is short, subcapital, I make extended Y. Vargazation as well as buttressing from below. Again for want of stability. Very small head. This lady had eclampsia, 21 years old, Artemis Hospital, Delhi. They said we'll do THR. We rushed to Rohtak and she came to me and I did Y osteotomy. So this is Y. This is the picture. This is Y. One osteotomy and going into this. So it is buttressing from below. See how beautiful is the union. 21.
So we got something like an armchair effect.
Yes.
McMurray.
Yes, both valgus as well as armchair effect. So that will be the Y or extended Y osteotomy. So this is 5 months. But this girl underwent avascular necrosis later and we did a THR. But I am telling you the advantages. Every case will not undergo AVN. So I will show you how AVN is also, in spite of AVN paper, have good function. So this explains you the vascularity, there is a posterior aspect. This is the bone model divided into 3 parts. And here 1/3, middle 1/3, and posterior 1/3. Always make the slot of this U profile of the blade at the junction of anterior third and middle third. Don't go posteriorly because posterior are the vessels. So iatrogenic AVN will occur. Again, I am defining the same again. So about 5 centimeter in cm. This is published in CORR 2009. Facial attack, vastus latalis muscle. Put a guide wire. You can put 2 guide wires. Where when you pass the screw, it fails to rotate. So that is the head of the. This is the window for the chisel, and this is the screw to give temporary fixation to the head of the femur, so that this doesn't wobble, or you can keep it there again. So entry point of the chisel, and here is the screw. So that has given you fixation, and here is the tubercle. Most common it is the trochanteric tubercle. That is the entry point. And now you give an incision along the vastus latalis, make a sleeve on posterior 1/3, slotted hammer so that the plate doesn't get rotation. goes anteriorly or posteriorly. In 3 axes, you can maintain this relationship, and the blade should be parallel to the femur. So this is the flap I was talking about. This angle is supplementary angle, and that is the angle which you have defined. So this should be parallel to the femur. This flap should be parallel to the femur. After you have defined the angles, do the fixation of this flap on the femur. When you are making a track into the head of the femur, keep it parallel, and image you can see. So image has made it easy. So you see here, check both views, lateral view as well as AP view, because this can be anteriorly or this can be posteriorly. This is lateral view. Frog-leg view, very simple. Just flex, abduct, externally rotate. So your assistant will help you. Patient will conventional table. Easy on fracture table also, but then you have to have your image accordingly. Adjust first. That reduces the number of assistants also on fracture table. But all osteotomies cannot be done on fracture table. I generally use fracture table when I want to remove the sinews, broken sinews. The position should not change. I will show you the case. So this is frog-leg view. So on the pictures, this is vastus latalis muscle. That is the posterior 1/3. If you are in the plane, there is no bleeding. Bleeding is only at the time of osteotomy. You take it for some time with your sponge. See, all these are my slides. I have not taken from internet or something. You will not get also on internet. But there is hardly bleeding because I am doing an avascular zone. This slip, which is 1/3 posterior vastus latalis, go up to periosteum. Don't cut the periosteum. There is no bleeding. This is periosteum elevator. I am preserving the periosteum to preserve the vascularity of the femur bone. And this is the saw. Now there is some bleeding. Saw vibrates. So I put a sponge. Or you take a sharp osteotome, there is hardly bleeding because osteotome that blocks the vessels, the veins. Osteotome vibrates, so it opens the vessels. So there is bleeding. So that is the saw, that's the proximal fragment. So you keep this distance 1.5 centimeter from the entry of the blade to the first osteotomy. There should be stalk of bone measuring about 1.5 centimeter, depending upon the elbow of the blade. See here, this is 1.5 centimeter, because elbow is of 15 millimeter length. Now, has he got the implants? No. So this is the blade, this is the chisel, vastus latalis, periosteum intact. So that is the proximal fragment. That can go up to here. Probably that is this. This is the proximal, that is the, no, that is not the distal one. So again defining the same angle, 30, 30. So this is 30 also again. It becomes Y osteotomy. You see here, one limb and the second limb, Y osteotomy. So this is 30, this is also 30. I'm repeating so many times so that you don't forget. And I do wish that each one of you is able to perform the osteotomy. Not difficult one. Work with an experienced person first. This is the saw. So if you find that the wedge is less, so you can excise more. So start with the lesser wedge. Correct the rotation and malalignment because the limb is in external rotation because of the formation of the fracture. Now that is what we have done. So angle you see here, approximate the femur to the plate and start your screws from 1, 2, 3 and 4 so that the osteotomy is compressed. That is the slotted hammer issue. So you can keep it like this, prevent the rotation. So this can maintain the axis. So a plate holder, it has two jobs, can hold the plate. It is also hue profile. This is the flap to the chisel. Hold it, get in there. This is the chisel, has a hue profile. This too has a U profile. So now they have made a small one on my advice. Because if it is large, then you have to have a bigger room. So you can, in this profile, so this is the one. So let us say you want to excite, this is the supplementary angle now. This is the true angle. So if blade is of 130 degree, this will be 70 degree. If you want to excise a wedge of 30 degree and plate is 120 degrees, see, this is plate. This is 120 degree. This is the, with my finger supplementary angle. So add 60, 30 to 60. So that this is 90. So flap should be at 90. And as it is inserted further, so this is the femur. So now it should make an angle of 30 degree. So as you close it, there will be approximation between the plate and the bone, and wedge will close. That is very important. That is what I am showing here. This is 20 degree. Wedge is 20 degree. As it is closed, so this is also closed. So pass the screws from distal to proximal side. It will close and get compressed. So compression forces are better for stability. So screws are from distal to this side. Now if you insert the first screw here, so the plate will come laterally. Femur will come laterally. That will cause lateralization, and that is also good. So when you lateralize or you lengthen the neck, so you pass first screw from above. Normally you pass from distal to proximal side. This is a good plate with good hue profile. I am seeing they have improved their chisel also. This chisel is also excellent. Their metal is good. It will not fail you. But okay. These are the various templates. 95. This is 90, 90, 70, 110. एक और भी होगा. So it is 90, 50, 40 triangles. Most commonly use 20 degree. So I generally excise a wedge of 20 degree or 30 degree. Most commonly of 20 degree. No planning is required. This is also 20, 70, 80. So depending upon what you want to do, these templates will help you in placing the chisel and the flap. So here you find it is completely neutralized. Axis per axis, both sides. Now this, when you want to lateralize, lengthen the length, you keep the plate out, plate out. So here you put a wedge of bone as you find here. So this neck is very small. This much neck was there only, so I have lengthened it. I will show you the case also. So this is lateralization. Femur is cut, pass first screw, and this all is lateralized. This is lateralized. You see, femur is cut from here to here. Put a bone here. So neck is lengthened from this place to this place. This is medialized. You put the plate with a higher angle, but exercise a lesser degree of edge. So whole of the femur is medialized. The lesser trochanter is just abutting or close to ischial tuberosity. It is not so. It is not so here. It is not so here. You see, it is lateralized. See, this is lateralized. Ischial tuberosity is far away from here. And here, so this patient will have length because the muscular arm is shortened. The lesser, this tip of trochanter should be at the level of the center of the head of the femur. For THR also you do the same thing. So this patient will have length. Walk like this, same side. It is, all of it medialized. So axis, normal axis should have been here. You can lengthen. Valgus rhodomy lengthens the limb. See here. This is the top of trochanter, center of head. So this much is the shortening. When you do vulgarization, so this is now B. So A plus B is the length again. This has come at the level of the center, slightly higher bottom. So limb is lengthened in spite of a removal of the bone. Venous causes shortening and valgus causes lengthening. Lower, here I have not divided the capsule. Capsule is not divided. And it will heal. You can do with DHS also, same thing, same procedure. For a learner, with DHS is easy because you pass a guide wire and over it you can drain and put your screw. See? See? Now, instead of putting a blade, I have put a barrel plate, double angle. So, you can revise it. I think I'll take more time. Remove the screws. I'm removing the screws. This plate had failed. Implant is out. This is the implant is taken out. This is being taken out. This is taken out. And I have put two screws here now. After all the implants are removed. And you see here, initially the plate is cut through entirely. I have only taken the chisel and this track I have laid posteriorly here. You see, this is the posterior track. And the posterior track I have inserted the blade. That is what I have done only. Not cut the capsule. Only taken out the plate and screws. And the same plate after sterilization, if it is happened just after a week, or a new implant, I have only made a track posteriorly with same angles. Now it was unstable, so it cut through, and it is stable one now. See, this has gone now posteriorly. From here it has gone posteriorly, and it has healed. 154 weeks. He is a teacher, and see the function. You cannot get such functions with arthroplasty. There is a bias about osteotomy. In all those people, industry, who want to make money, coming with the name of technology, I should be graceful to them and not say that you are looting our country and our third world countries. Cheating the people. If you want to advertise arthroplasty, show the cases of osteotomies also. Even if badly done osteotomy will give you good function. It's very simple procedure. Technology itself has made it more simple. Not against, we don't have any bias against arthroplasty. Must do, but one absolutely indicated. Because there is no savior after it fails. Osteotomy preserves bone, osteotomy creates bone. THR destroys bone till it becomes very loose. Again take grafts, do the revision, it again will loosen, now it will go for 10 years, 8 years, 12 years. Third revision, there is no bone at all. So no savior. Osteotomy, even if you do third time, it will create more bone. It will invite more medial and garment tissues to create vascularization. Thank you very much. ये दिखाना bone. I mean, I just show you those things. So this is the bone. Do you have a marker? Anybody have a marker? Any sign pen or something like that? So, this is the trochanteric tubercle. And at the trochanteric tubercle, you divide it into 3 parts. So this is a straight line. So here is the junction of middle third and anterior third. Because posterior there are vessels. So stay in the anterior 1/3 and middle 1/3 junction and create, within osteotome, create a track. And give me the chisel. You have already defined it, ये भी दे दो यार, ये भी दे दो. So, see this. This flap should be parallel. This flap should be parallel. Plate है ना? And you see here, the plate is making an angle of 30 degrees with the femur, as per your definition. So when the blade rests here, wedge is excised and you abduct it, the plate is against the femur. No error. And when you insert the chisel, give me slotted hammer. Hold it here. Slotted hammer, and when plate is there, ये जो आएगी ना, तो ये आपका like this, you hold it, so that it is बहुत chisel लगाओ, chisel. ये ऐसे कैसे किया? ये जो जाएगा ना, तो ऐसे. You can hold it like this. It will be parallel to this. Yeah. Yeah, patient lines fine. So you can plate parallel to the shaft of the femur with the help of this slotted hammer. Plate will come to lie anteriorly like this. It will come to lie posteriorly also. We want it parallel and against the femur in the corner as a sagittal plane. So slotted hammer is a good advantage. So we should have hands on bone motors also tomorrow. Thank you.
Good afternoon all. I invite our Executive Director, Sister Annie Feather, to come onto the dais. Now I invite Dr. Xavier Manvens, who is orthopedic surgeon by himself, and he is the Spanish qualified team coordinator. Now I invite Dr. Professor Maghu sir to come onto the dais. I invite Dr. Vaspi sir to come on to the dais. I invite Dr. Praveen sir to come on to the dais. The lamp lighting will be done by the dignitaries and the faculty. Can you please come in?
Sir. Biggest organizations in ప్రొజెక్ట్ అట్లే ఉండాలా ఆపింది అదే చెప్పమంటారు ఫేస్ మీద పడుతుంది
Thank you all dignitaries and faculty. I request Dr. Praveen sir, who is our director of this RDT hospital, to welcome dignitaries.
Good morning to one and all. Probably this is a proud moment for all of us. From the Department of Orthopaedics RDT Hospital, I proudly welcome you all for this RDT Orthopedic Surgery Education program. And this is a such program of sixth sequence. And this has been possible only with the support of our Honorable Executive Director, Sister Antifaran, who is a great person in the organization, and she is the great pillar in developing and shaping this organization for the past 52 years. I welcome you, sister, for this program. Professor N.K. Magoo, a well-known academician, teacher, innovator, and pioneer in the field of orthopedics, surgery. And dear sir, on behalf of our RDT hospital, I welcome you for this CME. And Dr. Xavier Manabens, who is a coordinator for the Spanish voluntary orthopedic team, has been working with us since 20 years. He is a great support to the department and building the department. I welcome you, sir, for this evening. And Dr. Vasaki, senior orthopedic surgeon, who has been with us since 2016. Every month travels 900 kilometers to come here to help us. And a great support to the department. I welcome you, sir, for this CME. And I welcome all the faculty members, Dr. Srikanth from Nizam Institute of Hyderabad, and Dr. Akash from Mysore, and Dr. Santosh from Bangalore Baptist Hospital, and Dr. Harish from Bellary Hospital, who have travelled their distances to share their knowledge amongst us. Please, if you come forward now, we will welcome you with a bouquet. Dr. Srikanth. Dr. Akash from Mysore. And Dr. Santosh from Bangalore Baptist Hospital. And Dr. Harish from Bellary. And I also warmly welcome the attendees who has travelled so far, and I am very happy it is a mixture of great professors, orthopedic surgeons, and postgraduates. And my sincere welcome to, we have one more orthopedic surgeon from Spain. He is Dr. Jose Resines. And I also welcome our hospital head of the departments, and my sincere welcome to Mr. Naveen Joshi, who is from Delhi, Kaushik Surgicals, who has helped us in the ortho workshop. And I extend my warm welcome to media people, chiefs of clinical departments, administrative staff, and a special mention to Dr. Ashok Shah, who is live streaming the event in Ortho TV. And a warm and heartiest welcome to all of you. Thank you.
Thank you, sir. Now I request Professor Maghu sir to say a few words about our CME and to address the crowd.
Thank you, Sister Dr. Veen, Xavier, Vasuki, and my faculty, Akash, Chandrakant, Santosh, and Harish from Belgium. Very nice meeting you. I was told that this hospital is in a rural area and people are keen to learn hip preservation procedures. And I said, yes, I'll come immediately. I'm very glad to come here that this hospital is serving the poor people with a zeal and with a mission. Very clean place. And I'm also determined that this CME in workshop is successful and everybody learns osteotomies and other procedures, particularly in the ABN and non-hernias. And thank you very much. I'm grateful to you for your kind invitation. And I wish all good to you and to this institution. Thank you.
Thank you, sir. Now I invite Dr. Xavier Manvins to share his thoughts.
Okay, well, I'm very happy to stay here, and emotion is very important. Well, after 23 years, today I see a hip preservation is good, because every day we are working in advance, creating a new projects. I think it's too important, the hip preservation, the mind, the heart, and all together we can change day by day a little bit this world. Thank you for all your assistance. I'm absolutely happy to stay here again with you and to work with you. Praveen, thank you. Akbar, thank you, sister. Thank you, Vasuki, everybody.
Thank you, sir. Now we'll felicitate our faculty. Sister Annie Ferrer will felicitate Dr. Maghu with a memento.
I should felicitate her first.
Yes, sir. Thank you, sister. Dr. Vaski sir will felicitate Dr. Harish. Now Dr. Praveen sir will felicitate Dr. Akash. Now Dr. Xavier sir will felicitate Dr. Srikanth. Now I'll felicitate Dr. Santosh. Now, vote of thanks will be given by Sister Annie Ferrer will speak a few words about our CME.
Good morning, dear friends. Yesterday I was thinking about this CMA, which is a continued medical education, right? That's the meaning. And I was thinking in my 53 years here, how important education, continuous education, continuous awareness giving, continuous transfer of knowledge has been so important across these 53 years. Yes, even when I thought, okay, we've done a lot of work in health, in education, in housing, in ecology with persons with disability, even when I think of, yeah, you can't live in a hut, you have to live in a house, no? And you must have access to health and education. But if you don't have knowledge, if we don't have knowledge, if we don't have awareness, how do we live? Somebody in the village told me the other day, said, I can only fight for my rights if I know what they are. Yeah? And I think that I felt when thinking about this workshop yesterday that all the awareness across the 50 years on health, on education, on the laws that protect us in the country, on the environment, about drought, about agriculture, all this awareness and imparting of knowledge and continuous education is as important as the work itself. Just going around there, building a house, coming away, doing, no. This is really, really for me a very, very important part of our work in general and our work in development in particular. I've always considered it, and I think people themselves consider it really, really important. So therefore, I'm always happy to come to our continued medical education workshops that we hold in the different departments from time to time. I'm very happy to welcome you all here. I thought another point also that really makes these continued medical education workshops so important. You know, when patients come to our hospitals, they come from faraway villages, they're short of money, they have scarce, less transport, and they will arrive in the OP and say, you solved my problem. Never mind what it is, you have to solve it, because I cannot go to Bangalore, I cannot go to Hyderabad, I cannot go anywhere. Even that, though that may not be advisable sometimes, it is the reality of the people who live in the interior areas, no? That when they land up in a hospital, they want to get the solution there. And therefore, these continued medical education workshops become so important that in the hospital where you are, in the rural area where you are more and more and more able to give that solution to the patient. And just last, I would like to repeat the very few words that Dr. Javier Manuben said, but he said two very important things there which I always say in my experience also. Where do we find the best person to work anywhere, be you a doctor, be you in development, be you anywhere working, a nurse, anywhere. You combine the mind and you combine the heart and you work together, you have the best person. So thank you to all of you very much. What is very important to us, and I am really personally very grateful for, is professionals like many of you who come to the rural areas where we need your support, we need your knowledge, and we need your help so that we can better serve people in the rural areas. So this collaboration is also very important to us, and wish you all best of luck in this workshop today, tomorrow, and hope you learn what you want to learn and enjoy at the same time. Thank you.
Thank you so much. Now I invite Vaski sir to give a vote of thanks.
Good morning to everyone. First of all, it takes quite an effort to conduct a CME and invite the faculty and also the delegates to be here. So with the tireless support and effort of sister, we are able to conduct this CME. We owe a lot to her. Madam, thank you very much for being here with us today and giving us the advice so that we will be able to follow them as much as possible. Thank you, madam, for being here. So it always feels happy and you say very great to meet Professor Madhav. Wherever he goes, he is an inspiration. He is an inspiration to each and everyone. And each and everyone who knows him knows what he is. And he is attracting so many people here. Not because of his this one, because of the skills and because of the knowledge what he has. It is invaluable. And all of you are gaining a lot from him. Sir, thanks for inviting, thanks for coming here, and thanks for being with us. It's a great pleasure to have you here. Dr. Xavier, he is a very known personality to us. He is the man who behind this orthopedics department establishment. He has been supporting us, he has been here. We welcome you here and we wish you a long and healthy life also, sir. Thank you very much for being with us. I also give my sincere thanks to all the faculty who have been here, come all the way to share the knowledge with us. A hearty thanks to you for being here. And least but not the last, our delegates who have taken their trouble to come here, to be with us, to learn and experience. Hope you will have a very good knowledge and also skills to take back home and help those patients who are needy. Thank you for being with us. Thank you for being with us, sir. And also I thank all the hospital staff, the Mrs. Kaushik Surgicals, and our staff who are supporting here, who have come all the way and made this program a success. Thank you one and all for being with us. Thank you. Now I request everybody to rise for the national anthem. Thank you.
हाँ ओके सर हाँ हाँ
40-year-old lady. She had a domestic call. She was pushed by her brother in her house. And she went on the floor. She had a pain in the hip. This is about 3-4 months back. After which she did not seek any treatment. So she was limping continuously. After 3 months she came here. And after the initial assessment, these radiographs were taken. This shows a fractured neck fever and the basic cervical region. The basic cervical region, almost looking like a stress injury with non-union. So she is a young lady, very active in her life. So we have planned for a hip preservation procedure. Our blood investigations are within normal limits. Pardon me? Can be a little bit louder.
Is there any limb discrepancy?
Minimal limb discrepancy we have. There are no fixed deformities. Okay?
Probably it was started as a stress fracture.
Yeah, that's correct. You're right. Probably it started as a stress injury.
It's about 120 degrees now.
Yeah, it's about 120 degrees. Approximately about 120 to 125 degrees.
So vertically oriented.
Yeah, vertically oriented. Probably a bowel angle of about 50 to 60 degrees looks like that. Yeah, the lateral view. Show this lateral view on the CR. We have just taken a view here on the CR. Just look at this lateral view.
It's not much of.
Yeah, not much of a displacement. Okay? Basically looks like a stress injury going for a non-union. Something seen in military recruits. A classical stress injury which happens at the basal cervical neck fracture. Yeah? Yeah.
All these monuments, you pick an monument from the status of the head.
Pardon me?
I don't get it. As long as the shape of the head is maintained, there is no need to measure CD or MR. If you consider the head is but taking it in the area of medical legal, whatever it must be the liability of the head. Even if there is a shape is maintained, it can no conflict. Take your technique is normal to find the techniques. There's no creating and also unites. And you can provide stable fixation. So go ahead with it. Shape without bending. Since this is a stress fracture, not CRP incorporated.
లేదు సార్ అది ఒకటే చూపిస్తుంది అది ఒకటే చూపిస్తుంది అదే స్టాండ్ చేసుకుంటున్నాను
Harish, can you hear me?
Yes.
Can you hear me?
Hi, good morning everybody. Hello. Hello, good morning everybody. My name is Dr. Gangadhar, anesthetist in Orthopaedic Hospital. Welcome to you all. PM. Yeah, This is a patient of 34 years, Gautami, right femur fracture. Today, hip saving procedure is planned. We gave combined epidural spinal anesthesia for this patient. And here I am, my technician team also, Lukappa and Anand. And in
Let me introduce the
yes, sir.
nursing team.
Sir, good afternoon, sir.
Welcome.
My name is Anjali, sir. Sister Anjali.
Hi, good afternoon. Welcome. I am Dr. Varaprasad. I will be assisting Dr. Mabu sir in this case.
We also have an image radiographer. Yeah. I'll introduce the radiographer also to you.
Okay.
Show the radiographer.
Hi sir, good afternoon. I am X-ray CM technician. I am Kiran.
Okay.
First, sir, it's so nice of you to introduce all this staff and
because without the staff, we cannot work here. We are the main pillars here. We have a good imaging system. Sir, imaging system. Imaging system. We have got a good CM. Okay?
Yes,
So the patient is supine. Dr. Varaprasad and Anjali are helping the patient. Yeah. Patient positioning is supine. Okay? As Professor Margo has pointed out, it is on a regular fracture table. Regular table, not a fracture table. Yeah, it is a regular radial table. We have a BenQ table here. Make it. We have a BenQ table here. Show the equipment. Sister, can you open the laser? We've got the angle blade plates, screws, and the necessary equipments here. We also have general orthopedic instruments. We also have striker power system here. Battery operated striker power system here. Yeah, this is a modular operation theatre. We have 4 theatres like this here.
what all plates are these?
Yeah, we have kept the.
All are 120 degrees?
Looks like that, but I can't touch them and see. Let me, when Professor Maru comes, probably will tell you. Maybe 120, 110, and 130. We have 3 plates. 65, 75, 65, 70, and 80. Looks like that. Okay? Yeah. Good. Yeah, go ahead.
Advice you give for someone who is beginning with the new angle gateway or angle obstacle, is it better to use the patient on a fracture table or on a supine table like this?
See,
For a beginner?
Yeah. When I started this osteotomy about 10 years back, maybe about 12, 14 years back, I started with an fracture table only. Yeah, I never started on a regular table. Because what happens, the radiolucent tables may not be available everywhere. It may be difficult for you to obtain proper radiographs. So that will be an issue. Probably it was better to start with a fracture table. Once you get used to it, then you can move on to the regular table, which is available everywhere. We also have the Harish. We also have a supporting staff here. Obalama, who has helped in scrubbing the patient and preparing the patient.
తీసుకొని పోగలవు కదా సర్జరీ చేసేటప్పుడు కెమెరాని తీసుకొని పోగలరు
బయట
బయటికి కాదు ఇక్కడికి
ఓకే వస్తాను ఓకే ఓకే మీరు మాకు చెప్తే తీసుకుంటాం ఇప్పుడు నేను చెప్తాను మీరు చేస్తాను మీరు చెప్తే గైడెన్స్ ఇస్తాను నేను చేస్తాను మనం అనేది ఇక్కడ
Any questions from that side? Any questions, clarifications that we need to do?
Waiting for the
Yeah, Dr. Maru is getting ready. Getting ready. You have two assistants here for him. Two big fellows. 17. Oh, yeah, tell me.
Girish wants to ask.
Yeah, sure, go ahead. Can you be a little bit louder, Girish?
The posterior angulation at the head fracture. Fracture, how will
Pardon me, I can't hear you. Huh? Pardon me?
The posterior angulation at the fracture. It is recommended. Regular table.
In the regular table, it may be difficult for you. In the regular table, it may be difficult for you. Probably, if there is a little bit of anterior open reduction and put Simon pin and then manipulate the antiversion. Okay? Yeah, anterior capsulotomy from the anterior approach. We can get the fracture reduction. An acute injury. What do you say, Dr. Adi? He is asking if there is a posterior angulation.
Yeah, that question I got. What was the answer?
The answer that I was talking to him is about the any anterior approach, open the capsule anteriorly and put the statement pin and manipulate head to its position. Yeah. Yeah. Yeah.
From the lateral view,
Yeah.
there seems to be increased joint space on the CM projection.
That is because we have taken it in traction.
Okay.
We gave a traction here.
Okay.
And just saw whatever we can do the reduction is that. So that the view shows a little bit of distraction at the joint.
Okay.
నుంచి ఆడిషన్ పక్కన చూస్తే
కొంచెం అక్కడ స్పేస్ అది తీసుకో ఆర్ట్ తీసుకో అది ఇక్కడ పెట్టండి అక్కడ ఆయనకి ఒక ధోని అమ్మా సరే ధోని వేసుకోండి బెటర్ సరే ధోని ఎందుకంటే ఇది తగ్గుతావు కదా అది వేసుకుంటే కొంచెం సరే ధోని అదంటే అది ఏం ఎక్కువ చేయడు అదే లెక్క చేయడు అదే ఆపరేషన్ చేసి ఎన్ని బయటపడి అన్ని బయటపడి 1 minute. Hope everyone is awake.
We are not applying this outside. Friday, we are not applying. Okay. After.
So this is standard lateral approach used here.
Pardon me?
The standard lateral approach vaccine
Yeah, and this fresh recent APU.
Standard lateral approach. Okay?
Okay.
You can address the questions directly to me.
Yes,
Dr. Margo is not telling the scholar mind.
Okay.
He doesn't want to be disturbed during surgery. I will disturb him. They'll ask me questions.
So why not just
little bit uncomfortable for me.
sir, why not put compression screws across the fracture?
Can I put compression screws?
Yeah.
Instead of doing osteotomy.
It's just a stress fracture. Following it heavily in the chest. Why don't we put CCS screws non-vertical?
But then you cannot make the patient mobile entirely. You can also put EHS. That will make it involve reduction. It will still heal. Biologically it is active. Only thing is there are shearing forces. When you see the traumatic fractures, when you go in the literature, they say they are known to malunite, but the basic fractures they are known for non-union because of the shearing forces. So we must get away from the shearing forces and do wall reduction. So that is what the power strocking will do. So it will also buttress it from below and will also go away with shearing.
So probably will be short short of the union.
Yes. Yes.
Okay.
What is your answer, Harish?
Yes, yes. This is for discussion I'm
Yeah,
asking.
good.
Because there are some post graduates here.
Yeah.
Basically, you can also do easily and do the osteosynthesis with your life. But you cannot repeat our WhatsApp.
Pardon me?
Can you just repeat what Dr. Madhu said?
He is saying fracture at the basic cervical region, sharing forces also cause non-union. Putting a simple catheter screws will allow only a minimal stability, will not allow a grand stability at the fracture site.
Okay.
So doing wireless osteotomy will convert sharing forces into compression force.
Yes.
Also putting a screw and osteotomy will almost short of union.
There is some internal rotation. So we do mild.
There is some internal rotation deformity, as you can see here. Dr. Harish,
yes, sir.
Can you see there is some internal rotation deformity? You see at the knee, the patella is rotated internally.
You are able to see.
Can you just focus the knee? Can you see that? Yeah.
Zoom out.
Zoom out a bit.
Yeah.
So there is a mild internal rotation deformity
Okay.
at the hip. So probably by doing osteotomy, you can do little extra rotation and bring the bend to the neutral too. Okay?
Yes, sir.
Thank you. So we're almost ready.
Yes, sir.
Okay.
This is the attitude actually. This is the attitude to the limb, otherwise there is no problem. Normally there should be external rotation problem.
Yeah. Correct. So we're ready with the incision. So sir, what are the landmarks for the incision?
In the right one, I will see.
You're not able to see the.
Yeah, just a minute. We'll come back.
take out common bone levels. Then he will be cutting also. So the landmark for the sir, just top of the trochanter. So sir is feeling the top tip of the trochanter. Yeah, 1 minute. We're just readjusting the. Then I want to for that. So please bring the unit here. Can you see now? Okay. Harish? Yeah. Sir is palpating the top of the trochanter. Can you tilt this because this is lying too much to straight? You want to tilt? Patient should be at the edge. Patient should be at the edge. Somebody can push the. You put some sandbag here so that rods are coming. Okay. Can you put a sandbag? Yeah, we can do that. We can from above. Put a sandbag better. Sir. Either down sandbag. Make a roll there. No, we didn't do sandbag. We just push the patient. No, make a roll. Fine. You put a sandbag. Yeah, we'll do that. Make a roll. So yes, palpating the top of the trochanter. So the cancers to put the view. We are trying to put the cannulated or non-cannulated. Okay, we are discussing. We are trying to put a pump underneath the iliac crest. Okay. Under the hip. Under the iliac crest of the hip. So that it will become more prominent. The trochanter will become more prominent. Can you see he is pushing it inside? One minute. Raise the hip. Not too bulky. Keep it medium. Even guide. Even to यहाँ लाओ.
स्टैंड वेसुको टाइपड वेसुको
పేషెంట్ ఇంకా టేబుల్ ఎడ్జ్ రావాలంట Patient positioning is being adjusted. Patient is being brought to the edge of the table with the involved hip being elevated with a sandbag under her buttocks. Professor Madhu, pardon me?
We lost the focus.
You got the focus now?
Yes.
Yeah. So we have brought the patient to the edge of the table and elevated the hip. So he has palpated the tip of the trochanter. Now he is obtaining an image with the tip of the trochanter. You see the image intensifier taking the radiographs now. Image. Okay. Now a referral radiograph is being taken. Pardon me?
The tip of the trochanter. Is it the proximal extent of the incision?
Looks like that. Yeah.
I can't hear you, Harish. Little bit louder. Yeah, yeah. Yeah. No, not in the lateral position. No, not in the figure of 4 position. Only the guide wires, when they go, they will be in the figure of 4 position. Okay? Yeah, here you see. Image. X-ray. He has taken an image with the tip of the trochanter. Can you see the image?
Yeah, we can.
Yeah. With the guide wire on.
What's the purpose of this?
Yeah, to mark the tip of the trochanter.
It's only to isolate.
Yeah, tip of the trochanter. Now the incision. We're going to start the incision. Starts just above the tip of the trochanter and goes down all the way. Can you see that?
Yeah.
Yeah. Is inside the superficial fascia and trying to catch the bleeders. Patient has got quite a bit of fat, huh? So the field is almost bloodless. Yeah, very critical. He's taking his time to get the superficial, the subcutaneous fat out. Yeah, now we have reached the TFL. Can you see the TFL?
Yeah.
That is the inside now. Pardon me? Yeah, to prevent the blood loss, also to preserve the blood loss. Preserve the blood vessels. So the proximal extent of the incision just about the tip of the trochanter. The distal border of the incision is just enough to get the plating. Pardon me? Yeah. If necessary, the incision can be extended at later. First is to get the fracture reduced and
I am not divided the
held it for you.
muscle as yet.
He has not divided, he has just divided the tensor fascia later according to the teeth. So just about to see the muscles. That's the gluteal bursa, the bursa between the vastus lateralis and gluteus medius.
And this is the abductor.
And that's the abductor.
This is versus lateral.
Yeah. So that's the gluteus medius, what on the top of the incision.
So,
on the down it's vastus lateralis. So you will be inserting, you will be just the position where to put the guide wire in for the physics. Pardon me?
Yeah, just show me the guide wire.
Yeah, yes. Yeah, that will be, that I know.
Yeah, this is the trochanteric tubercle, okay?
This is the trochanteric tubercle. Can you see that?
Okay. Middle side defining. Show me middle side also.
That's the trochanteric tubercle.
So this angle is actually here our 100 degrees, you see.
The angle is about 100 degrees. Here the next shaft angle. You see the next shaft angle. Come down a little bit. Yeah.
So I will excite it with 20 degrees.
Yeah. You see that now the angle is actually about 100 degrees. Okay. 100 degrees from the shaft. Shaft to that guide what you see. Okay, it's about 100 degrees. So we have to make it about 130 degrees. 100 to 110 degrees. Probably about 22 mm of weight can be needed. Yeah, now you see the two levers showing the anterior and posterior portions. Can you see that? Two levers, bone levers. Yeah, it should show this. Can you see the bone levers now? Anterior one, the posterior one is down. So that shows the width of the trochanter. So the guide wire is in the junction between the anterior 2/3 and the center one, the middle point, what you are mentioning. Now he is slowly making an entry into the trochanter tubercle area. Okay. So that's the guide wire which is placed.
Your voice is little low.
Pardon me? Yeah, can you hear me? Yeah.
Now I am giving
Now he is giving an L-shaped incision, trying to lift the vastus lateralis up. Okay? So that's the L-shaped incision. The vertical L of the limb is little posterior and going down towards the vastus lateralis. The horizontal limb is on the anterior aspect of the trochanter. Now he is saying the trochanteric tubercle. His index finger of the left hand is at the trochanteric tubercle area. Now we will see the anterior and posterior edge of the femur very clearly. So that's the exposed lateral shaft of the femur. See that? The chisel is right on the trochanteric tubercle. Can you see? The osteotomy is right on the trochanteric tubercle with a minimum dissection.
Can the camera
What do you want?
Can the camera come over the shoulder of
You can come here.
You can see the direct back.
Is that better now? Is that better? Yeah. Now he is making the entry point there.
Very clear now.
Yeah, with that chisel he is making the entry point. Can you see that?
Can you give me small osteotome now?
Yeah. With bone osteotome, he is making an entry point in that area.
That area bone is quite strong.
Yeah, that area bone is quite strong. As we said, it is about anterior 2/3 and from the center it's about 1/3. Yeah.
So the head has gone posteriorly here.
Pardon me? Pardon me?
10 mm wide. Is it a 10 mm wide chisel?
Yeah, it's about it's a 10 mm wide chisel. Correct. So we'll take the image now and we'll see that, show that image.
Just see the lateral view. Yes, I'll tell you how to take the lateral view.
Show the image. Can you see the osteotome entry point there in the image? Can you see the image?
Yeah.
That's the osteotome entry point. Entry point for the chisel.
Okay. Now let us
Now this is the AP view. Now we will take a lateral view. Okay. Now you see how the lateral view is being taken. See, the leg is kept in the figure of 4 position. Can you see that?
Posteriorly. Posteriorly is acceptable, but I will make it so when you are not on the margin, this problem comes. Because your table is stuck and this slips. So you are trying to show that again.
You see the osteotome is on and they are taking figure of 4 X-rays. You see that?
So I think here is to get the edge of the table.
Yeah, because what is happening here is below the table we have got the railings. So see how it comes in image will come in. Yeah, exactly. You need a completely radial. Now that's the position which is in the AP view.
अरे ऐसी lateral view आ जाएगा.
Yeah, just take a view there. Now we are seeing the lateral view. Pancham local. Yeah, can you see that lateral view?
No, yeah. This is not lateral. Is this the view?
No, he can take like that. This is better. You know?
This is okay.
Yeah.
This is not sure. This goes like this when I make a lateral move.
Yeah.
Lateral move that will better because you like और उठा इसको और उठा अब दिखा भाई yeah this is correct.
See, that's the lateral view. You see that?
Correct. Okay.
Yeah. See that lateral view? See that lateral view? The osteoid.
इसको सीधा कर दो ना अब तरीके यार.
Keep it down.
Darling.
Keep it down.
Directed towards the posterior aspect.
If you see that the picture, you see that the osteotome is on the anterior and the middle junction. Can you see that?
Correct.
Yeah. That's the position that we need.
Yes.
So that's the lateral view.
So when we want to exercise the wedge of 20 degrees, that is what I have planned possibly.
Okay.
Chisel दिखाओ chisel.
Now he is going to introduce the chisel to that.
Yes, this and left.
Sir, can you turn this side, sir?
Sir, can you ask?
Yeah. He is trying to assemble the chisel and the flap.
So supplementary angle of 120 is 60 degree. So I want to exercise a wedge of 20 degree.
Okay.
So 20 plus 60 is equal to 80. So this angle I am going to make 80. Okay.
Okay.
Can you see that flap here there?
Yes.
Now
Supplementary angle of 80.
give me templates. Yeah.
Now with that template,
80. Here it is 80.
80 templates, that flap is going to be set.
20 plus 60 plus 20 is
80.
80 is this.
Sure.
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 This is 80. This is 80.
Okay.
Tighten it. Tighten it from below. Tighten it. Loose.
You need a spanner to light it. This is shoulder. Can you see the wedge there, Harish?
Yes, sir, we can see.
That wedge is about 80 degrees. Complementary angle. The template wedge is about 80 degrees. They have adjusted the flap to 80 degrees. Can you see that? Yeah, this flap
This is 80 degree.
Yeah, this flap will be parallel to the femoral shaft.
From here, it is 80 degree. This angle is 80 degree. So I will exercise a wedge of 20 degrees. So 60 plus 20 is 80 degree. Take out the plate of 120 degree.
Did you get that point?
Yes, sir.
Yes.
120 degree plate.
Yeah.
This, from my experience, it seems that 85 degree blade length will be good for this.
What's the summary, sir?
See, from his experience, he is saying 85 mm length of the blade.
Sir, can you repeat one more time?
From his experience, he is trying to calculate the length of the blade. Can you hear me?
Yeah, I can hear
Yeah. So he is trying to calculate the length of the blade.
Otherwise, you can calculate it.
The length of the blade, from his experience, he is saying is about 85 mm.
So for the inexperienced, how do we assess?
For the inexperience, how will you assess?
Because we are planning, right?
How to get the length of the blade, correct?
We are planning, I think.
Yeah.
Before that, we have to get a proper.
How to get the length of the blade, sir? Exactly.
80. So it is 80 and not 85 with him.
Okay. We have 80 mm blade, we don't have 80 mm, 85 mm length blade. How to calculate the length of the blade?
When you put the chisel, show me the chisel. Show me the chisel, please. The chisel has markings.
Okay, sir.
The chisel has markings. You see here. Yes. This is 90. So this is 80. That is 70. So and this is 60. And here is 50. So 50 is for blade plate of the distal femur. Okay. We are doing hip. So hip is now The plate I have is of 80 millimeter. This is sufficient. Okay. If it is insufficient, I'll put it further inside. So ideally to me it looks the 85 should be the blade length. And you can calculate the length when you are putting chisel in the... Listen, please, listen, don't interrupt.
Away from the edge of the...
Harish, just wait a minute. He's trying to explain.
That's the maximum it can go inside.
Harish, just wait a minute. He's explaining. Good.
When you...
The tip of the blade.
Just wait, Harish. Harish?
Stay 10 mm away from the subcontinental bone.
Yeah.
Is that right?
Harish? Harish? వినపడదా?
Okay.
Harish? Hello? Can you hear me?
Can you hear me? Yes, sir.
Both of us can't. I can hear you, you can't hear me. Hello? Can you hear me?
Yeah.
Yeah. Professor Mabu will tell some points now. Just wait a
Yes.
The chisel itself has markings. Okay? Not audible.
Can you hear me?
Yes, sir, we can hear you.
Chisel has its marking. So when you insert the chisel up to the required margin, say 1 millimeter short of subarticular cartilage, 1 centimeter short of articular cartilage, so you can measure the length of the blade required from the chisel itself. Am I clear now?
Are you clear now, Harish? Harish?
We can hear you, sir.
Yeah, so what sir is saying, hello? Hello?
There's something wrong with the system.
Can you hear me, Harish?
Yes, sir, we can hear you.
Yeah, what sir is saying, when he is inserting the guide wire and the chisel itself has markings.
Yes, sir, we saw that, sir.
Yeah, when he introduced the chisel,
Yes.
1 centimeter just distal to the subchondral bone, you will get the length of the blade.
Yes.
Now that's what he's trying to test.
This is the test. This is the test
Now he is trying to show you the length of the blade by obtaining an image. Just can you see?
Yeah, we can.
Yeah.
Here.
So is that to see the direction of the blade?
No. It is to get the length as well as the direction.
Okay.
Now show. The flap must be visible. After show. Yeah. The flap is not parallel. Show now. Now you show.
Okay, sir.
Like this. So because there is a fat, too much of fat, I am not able to see that. Now how? Yeah, here. With the mice. Show me again, please. So this is this I have mathematically adjusted the flap and the chisel. Okay, but not the. It also seems my blade which I use for making an entry point for the chisel is okay. It's actually
Can you just repeat? It was not clear.
What he is saying, show that CR picture. Can you see the CR picture? Harish? CR picture. CR picture shows the direction of the plate. Okay. So also you see osteotome just above the plate.
Correct.
Yeah. That slot is well enough for him to introduce the plate.
So the blade will be introduced the side of chisel or
No. The chisel is below that osteotome. There are two instruments you can see.
Correct.
So the osteotome was placed on the surface of the patient. Okay?
Correct.
To know the direction. The chisel on the top is the entry point.
Oh, that's entry point.
Okay? Okay. Now he is trying to make the entry point. And he is trying to lift the muscle too. Pardon? Yeah, anterior 2/3 of the vastus lateralis is being lifted anterior. Can you see that?
You separating
Vastus lateralis. Yeah.
I am doing the avascular zone.
So yeah, correct. Posterior to anterior 1/3, which is almost the avascular zone. So he's trying to lift the vastus anteriorly so that the shaft of the femur can be exposed. Okay?
Yes, yes.
That's the dissection going on now. Distal shaft dissection. Next. Outside. Now try to extend the incision a bit
To adjust the flap.
to adjust the flap and also to get the plating. Okay?
Okay, sir.
You see that absolutely there is minimal bleeding. We are going in the avascular zone. You know, at least one must have finished with 3-4 mops by this time. 3-4 mops would have been finished by this time.
Yes.
Yeah. Now absolutely he is using only one mop. See that slitting of the vastus lateralis? Can you see that? Yeah. The vastus lateralis is being slit nicely. Absolutely no bleeding.
Yes.
He's not going to strip the periosteum also.
Yeah.
Now,
So the periosteum.
yeah. Now you see that the
Very good instrument.
Can we strip only where the osteotomy has to be done?
vastus lateralis is being elevated. Can you see that now?
Don't put those.
Yeah. That's the vastus lateralis being elevated.
I have to put this muscle because I have to take out a wedge.
Yeah. So you're just exposing the lateral surface of the femur and the proximal area so that
When I split it with the finger now.
get the
Give me one more moment. Give me one more moment.
a delicate finger dissection also will separate the vastus lateralis.
Give me
Yeah.
one more.
Can you see that how he is separating the vastus lateralis delicately with his finger?
Yes.
Not using any sharp instruments. Only the sharp instruments looks like only the woman's
Not good one,
liver.
not good one, okay.
Yeah, that's
Now
the
you see the
exposure.
wound. Now you see.
Now you see. That's the exposure.
Show here.
Show you. Yeah, he's
See, periosteum is intact, small
See.
muscle intact.
periosteum is intact,
This
muscle is
plate.
intact.
From here I will take the
So,
graph like
see.
this.
Yeah.
Okay.
So he's,
You place muscular, right?
yeah, it's almost submuscular. Periosteum is intact and most of the muscle is also intact. Only the proximal portion of the femur is exposed just to take the wedge.
The voice is closer.
Only proximal portion of the femur is exposed just to sufficient enough to take an edge, to take a wedge. Okay. The rest of the vastus lateralis is intact. Can you see that?
Plate will be placed submuscular or over the muscle?
Plate will be placed in a submuscle like you place a lock compression plate.
Yeah, we just
Yeah. Just slide it below the muscle without stripping it too much. Now the muscular stuffing is only done in the proximal part of the incision.
I'm not stripping, I'm just trying to see the track.
Proximal part of the incision is only being the muscles are being stripped only in the proximal part of the incision. The distal part remains intact.
Just you remove it.
Okay. Now the
Put light here.
can you see that now? Yes, we will remove his mop and we will be able to see that. Yeah, yes sir.
Yes, what do you want? Somebody should remove it and give me the chisel. Yeah, now light is open. Don't.
Yeah.
I will remove it. This is up. You remove it.
Now that osteotomy is being removed. Can you see that?
Yeah, we can see that.
Yeah, now the chisel is being placed. Yeah. And now see that, now we'll take an image and see the entry point.
Who is the extension control here?
Yeah, that will do. That will do. Pardon me? Yeah. That will take it 1 minute.
No problem.
We'll take the flange parallel to the flap.
I will do myself. Okay.
Unfortunately, the flange fell down. Okay. Now he is getting the entry into the.
Now where the experience?
Yeah, with his experience.
Tell me. Show me.
Yeah, should.
So we can make out that the
It's
chisel
above.
is
It's
almost
above
perpendicular
and
to
yeah.
so that there is no flexibility.
Correct. You see that the entry point with the chisel? You see that? Show me that chisel is in the trochanter. Can you see that? See on picture?
Looks like going
Yeah, yeah. That you will try and adjust the. Yeah,
All these chisels come with the provision to fit over a guide wire.
Hammer.
So for beginners, maybe that will be more.
Yeah. Correct. You are right.
Okay.
We are trying to adjust the position of the chisel. Okay.
Maybe if there is no provision, we can pass a guide wire reshaping.
Yeah. Plus you can pass your chisel over that.
Pass the chisel.
Yeah, that's right.
Innovations come by the
Sir, Mapu may not be there.
everyone.
Yeah, he doesn't need all those things.
No. I have to learn from everybody.
Yeah. Now he is trying to pass the chisel in the.
It goes, once a track is made, it goes like that.
So he is trying to make a track.
Sure?
Yeah.
It's going up?
Yeah, it's more superior. Looks like more superior.
Your point, entry point and the last set, which is 1 centimeter short, should be correct always. Give me some mosquito.
The crux of the surgery is getting the entry point right.
Entry is at the pair of the trochanter, right?
Yeah, at the trochanteric tubercle.
It can be down also.
It can be down also so that you can adjust exactly the position of the plate.
Correct.
This
It need not be exactly at the trochanteric tubercle.
It's slightly and clearly. I am feeling
Yeah.
it.
See, in this patient, trochanteric tubercle entry is
The
little bit
lateral
superior.
margin, no. The lateral margin has changed the position of entry point. This thing.
Pardon me?
Any reason
This
for
thing
that?
has changed the entry
Because he is not able to visualize the thing properly.
Yeah.
So the entry
I'm
point
able
is
to visualize everything because this stuck it.
yeah.
While making a frog like you, it
Yeah.
has changed. Remove it now. We should be truthful for every angle.
Yes.
We should be honest and truthful.
Yes.
Yeah. देखो, Hammer. So this is slightly interior.
Yeah.
I may not break anything.
Good. Now got the yeah. Now we will see the entry point of the chisel.
No,
Yeah.
show me please.
Now take the X-ray. Yeah, show that. Can you see the entry point now?
Just show. So, slightly hard noise I have heard. So this might be slightly posterior. Okay. So the fracture table actually would have been better for a learner, not for me.
Got the point?
Make it a. Give me a.
Harish?
Sir,
Got the point?
no, we didn't hear it.
See here, the table has got a little problem issues with it because the patient is not getting at to the edge of the table.
Yes.
Okay. So by not getting the patient at the edge of the table, it may be difficult for you to introduce your chisel in
Show
an
the
ideal
lateral
direction.
view.
Okay.
So this is going correct.
So you see the position now.
Yeah.
This is the lateral view.
Correct.
Yes.
Position of the chisel is in the correct position.
I'm making full slot now.
Now the entry is confirmed and found to be correct. Okay?
Okay.
Now he is driving the chisel more inside into the femoral neck.
This angle is 70 degrees, okay?
So the angle is around 70 degrees.
Show.
Yeah. So that can you see that?
Yes.
As it is making a track into the
Yes.
Show.
neck.
Lateral view.
Yeah.
Lateral view, please.
Now you see this is the AP view. It has made an entry into the neck area. Now we are taking a lateral view.
The weight
Is
of
it
the limb should be on your palm.
the cable or something?
Yeah, show. So this is okay?
See, this is the lateral view.
Yes.
Can you see that?
Okay.
Yes.
Looks like an ideal position.
I just have a question.
Yeah.
If we are pushing the chisel inside,
Yeah.
there is a tendency for the head to go into RS.
Ah.
Is it advisable? I mean, just asking.
Yeah. It is advisable to fix the fracture.
Put a cable or a screw proximal to the.
Yeah. In some cases, the front Baba has said that you can put a cancellous screw or a.
Yes, sir.
Yeah, cancel a screw or a Steinman pick to fix it. Yeah, that's your right. So that the head will not go up and down.
Yes.
It's fine. See that the entry point, and now that's the AP view.
Save the picture, please.
AP view, and the chisel has gone almost to the subchondral bone.
So now I am going to seat the plate inside it.
Okay. Now the plate will be seated inside.
So डाला नहीं क्योंकि fibers union है वहाँ पर. Nice.
What is the ankle plate you want, sir?
I want
What is
plate
that?
to be seated correctly.
What ankle plate?
120, which I have selected. उसको fix कर सकते हो क्या? इधर देखो. You see?
This is the plate.
128.
80.
हाँ चलो
I have to explain how to put it for the second time.
See, this is the plate that is selected. Can you see that, Harish?
Yes, sir, we can see.
Do you have the 85 plate?
So 120 and 80 mm.
Okay.
The length of the blade is 80 mm. It's a double angled one. 120 degree. Okay? Yeah. Now we have made the track for the plate, for the blade.
Yes.
एक को पकड़ लो, एक को छोड़ दो.
You see the exposure?
Yeah, we can see.
Yeah. See the vastus lateral is not being fully erased from the bone.
We don't have 85?
80 sir, we have 80.
80, okay. एक स्पर्शिक वाला कहाँ है? वेरी स्पर्शिक कर देता है. इसमें होगी 85 एरिया. अच्छा, you can read it from there. So what is the
So
size?
we'll read the length of the
Can you read it?
plate. So the chisel there.
Chisel on
అక్కడ చూపెట్టు chisel. Can you see?
80 looks correct, sir.
Huh?
80 is good.
So the chisel reads 80. But professor says it should be 85. But the chisel is reading 80. We don't have 85 here. We have 80. So the plate is being assembled.
Hello, sir.
Yeah, tell me.
Sir, we cannot separate the fracture. Like in the beginning stage, is it not better to?
Yeah, that's what Dr. Harish was asking.
Yes, sir.
You put a K wire or a screw, cancel a screw earlier to stabilize the fracture and then get this knot done.
Yes.
There is a lot of fibrous tissue.
In sclerotic edges, in non-linear sclerotic edges, will there not be any resistance to the chisel? Is it that sharp or any?
It is the chisel is very sharp, number one. Number two, if it was a fresh fracture, I would have first stabilized with two cushion wire as shown in my demonstration and in my presentation, and then put a screw. But this is a 5 months neglected non-union with a lot of good fibrous tissue.
Inherent stability.
Inherent stability is there. That is why I have not put a screw. But now since the blade is 85, and I think it should be 85, I additionally later on I'll put a screw.
So can you show them how to assemble this?
So you have seen this assembly.
See the assembly?
So
Sorry?
at the angle, at the, this is the blade, this is the blade, and this is the angle. So you should use your jaws or the bone holding forces at the elbow. So this is the elbow. And this should be the axis of the blade.
Okay.
Okay.
Sir, we have 128 in our system.
One?
In our system, we have
It's a long blade. 123
What the position there? The position of the plate as well as the holder.
somehow this now angle look. So I will move it 10-15 degree angle. Bed. इसको मैं थोड़ा अगर डाल लूँगा ना पहले.
Yeah. Where you are going to put it inside?
हाँ तो फिर वो जो उसका मार्जिन है because we don't have motorized saw. Do we have motorized?
We have motorized saw.
Yes, battery operated. What is
Battery operated. Battery operated. Strike.
Okay. तो मैं थोड़ा सा पहले शुरू कर देता हूँ इसको. एक और दो हम दो.
Now the next step will be taking the wedge. Okay? Harish?
Yeah.
Harish is getting annoyed.
You can see that
Harish is getting annoyed. That's what Professor is saying.
No. Doubts here we discussing.
Don't discuss outside.
Don't discuss outside. That's what he's saying.
Being an inside. When I come back, then you blast me.
Discuss inside, and when Professor comes back, blast him. Okay? So now he is exposing the lateral shaft there, the proximal area, to make an osteotomy.
So this much size is of elbow.
Yeah.
This is the size of the elbow.
You see, that's the size of the elbow where he is showing the cautery there.
Okay. And from here I will excise the wedge of 15
below that he is going to excise the wedge.
Okay.
1.5 centimeters from the seating chisel. That's what he told you.
Give me your saw.
Correct?
1.5 from the?
From the entry point, from the seating chisel. You see 1.5 distal to the seating chisel, the wedge will start.
Okay.
That is to accommodate the elbow of the plate. Okay? Yeah. Now he is trying to get the wedges in.
Even the how you put some jabbing so they should understand. I am worried that I should finish it fast.
No, it's going to go.
Ask me, sir, before the osteotomy is done.
Yeah. Now we are.
And you see there is no bleeding. You see there is no bleeding.
See, absolutely no bleeding. Okay. Now we are trying to locate the wedge as well as the, and then do the osteotomy. Okay. Yeah. Now we are putting the KY to locate the wedge. Okay.
Then after the plate is placed or before?
No. This is before the plate is placed. Only chisel is there inside. Okay. Now 1.5 distal to the entry point, parallel to the chisel. He has made a. He has made a.
This is going above the lesser trochanter.
So that is going above the lesser trochanter.
So is this just a V osteotomy or a Y osteotomy? What kind of osteotomy?
Yeah. Can you see the? Can you see the proximal K wire?
Yeah.
Going parallel to the seating chisel, going almost towards the lesser trochanter. Okay? Yeah. Is it a Y or V osteotomy, sir? What do you plan?
So what is their need? What is their? So V osteotomy will also work very well, and Y will also work well.
Both will work very well. That's what Professor is saying. Okay? V and Y.
I would like to see a Y osteotomy.
You would like to see a Y osteotomy. They would like to see a Y osteotomy. So the second K wire is introduced for about 20 degrees of wedge. Can you see that? Yes, you show this. Can you see that now? The second K wire? Okay? It is going for about 20 centimeters of slope. Show?
Yeah.
You see? You see that? Show? Can you see that wedge?
Yes.
Can you see?
Okay. It is becoming V, but on the way I will make it Y. Okay.
It is becoming V. Okay. While making an osteotomy, you will make it Y.
Give me second wire.
Okay.
Okay.
Now you see that osteotomy markings have been done.
So this angle is about 15 degrees. Can you give me the template?
So the
small template.
Sir, I want to ask one more question.
Yeah.
How do we control the rotation?
Rotation of?
Once we done do an osteotomy,
Yeah.
there is a rotation alignment.
Rotation.
Will any events be placed from anterior to posterior, proximal and distal to the osteotomy side to guide the rotation?
The best way is the patella should face the roof just away. So when you are going to fix it, you place your patella away from the roof. Okay, otherwise you make a wire cut along the angles above and below. And then when you rotate it, you can see this is the 15 degree or 20 degree wedge. Okay. So like that, rotation can be judged between the two wires. So here the two wires are parallel.
Yes.
The rotation is not a problem in this patient because I have shown you patella, it's normal.
Correct.
Because of the fibrous tissue, maybe this patient was walking, so with this the patella, there is no external rotation deformity.
Sometimes when we have been in hospital, these wires come off. So that can.
It doesn't matter, wires come out, can come out.
Usually the wires come out at the end of the osteotomy. When you finish the osteotomy, the wires will come out. Looking at the patella and the limb rotation, we can assess.
That is to place one wire each on either side of the hospital.
You can put your wire like this and make an angle.
Place where the plate is seated.
Just see.
You will find the
Hang it. Guide wire. You can put the wire like this.
You see that?
So it is making an angle about 20 degrees.
Yeah.
Yeah. You see this wire? Show under camera.
No, there.
Show the camera on the boom.
What was that wire, sir?
So this wire will tell about the rotation. Now if I cut it here,
yes.
So rotation can be of 10, 15 degrees. Or we want to do a fraction, say we want to do a fraction of 20 degrees, so you can make an angle here. Both anteriorly as well as laterally.
So if you want a flexion or extension,
Yeah.
we have to use the place the chisel either in flexion or extension.
Give me 20 degree angle, 20 degree angle. I'll just show you.
The vertical wire will tell you flexion extension.
Show me please wire.
Also rotation.
टेम्पलेट भेजिए टेम्पलेट बहुत सारे थे ना 20 डिग्री लिखा हुआ है.
Now you see that wedge and template wedge. Now we are trying to insert the template and look.
There are small templates also AO has made. Small templates AO has made. I will show you in my video.
Okay.
So you can see the wedge will be nearly देखा ना shoulder like this दिखाओ show again show so this is 20 degree wedge you see
yes
you can see the wires are parallel to the edges of the template
yes
and apex is there okay see when you make a why has taught me whose question is it
Harish
yes when the calcar tries to break
pardon sir
calcar tries to break in very hard wounds.
Okay.
In osteoporotic, that is easy. So in this lady, the bone is quite good. You see, you could hear the hammer's noise when I was hammering it, and I was feeling it. The bone is quite good.
Yes.
Okay.
It's quite young around.
Yeah. So just I am cutting the outer cortex with the saw, and I will complete it with an osteotomy or later on when I insert the blade. Okay. You got me? यार ये पिक्चर सेव कर रहे हो क्या?
Are you okay with the explanation, Harish?
Yes.
Now we are going for the osteotomy. Okay?
Follow. देखो when I say when I use a saw, it vibrates and then there can be bleeding.
Using an osteotomy to compress the bone and the vessels inside. Using the saw, electric saw, vibrate the one will cause bleed. That's what you are saying. You see some bleeding, you can see there.
So yeah.
So that's the disadvantage of using a power saw. But
Are you happy? Picture ले लो.
Yeah. Can you see that? Can you see the osteotomy? Yeah.
This doesn't take time. I am taking time to teach.
Yeah.
And assemble the instruments. Otherwise, it doesn't take much time. This can be finished very easily in 60 minutes. Very, very easily in 60 minutes, 50 minutes, 45 minutes.
So that's the proximal limb is being done. Now we are going for the distal limb of the osteotomy.
Okay.
Okay? To get the 20 degrees.
Home and Take how much? So only the osteotomy side will bleed now.
రాలి కొంచెం ముందుకు తీసుకురా కనపడుతుంది మనకి. Sorry, what?
I want to make a distal osteotomy.
So now the distal limb of the osteotomy will be done. Okay?
Yes.
So we are ready for the distal limb of the osteotomy. Proximal limb is done. No, you have not broken the medial cortex. Okay?
So is it essential to break it?
Yeah, it is essential to break it.
The bed I am excising only 15 degrees. Okay.
Good.
Where is going? Show?
Yeah.
Is okay?
Show that.
Okay. It's okay.
See that the distal limb of the
You see the saw?
osteotomy.
Bring the osteotomy. Yeah,
Can you see the saw there?
Okay, show me. Yeah.
Yeah, that's the distal limb of the osteotomy, making about 20 degrees angle.
Yes.
About 2 mm of wedge. 20 mm of wedge.
See, is it wide? How? Yeah, it is.
See, now it is a wide because we are short of the medial cortex. Can you see that?
Yes, yes.
So we have not gone through the other side. So it is a Y with a small horizontal limb.
Correct. So now I will excise the chisel, remove the chisel and put the blade.
Okay.
Okay?
So before you break the middle cortex,
This actually shows me that this angle is about 75. So the wedge should be 15 degree, okay?
Okay.
Now before completing the osteotomy, the plate will be
Yes.
Now whatever bleeding is there, it is from the osteotomy side. And I am taking time, so bleeding otherwise sponge. The sheet is there. Maybe small sheet. Sheet. This one. So focus नहीं आएगा. Small sheet.
the bleeding is mainly due to the
It's
power
not much bleeding.
power instrument.
It is just oozing.
It's a oozing from the medulla due to the power instruments.
Yes. Slotted hammer.
And osteotomy could have
Doctor Masood.
reduced. Yes, sir.
My don't hurt me.
Okay?
That's fine. Look. Yeah.
You see now he is taking the chisel out.
Yes, sir, we can see.
Hammer in. So there is slotted hammer is being used to take the chisel out.
मेरे हाथ में लगेगा. चलो. It's a good bone.
It's a good strong bone. They are really using the nice force to get the chisel out.
Just hold. Yes. Give me some moment.
Yeah, young lady about 40 years.
और ये
A healthy lady.
हाथ को चुभेगा ना ये. इसको निकाल.
So quite a strong bone. Whatever oozing is coming from the osteotomy side. Yeah.
Because you are taking time, yes. पूरा नहीं निकालना इसको. Plate hold करो.
Sir is going very slowly today.
Plate hold.
He will finish this procedure about 15-20 minutes.
Just keep it ready.
Just for us to learn the steps, he is going slowly.
Slotted hammer. It's not out.
So we are trying to get the chisel out.
One second. You hold it from above. Yes. Beta me. Hold it. Hold it. अरे यार. Hold after that. Yeah. अरे तुमको चोट लग जाएगी डॉक्टर.
The bone is really hard. The chisel is refusing to come out. And they are giving really nice blows.
यार इसको तू दो चीज मत कर.
Just take it out.
ठोक दे.
Take it out.
चल.
Somebody hold the.
it's really hard. Bone is really hard.
Just
Chisel is really nicely seated inside.
see the image. See the image. It is out or not?
No, not coming.
Huh? Not out? So your force is very less, yeah? Okay, hold it. Just one force, yeah. Just come. Yes, so? Show image.
Show the image. Now, see the bone is very hard and chisel is seated very nicely inside.
Just.
And then I try to take out the chisel.
It's almost.
So the chisel is out.
You see the wedge?
Yeah.
Wedge is there?
Yeah, the chisel is almost out.
Now give me a screw. Drill and screw.
Screw, sir.
At this moment, because my hammering might have disruption some at the fracture site. Okay? Yes. So when I'm putting the blade, there may be some problem. So to avoid that problem, now I'll fix the fracture with a screw. Okay? Okay, sir. I'm fulfilling your desire.
Harish is fulfilling your desire of putting a screw inside. To avoid the trouble.
Otherwise, you will be laughing at me. I told you put a screw, Dr. Mabu, this is what you see has happened. So thank you for making me wise. Sure? Here the equipment is very osteoporotic. Yeah, show? Show? Yeah. Give me 85 with washer. 85 with washer. इसको suction because the press करो. Sucker will invite more blood. You can just press it.
Can you see that track for the screw? Yeah. Track for the screw is being made. We are going to put a catheter screw.
Give me 32 millimeter screws head.
We are going to put a 85 mm screw with a 32 mm thread. Okay?
Okay.
To stabilize the fracture so that we know toggling when we are.
Sometimes the bone at the elbow is size is less. This can break at the fracture site. And your fracture base or cervical base of fracture can be exposed. So you have to be very careful. You see there is a still stock of fracture or bone at the osteotomy site. Between the head, proximal fragment and the osteotomy site where you find the plus marker, there is a still bone. Okay? Yes.
Got the point?
Can you come again?
See, there is a sufficient bone stock. He has not completed the osteotomy.
Correct.
So there is a sufficient bone stock.
Yes.
So if you complete the osteotomy and try to place your blade inside, that proximal fragment can break into pieces. Because there will be no stock of bone. Because they have made the osteotomy already.
Yes. So before we complete the osteotomy,
You have to put your blade inside so that you'll have a sufficient bone stock to support the thrust that you give it while hammering the blade inside.
No, it cannot be long, yeah. It can generally I put 80 here. It will be long slightly. What is the show? Yeah, slightly. We will change it on. I put 80 or 75 here. But to me it looked that maybe magnification is more.
I think that should be.
Show? Yeah, okay. We'll change it later on to 80.
So that's the screw which has been put there at the top. Can you see that?
Yes, sir.
Maybe a slightly longer one. We can change it at later on.
Once the plate is inside.
Yeah, once the plate is inside, right, then we can change it to a lesser one.
अभी भी डाल दें क्या? अभी डाल दें अभी ले लो.
Plate. No, you put the cannulated. No, you put that right inside. Right inside and remove that screw.
Cannulated.
Yes, right. Put that right there. Easy.
You know? Come on side.
Hello.
Break something. Give me 80 subcontractor. I mean, what is that? 80. This depends on the length of the or how many years you found. This I am telling you. I never got 85 here. It is looking like 85. But 83 is already these are size और measurements maybe faulty. बाहर कहाँ चली गई?
इसको थोड़ा सा बाद में देखेंगे. So that this screw
दिख नहीं रही हमारे को इमेज के अंदर. Yes. तो clear is outside. It's okay.
we need to remove it.
So take the plate in your hand. Some discrepancy can still be there of angles.
Now we are ready to seat the blade inside. Okay?
Yes, sir.
यहाँ पर लगाओ टेंशन. यहाँ ब्रेक लगाओ सर. यहाँ ब्रेक लगाओ. इसको निकालो.
She is meticulously placing the levers, bone levers.
आराम से.
Now we are trying.
हैमर लगा लो.
Now we are trying to take the chisel out and put the blade inside. Okay?
Be gentle. शॉर्ट में से बंद करने की कोशिश करती है. एक हमर यहाँ लगाओ. My entry point is not.
Very slowly, yeah. Now the chisel is out. Yeah, and the plate is out. Okay? As you see,
it should go 4 screws distally.
Yeah, the 4 screws distally.
It should go gently.
So slowly and gently the plate will move inside.
दिखाओ. Bring like this. Just. Is going up slightly? No.
Slightly going.
Slightly up, no?
Slightly going up.
Yeah. Now you can hammer it out slightly.
Hammer it out.
It's slotted hammer. So you can keep on doing correction till you are short of 1 centimeter at the end. Slotted hammer.
Got the point?
It is here.
See, the entry point and the direction of the blade
Yeah.
Yes, sir.
can be adjusted till you are 1 centimeter short of the subchondral bone.
Okay.
Sometimes the blade can take a superior direction.
Okay.
So we can adjust it correctly. Okay? Now you see the direction of the blade going inside?
Yes. Now, just one thing more. Listen, you should also check it your lateral view. The blade may go in wrong direction still. Okay?
Yes, sir.
So AP view is okay. Now we are checking the lateral view
Yeah.
to get a correct direction of the blade.
You have to be very
Now,
careful because there is a short motion already. I have not broken the medial cortex purposely. You understand?
Don't break
Put
medial
your
cortex.
Put your hand here.
Now one has to be very careful in taking a lateral view because we have already made an osteotomy.
Sure.
Yes.
Okay?
It's good. It's good.
See that's the
Good. And we remove the screw
see
later
that's
on.
the lateral view what we have taken,
Yeah.
Okay.
and it's in good position.
How
Okay?
Yes.
Please.
So we have to be extremely careful while putting the leg into figure of 4 position. Okay?
So there is something wrong. Follow it.
That's what you were mentioning earlier, you know.
Impact though? एक थोड़ा सा और डालने दो हैमर
So we are trying to seat the chisel, seat the blade inside.
See?
Sure. Can you see now, Harish?
Yes, sir.
Yeah. The blade is progressing inside.
Yes.
Now we are removing the insertion handle,
bone holding forceps.
removing the insertion handle and trying to impact the blade.
Yes.
Okay? And finally, after making the osteotomy, the shaft will be lateralized to the blade. Okay?
So the medial cortex will be
Yeah, lateralized to the blade. Medial cortex is not broken still.
be broken after the blade is
Exactly. So that we have a sufficient bone stock and the osteotomy will not crack in a haphazard direction.
Yes.
Now I am completing the osteotomy.
Now he is complete.
And you can see the angle still. Before insertion, you can see the angle. बाहर लाओ जरा. बस दिखाओ. You see the plate is making an angle of 20 degree. Okay?
Yes, sir.
The plate is making an angle of 20 degree equivalent to the
Going
bend.
away from the bone.
Yeah. So I will remove it later. Let me first complete the osteotomy of the medial cortex.
Okay.
Because otherwise saw and plate will come on the way.
So the screw looks little anterior. The anterior.
We will remove it.
This screw purpose is to hold that fragment so that
It looks like it's staying.
No, it is covered by 3 millimeter of cartilage. What you see is bone. You are not seeing the article cartilage. That is forming the joint. So that is 3 from this side and 3 from other side. The screw is not in the joint. Okay? We will remove it.
the purpose of the screw was to hold that head in position so that when we are banging the plate inside it will not topple up. Got it? Harish?
Nobody saw that.
Hello? Yeah.
Yes.
Yeah.
So always complete your osteotomy first on the inferior side.
Okay? The osteotomy will be completed first on the inferior side. Okay?
Okay.
The lower the distal limb of the osteotomy will be completed first.
Just show.
Release it for
Yeah, I will come back to you.
It's completed now. Show. It is a Y osteotomy, okay?
So it has become a Y osteotomy. The distal limb is completed. Okay?
Yes.
Yeah. Now we are trying to take the proximal limb off. The osteotomy, the 2 limbs of the osteotomy is meeting almost about a centimeter in front of the lesser trochanter.
I'm taking later.
Can you see that?
Absolutely.
Yeah.
Of the how?
Sure. That's the proximal limb.
Yes.
Now the osteotomy of the proximal limb is getting completed.
It's complete. It's almost like an extended Y osteotomy.
Yeah, extended Y osteotomy. With a shorter
No, it is not extended Y. Extended osteotomy go along the canal.
It has not gone through the ear. It's a shorter limb of the Y osteotomy. Now the proximal limb is done, the wedge is being removed. Local body, కనబడదు.
मसल अटैच है तो इसको प्रॉपर से पकड़ के निकालो
Hold it.
एंड मुझे वो दे.
So we are trying to remove that wedge. Can you see that?
Yes.
The inside of the osteotomy is still attached to the muscle. The lower is also still attached to the muscle. So the periosteum has not been completely stripped. Yeah. He is trying to just separate the muscle from that wedge. Okay. డ్రై పెట్టాలి డ్రై పెడితే అది అవుతుంది ఇక్కడ డ్రై
గుడ్ పెరియోస్టమ్ 3.5 వరకు not problem.
So the wedge is being taken out. Okay. Periosteum is really thick here. Muscle attachment is really thick. Finally, we got the wedge out.
Now we can make use of this graft later on. If there's some shortcoming, we can use this graft, this bone as a graft. Now show. Yeah. Good osteotomy. Okay. Then we make it here in the angle, but angle is not that much. We can see from laterally, and we have opened it. We have adducted the distal segment, femur. We have adducted this segment. Now you correct the rotation.
Now we saw the osteotomy. Yeah. Now
like this. Okay.
Now the rotation is being corrected. Now the distal limb of the shaft of the femur is shaft of the femur is being brought to the plate. Okay. That's finally the seating will be done.
और इससे छोटा right angle.
We did not bang the chisel inside, bang the plate inside. Okay, completely. For the reason that there may be some. Finally, when we are banging inside completely, there could be some cracks.
Now somebody
at the proximal fragment. Yeah. Now they are moving the limb. You see.
Last moment, some complication will occur. So you be careful. Now we have to abduct it. Yes.
Now the distal fragment must come to the plate. So we are abducting the limb. Abduct it. We are abducting and closing the wedge.
Yeah. Show. It is closed.
You see that?
It is buttressing the factor side. It is buttressing the factor side. You see it? This is buttressing the factor side or not? There is no answer from the audience. I'm sorry for that.
So your voice was little low.
No. See,
my voice is quite high.
The osteotomy side, now the distal fragment, the Y osteotomy side is buttressing the fracture also. Can you see that on the CM pictures?
Yes.
Yeah.
I've given a very small incision. Given a very small incision, you see.
The fracture side is almost completely
I want
compressed.
to lateralize it also. If you want, I can lateralize. If you want, I can compress. So I will compress this osteotomy and will insert the last screw. Okay. Leave it drill.
So in the plate we drill more inside now?
Pardon? I'll put little later.
Yes.
So now, the distal hole of the distal hole of the blade plate, okay, will be fixed to the shaft, so that the shaft will be completely lateralized, okay, to the plate.
Should I show you lateralization? अभी छोटी प्लेट छोटी है इंपैक्टर दो इंपैक्टर जाते हैं अभी देखो दिमाग कहाँ जा रहा है इंपैक्टर दो
One lever put one lever.
So I have to be very careful, Harish and people.
Harish,
Yes, sir.
now the plate is being impacted inside.
देखो बस अब ज़्यादा नहीं करूँगा because it will be medialized, okay?
Okay. You see that?
See the direction.
See the direction of the chisel and the direction of the osteotomy, and also the plate.
Yes,
Yeah, the plate is parallel to the shaft
So
now.
I told you that I need a plate which is 85. It is 80.
So we are little short of the length.
It is not very short. It is 5.
It's about 5 to 10 mm short than the expected length. Okay?
अभी है
It is still driven inside, right?
It is driven. It is driven inside and then inside.
अब हो गया?
The elbow of the plate is not inside to become the...
Yeah. Elbow of the plate with a little bit just away from the trochanter.
I'm keeping it away.
Sitting on the trochanter plate.
Yes.
Is it sitting on the trochanter plate?
No, it is not sitting on the trochanter plate. It's sitting just away from the trochanter plate.
So
Cutting those.
Huh?
Drill though.
There's a lot of still some space between the lateral cortex and the plate.
Yeah. We are not fixed the plate.
Then I will answer your question. I will answer your question. Don't worry.
Yes, sir.
You don't put these finalities, you see, are not so simple. And I am demonstrating, talking, doing everything. Okay? Drill though. Drill.
Now the plate is being fixed to the distal fragment.
क्या किया ये? चलिए ये. यार पकड़ो इसको ना. Sister shouldn't fix it यार. पकड़ो इसको. Can be holding the plate also. Something can break unless you put two support.
So the most.
Yeah, very good girl.
The most distal hole in the plate is being fixed to the bone. Okay? To get the distal fragment inside.
38 4.5. Drill is not good.
Can you see that now, Harish?
Yes, sir.
See the CM image? Okay.
Harish तो मजे ले रहा.
Next to calculate the distal fragment.
Yeah. That like the distal fragment.
Which is not good.
Not holding the bone holding process, sir?
No, that is unbalanced.
That disrupts everything.
That will kill everything.
Can you observe that he is not holding the distal fragment with any bone holding forceps also?
Yes, sir. We're just discussing about that.
Yeah, he's just holding with his hand and drilling it. Just putting the bone holding forceps will disrupt the biology.
I'm not lateralizing it. The reason being, the buttoning effect will be lost. Very good girl. Lateralize will be when you put the first screw.
Yeah, now he is trying to fix the distal screw and that will get the fragment onto the plate, the distal shaft onto the plate.
So plate is now you see extra peritone here, extra peritone.
You see that now? Now the plate is secured onto the shaft, and it is extra periosteal and also submuscular. Okay? Yeah, can you show that?
See, it's totally closed. You give me one bone holding forceps. Look.
Just hold and lift the plate.
Lift the bone against the plate. Yeah.
See the technique, can you see that? He is holding the plate with the bone holding forceps and trying to lift the bone up.
Indirect reduction of the fallen fragment.
So it is the indirect reduction of the distal fragment which goes posteriorly down.
It falls.
So he is not putting the bone holding forceps onto the bone. The bone holding forceps is fixed onto the plate. Now the plate is fixed into the distal hole of the plate is fixed onto the bone. So if we rise the plate along with the bone holding forceps, the falling the posterior displacement of the distal fragment will be prevented. Okay. Can you see that? He is holding the bone holding forceps. He is holding the plate. So sort of an indirect reduction with the plate assisted reduction.
इसको पास में फैन हो गया है ना, इस पीछे है नहीं, नीचे खोल नहीं कर रहा ना, थोड़ा खोल कर रहा है, इसको खोल नहीं, ना खोल नहीं, इसको रिमूव ही हो गया,
It's already reduced nicely.
I can feel the finger, you can feel with your finger,
There's nothing there, you can just put the screws on here.
Yes, relax properly, relax properly.
What is the screw size, sir?
It should be one by one.
So other screws are being sequentially introduced now. Okay.
Rotation. Sure. Everyone we should ask you. Because this plate is more prominent. Plate will should not be laterally posterior. Sister, can you change the bit? You change? Oh, that is again dirty. Yeah. That's 38. I don't measure generally. I do. Because 38. 36. 36 may be short.
So for a beginner, the screws must be measured and then applied. Okay? Since an experienced hand is doing it. Sure. Okay.
So as I am inserting the screws, the osteotomy side is getting compressed. But it should be one by one. You see here it is closed totally. What you see is actually closed.
The osteotomy side, what you see on the X-ray, what you see here, really it is closed up now completely.
Yeah. The view.
Yeah. There is a nice compression at the fracture side too. And the Y-limb is also buttressing the fracture.
What is buttress?
Can you see that osteotomy?
Yeah, the osteotomy side.
Yeah, is buttressing the fracture. Can you see that? Yeah. Fracture is also getting compressed and also buttressed. So 2 in 1. So now we are
buttressing the fracture.
Yeah, correct. We are completing we are filling the holes, the other holes. Right. We need that screw. Huh? We need that screw. The top screw.
Change 5 minutes or less.
Not be needed, it's nicely compressed.
Let me use slightly. Or you put 2 washer over it.
So that you get the length.
Right. Now let it rest. Now see, show. Yeah, this come. Okay.
Why does it? How is it? You see that everything is compressed nicely?
Yes.
We got good angulation about 130. The next shaft angle is about 130. The principle of shearing forces into compression forces is being maintained.
Now divide this graph.
One minute. Image it. Yeah. Can you see the image now? Now? Yeah. See the angle, see the seating of the blade, see the osteotomy. Okay. Pardon me? Yeah, proximal screw will be changed to now. We're just introducing the last screw in the plate. And the most proximal one.
This one
Yeah. Yeah, that is being done now.
Now show. Now start this close.
Now see that the osteotomy is closed now. We have done with all these screws.
Yes.
You see that?
Yes.
We are done with all these screws.
Now show.
Osteotomy is closed.
And see the alignment of the axis.
And see the alignment.
Narrow and everything.
See the alignment of the neck shaft.
This is third segment you need to change. Probably it has gone wrong direction. Third screw you change and you close the wound. You see, and you show them. This is what the plate is. Plate is extra.
You come this side, or you can sit.
And no blood is required in the position of plate. Graph the logo. So I am putting this graph here.
We will tell you. Now we are placing that weight at the elbow of the plate.
Yeah.
See that? Yeah.
Now, see, this is vastus latalis. Whole of it is intact. We don't need to stitch it. It is for okay. You just see the tensor fascial lata, and you see here the plate is on the extraperiosteal. No muscle is lifted. You see?
Yes, sir.
And in the elbow we have put the graph. This.
Yes.
And you see here now. The graph you see like an arch.
Can we see the lateral view, sir?
Yeah, please show. Be careful.
Yes, sir.
Wait, come on, Let's not show.
The bone graft has been
You like it, sir? Is it okay? Head दिखाओ head. No, head will see when you go to India. Okay? We'll remove the screw.
We're going
We are going to remove that screw.
We apologize from you, sir.
Okay.
So there is no need of the screw, right?
Yeah, don't need the screw right now.
Yes. So its purpose is out.
Yes, there is no need of this screw. It will make it sac and it will fill with bone. Become close it. Thank you very much.
So that
put drain, sir. Sir. Drain. Yes, you put drain.
So that's the technique that we have finished now. Okay? Harish? Yeah. Professor will be coming out.
That's a nice demonstration.
Yeah. Why don't you give a big hand to him? Why don't you give all of you give a big hand to him?
Pardon, sir?
Why don't you all give a big hand to him?
Yes, yes.
Yeah, clap round. Yeah, good. Thank you. You all thank you.
Thank you, sir. Thank you,
We all thank you
Thanks
from
to
here.
all the OT staff and the anesthesiologists.
Thank you. Just wait there. Professor will come.
Yes, sir.
And he will answer his questions.
Thank you, sister.
Yes,
Very nice. And thank you, Professor Puni, and this boy. Thank you very much. Thank you all. Thank you. Very good.
Okay, sir. Okay,
Very
thank you.
nice camera. Very nice camera.
You can speak with them. What are the questions?
I'm coming out. You can blast me now. Okay. अभी करते हैं ब्लड आ गया ना एरो से see whenever you use the saw vibrates.
Extravascular coagulation. The trauma, there is vascular interruption, there is disruption of the retinaculae which supply the blood to the femoral head. That leads to decreased blood flow. Intravascular coagulation as in sickle cell anemia, dysplasias, hypercoagulable states like polycythemia vera, these lead to the block in the microvasculature and then in turn lead to the decreased blood supply. On the other hand, the alcohol and corticosteroids, we do not know what exactly is the mechanism, but normally they lead to increased lipidemia, and corticosteroids, on the other hand, they also lead to decreased healing potential of the insert, leading to the fat emboli which block the vessels and thereby causing thrombotic occlusion. And extravascular compressions as in deposition disorders like Gaucher's reactivation, the edema, which compresses the intra-osseous microvasculature and leads to compression. The end result is decreased blood flow and ischemia ensues and overacute osteotic necrosis and then collapse. The compartments, like it almost mimics like a compartment syndrome of the femoral head. So this is a Starling tube. Whenever there is a rigid tube and you are increasing the pressure, then the thin wall tube is going through a rigid cylinder. The blood circuit, the kink tube, the small kink tube gets blocked. Similarly, in the avascular necrosis of it, it's a closed space. Whenever the pressure increases, the lipid deposition and adipocyte hypertrophy in the marrow are the two predominant clinical conditions which cause intraosseous extravascular pressure, which reduces the circulation. And normally the corollary of this is whenever you do a cold decompression without any stem cell testing, the pain relief is immediate, almost immediate. The very next day the patient has some relief in pain that could be relieved because of the cold decompression reduces the intraosseous pressure. Coming to the risk factors, as I already mentioned, there is lack of cohort and RCTs to pinpoint exactly what is the cause. Mainly most of the evidence is based on the case control studies, and even today most of the cases are usually idiopathic where we don't find an identifiable reason. The known risk factors: trauma, neck fractures, dislocations, iotrogenic trauma whenever we are operating, if we are going to medial and entry, or while dissecting out we are stripping out the periosteum, we are stripping out the retinaculae. These are the known causes, and sometimes like we were told that valgus reduction is a good reduction whenever it comes to neck or femur fractures. Although the valgus reduction leads to non-union and implant failure, valgus reduction does put a lot of pressure on the retinaculae and leads to decrease in the blood supply. The role of capsulotomy in acute trauma is controversial. In children, it's well known that we do a capsulotomy to relieve the extravascular pressure on the retinacular vessels. However, in adults, it's not documented, it is still controversial. The steroids, the role is multifactorial. It increases the adipocytes, it increases the intravascular lipids, it leads to hypercoagulable state. However, what exactly causes is not known, because many of the patients are on steroids and many of them abuse alcohol, but only few land up in avascular necrosis. Coming to blood dysplasias, the sickle cell disease, polycythemia vera, hemophilia. Hemophilia, it is not a hypercoagulable thing, but repeated bleeds block the intravascular, intraosseous vasculature, leading to ischemia. Coming to the miscellaneous causes, there is Gaucher's disease, Casen's disease, that is pressure osteonecrosis, HIV. Once again, the mechanism is not on whether the disease in itself causes it or the treatment of it causes it. SLE, pregnancy, smoking, gout, inflammatory bowel disease, and tumors. Normally, it's mostly likely to be a combination of factors, including genetic susceptibility, dosage, underlying condition, and the treatment of it, which which leads to avascular necrosis. Coming to the clinical presentation, initially it is very vague. Patients come with a problem of occasional limb or occasional pain or groin pain. In the later stages, there will be restricted mobility. Sometimes if it is accompanied with by synovitis, there will be initial restricted mobility. There will be limb, and especially if the patient is post-COVID, always suspect of avian. Coming to the investigation part of it, we need to understand the classification before we go to the investigation part. The earliest classification was Fickett and Arley classification. Normally it is divided into pre-collapse and the post-collapse or early collapse stage. So stage 1, stage 0 is preclinical where there are symptoms but there is nothing diagnostic either by MRI or by radiography. In pre-radiographic, that means in the X-ray the changes are not there, but if you do MRI at this stage, you will still be able to identify a lesion. Pre-collapse stage can be identified on X-ray, but you need to have a look with very close eyes because the changes are very subtle, especially in the initial stages. Early collapse stage, crescent sign, subtle sequestrum is there, but still the joint space is still normal. And coming to the late stage osteoarthritis, you don't need any other investigation, you can just do away with the X-ray. Steenberg modified the Fickett and Arley classification. 0 to 3 were retained. Stage 4 there was flattening. Stage 5 there is joint narrowing. And stage 6 is advanced degenerative changes. These stages were further divided into mild, moderate, and severe. And the Japanese committee also included certain changes into the classification system where the involvement is whether it's in the weight-bearing zone, whether the lesion is in central, or the degree of involvement, like 15 to 20%, 30%, more than 30%. So the ARPO classification, it is for osseous circulation, osseous organization. They classified it inculcating the Fickett and Arley, the Steenberg, and the Japanese Investigative Committee for Osteonecrosis classification. So the stage 0 remains the same. Stage 1, X-ray and CT in normal health, at least one of the mention is positive. X-ray will have some changes, but MRI will have some changes on the MRI. On the X-ray in stage 2, it's the same. But they have subclassified it. On quantification, one is the area of involvement and the surface which is affected, whether it is in the medial portion or whether it's involving the 2/3 or whether it is involving the whole weight-bearing lobe. So what we need to observe is the stage 1 and 2. There are no changes which are picked up very concretely on X-ray. So these two things you need to be very careful. So coming to the avascular necrosis, what changes do we see on the femoral head? So normally there are scattered cysts, the patchy sclerosis, and subcortical lucency. Many a times in a busy OPD, we are bound to miss this unless we pay complete attention to the reading of X-ray. And sometimes only the AP view, we advise for a pelvis AP view. Many of the changes could be missed on a pelvis AP view. So lateral view also becomes involved. Once it is degenerated, anyone can recognize the findings on the X-ray. But in the initial stage 2, it is important to pick up the changes on the X-ray. So further investigations, isotope label scan, scintigraphy is there. Normally it shows a cold spot surrounded by disease activity, area of activity, but normally we do not do scintigraphy on a routine basis. We go for MRI. So MRI is considered the gold standard. It's highly sensitive and highly specific, and it is the investigation of choice whenever we are going to investigate the early changes in AVL. So what to see on an MRI? Normally the T1 and T2 weighted images. T1 you usually see a single line, that is the degenerative front, and in T2 the degenerative front accompanied with the new bone formation, the inflammatory granulation tissue, that will be seen as a double line sign. And in the later stages you'll be able to see the geographical ulcers, geographical areas. So this is the T1 weighted image where you see only a single line. single line on the thing. This is almost collapsed. This is flattened head, but just for the sake of representation. In T2, normally there is a black line surrounded by a white this thing, which means that the inflammatory carnation issue is there. This is on MRI T1 and T2. So COVID and avian, is there a role? We are seeing a lot of cases, especially those patients who have been treated in ICU with steroids, life-saving steroids. We don't know yet whether it is directly the COVID which caused the avian or the treatment of COVID which caused the avian, but the number of cases of avian are on the rise post-COVID. So coming to one of the commonest differential diagnosis of avian of hip is transient osteoporosis of hip. Normally it is a self-limiting disorder. The MRI will help you to do the differential diagnosis where there will be complete edema, including involving the proximal femur. Normally it's a middle-aged female post-pregnancy who comes with a complete hip pain. Normally rest anti-inflammatory will subside, will take care of the situation. So coming to the take-home message, you'll have to have a high index of suspicion whenever a patient is coming with hip pain or sometimes even with knee pain or anterior thigh pain. So you'll have to have a high index of suspicion, examine the patient clinically, and you'll have to read the radiographs if at all you're ordering for one, because that is usually the first line of investigation. So with patience and diligence, you have a very low threshold for ordering an MRI whenever you are suspecting an avian. If you are suspecting an avian, then better get an MRI, let it be normal, it's fine. But if at all you are picking up an MRI in stage 1 or 2, disease in stage 1 or 2, you can still save the native hip. And whenever there is a history of COVID disorder in the patient, it should raise a red flag, you should get alert and preferably get an MRI earlier than you do for a normal patient. Thank you.
Good afternoon. Hope everyone is awake. Avascular necrosis is like a lottery. If you have treated the patient and if he got better, he will be the best doctor. Most of them do not get better. Okay. So probably with that note, there are a lot of treatment strategies which has been practiced in avascular necrosis. None of them have got a strong basic clinical and theoretical evidence. And each one of us have got our own theories on AVN and our own practical tips to treat this AVN. So based on these facts, I have gone through the literature and our own experience of treating AVN. I based some facts into a package and trying to place it in front of you. So first of all, you should know what is the magnitude of this avascular necrosis. Often we pity these patients because they come from a very productive age, economically, sexually, socially, everything very productive. They fall in a very young population with a high degree of disability. Patients progressively get down the course, have limp and difficulty in walking and difficulty in doing activities of daily living. They become dependent on their family members. Creates a sort of pity situations. In spite of repeated warning on them, warning on people, and everybody knows what alcohol causes. Still, the alcoholism persists. Even the government also promotes alcoholism. So it has become a way. Steroids, most probably the rural parts of this country, steroids still play a role, especially in arthritis, rheumatoid arthritis. Every patient is on a steroid. Many patients are on steroids. All of you have seen patients who have taken a lot of steroids, they come to you. So still steroid is being misused. Even be it is a COVID, be it is a rheumatoid, whatever it is, steroid is the mantra, especially in the rural area of this. Diabetes and all of gout, all metabolic diseases are on the rise. The avian also will be on the rise. COVID also joined the bandwagon. So everything has put a magnitude on this issue. Most of them get into a doctors who may not be aware of what is AVN. The simple hip pain can be given some analgesic and sent home, because they may not get an access to a good orthopedic surgeon who can make a diagnosis, because for a diagnosis MRI is necessary. Most of them cannot afford an MRI. So diagnose of AVN, stands and sleeps in the patient, slowly creeps in. By the time he reaches you, he will be in stage 3, stage 4. Most of our experience is like that. 85% to 90%, even if you get stage 1 and 2, irrespective of the treatment, they progress. A 10 years follow-up, 12 years follow-up, they progress to continuous arthritis. And in some of these studies, so all of the indications for total hip arthroplasty, 10% of these patients have avascular necrosis. The rest 90% is other indications. So that's the problem that we have. So what do you want to do, keeping all these facts in mind? So what is our aim of treating these patients? So we always aim at treating these patients so that the probable total hip arthroplasty can be delayed. And most of them cannot afford it to total hip arthroplasty also. So finally they end up in total hip arthroplasty. Whatever disease treatment strategy you prescribe or you practice is to delay total hip arthroplasty. At the same time, give the patient as much as joint motion as possible. We may not be 100% successful. A 90-degree flexion, patient is able to sit comfortably in a chair, is able to sit in a car, is able to travel in a train. Probably that is the aim what we are looking at it. Most of us may not cure an avascular necrosis. So what are the various modalities available for us? There are conservative and operative. Any orthopedic surgery has got two modes of treatment. Either you do surgery or don't do surgery. So these are the two aspects. There are so many modalities available for you. I'm not going to discuss the last four aspects, which all of you know. Probably I'm going to discuss the first aspect, the pharmacological aspect of this. The surgical modalities, plenty of them to choose. Plenty of them to choose. Match, core decompression, bone grafting, VMAC, bone morphogenic protein, stem cells. All of them have come together now. Intralesional bisphosphonates. Could be a femoral osteoarthritis also could be an answer to some of the patients. Hemi replacement. And last but not least, we have to consider in some patients the last one also as an option. So why should we use the bisphosphonates? Bisphosphonates have been tried and time tested medication for avascular necrosis. The basic mechanism of action is Frankel pathway. It inhibits the osteoclast. So by that, what happens? The resorption of necrotic bone is slowed down. So once the resorption is slowed down, the formation and remodeling of the bone also becomes better. So by slowing down the resorption, the normalization of the remodeling, bisphosphonates are going to prevent the collapse. Two drugs have been studied very extensively, alendronate and zoledronic acid. Oral therapy with alendronate, zoledronic acid with the parenteral therapy. Alendronate for a long-term management, zoledronic acid for the initial management. Zoledronic acid is said to reduce the pain of the patients, whereas alendronate sodium tries to prevent the radiological progression. So long-term alendronate, short-term or an immediate relief zoledronic acid can be used. So there are several studies, several studies. There are no long-term studies, 2-year study, 4-year study, 5-year study. Only one study I found by Agarwal having 10 years follow-up. He has got a good follow-up of 10 years, 53 hips. So by giving this alendronate sodium, there is a definite benefit in early stages that delays DHA. Whatever happens, there is a collapse of about 30% of patients at the end of 10 years. The average onset of collapse, they are delayed total hip replacement probably by about 5 years by giving oral bisphosphonates in early stages. I'm not talking about stage 3 and 4. Short-term studies, plenty of them available. You have got two groups, randomized studies, one having alendronate, other having no medications. So in the group 2, without medications, 19 out of 25 hips went on to collapse. Anyhow, the duration is around 24 months. So probably the first one We don't have much studies about long-term follow-up. Only we have this study, 4 years, 395 hips, 53 hips in 10 years follow-up. Probably this will say that finally the patients will end up in a hip arthroplasty. Okay, so what does bisphosphonates do? Why do you want to have bisphosphonates? Definitely the pain will be reduced in patients with bisphosphonates. I have seen definitely patients will have decreased pain. Probably it's a time buying strategy for hip arthroplasty. The regimens, so many regimens are being followed. You have 70 milligrams per week for 3 months, 35 milligrams twice weekly for 3 months. The intraosseous infusion of zoledronic acid is also being followed. And parenteral, this is what I am talking about, is a parenteral administration. I am not talking about intraosseous. It's a parenteral administration of 5 milligram infusion once a year for 3 years. So all this said to have delayed a hip arthroplasty. So with this regimen in mind, a lot of studies also has been done with intralesion of bisphosphonates. Few studies, noteworthy study is one which is published in 2020. Stage 1, the Harris hip score improved from 82 to 97. They have 2 years follow-up. Stage 2 increased from 72 to 91. So quite a significant improvement Harris hip score in 2 years. So of late, the trending one may be intralesion of bisphosphonates, intralesion of zoledronic acid. What is the strategy here? Do a microcore decompression and give a intralesion of zoledronic acid. Probably trending is coming up. A lot of studies have to come up to prove this intralesion of zoledronic acid will have a say in the management of early stages of avascular necrosis. So what is the final buzz? Everybody can practice whatever they want because we don't have a standard regimen of giving bisphosphonates. You can give for 3 months, you can give for 6 months, you can give for 1 year, whatever it is. But finally, it progresses, it retards the progression of the early disease. Probably if you catch the hips in stage 1 and stage 2, the biggest benefit is the last one. So far, all the studies have not detected any adverse effects, excepting fever and those things. There are no other standard or more adverse effects with this zoledronic acid or bisphosphonates. So that is the biggest advantage with these bisphosphonates. Okay, we're going to a surgical strategy. What does core decompression do? Core decompression reduces pressure, enhances new bone formation, stimulates blood vessels, and retards the progression of the disease. So that is the basic funda of doing a core decompression. Preferably, what is an ideal situation for you? If you do a core decompression in an early collapse with a small lesion which is less than 15% of involvement, very noteworthy is a medial-sided avascular necrosis will have a very good result with core decompression. Not secondary causes, idiopathic causes also will have a good outcome with respect to core decompression. See, studies also have been done, you see. Core decompression only, in early stages, 65% result. You add some more pickle into core decompression, autologous bone marrow, bone grafts, the result increases 74, 81%. All these are studies, recent studies which have got a good evidence to show that the core decompression can increase the survival rate of the hip. So add some pickle, get a bone graft into it. Okay? The bone graft basically to prevent the collapse. And simultaneously it can stimulate the repair by giving the osteocytes in position. The important is it lays a foundation for a new bone so that the collapse can be prevented. So what sort of bone graft you want to put? You want to put a autologous bone graft, allogenic bone graft, vascular bone graft, or a standard non-vascular bone grafts. Autologous grafts, they have a best osteogenic, osteoinductive, they don't have any immune rejection. Whereas allogenic will have immune rejection. So that's the one, that's the disease transmission. Sometimes the enough autologous grafts may not be available in patient to put it inside. The word coming up very frequently now in all meetings that we attend, regenerative therapy. Okay, so the basic funda of regenerative therapy is you give some bone marrow transmission that it produces not only the bone, it produces other growth factors, and also angioblastic activity will be stimulated, bone regeneration can happen. So this is the basic strategy of using regenerative therapy. Standard core decompression, percutaneous drill. Two things are available. Standard core decompression, removing a big core using your standard core drills. They have come with the percutaneous drilling where we can do 2 to 3 passes, about 3.5 to 4 mm pitch through the core area. The advantage is that in a standard core decompression, there is a chance for you to violate the articular cartilage. And also, some studies have shown a subtrochanteric fracture can happen with a standard core decompression. All this can be prevented with multiple coring. Lot of studies with percutaneous drilling. Picket 1 79% success rate, Picket 2 77%. But the size of the lesion is the important, less than 25% in Picket 2. 33 hips, both produces the same result. They have done 2 comparative study, conventional versus multiple drilling. Both produces same result, but multiple drilling is less important. SAT spice to core decompression, put bone marrow, bone morphogenic proteins. Of course, prohibitively costly in our country. So these are the strategies for adding bone marrow, for adding bone morphogenic protein. With bone grafts, what are the studies that we have? Human BMP, somebody has had human BMP with allogenic antigen extracted out of lysovicular autograft. 17 hips increased. Stage 2A, success rate is 93%. Similarly, adding BMP to bone graft with or without human recombinant improved in stage R2. So the varied results from varied studies. BMAC is coming into very routine practice now. The purpose of having the bone marrow aspirate, a bone marrow aspirate concentrate is there is insufficient supply of osteoprogenitor cells in some patients because of the metabolic disease or things like that. So this is supposed to give lot of progenitor cells. Okay, but it is proposed as adjuvant therapy in patients with CD and indicated only in early stages. So what is the advantage of BMAC? Minimally invasive, instead of obtaining a big fibular autograft or fibular graft allograft. It is minimally invasive, no immune reactions. The important is this area of interest is directly being targeted. But the limitation is it is not useful in incontinence. So don't go for 3-4 into 3-4, Picket 3-4 to a BMAC therapy. Stem cells are coming to practice. It improves microcirculation, gives you osteoprogenitor cells, growth factors, insulin growth factors, all those come along with the stem cells. So all this creates overall a favorable environment for the healing of the AV. Not much studies have been done on this arthroscopic decompression. Now there are a lot of people proposing arthroscopic decompression because early associated pathologies also can be addressed with avascular necrosis. It can exactly locate the area of the involvement. That is the one. But again, helpful in the earlier stages. But there is a weak literature support for this. So coming to osteotomy, which has been practiced from 1978. So what is an ideal patient? Ideal patient less than 40 with a BMI of less than 25. You should have a mobile hip, preferably a small lesion, should not have any developing cause. It should be a primary cause must be obviated, steroids must be withdrawn, alcohol must be gone. Then only this can happen. Morning, cobular angle we are telling 200 degree, less than 200 degree. Patient should have minimum collapse. Why 40? Now all studies have conveniently proved that 40 years is the cutoff limit for taking any conservative management. After 40 years, it's highly likely that the patient will end up in a hip arthroplasty. So try and avoid conservative measures after the age of 40. Age of 40 is best because secondary collapse in the sense that the fragment that you have rotated, the good fragment that you have rotated underneath the acetabulum might collapse. Very high chance of secondary collapse. Because of osteoporosis, after 40 years osteoporosis sets in, high chance of secondary collapse. So probably better avoid. So age 40 has been shown as a cutoff limit in all these patients. You also must choose a viable femoral head area. So when you take an MRI scan, you should have a good amount of viable femoral head area to rotate and bring it back. Otherwise, if you don't have a good femoral viable head area and you bring it back under the acetabulum, naturally the collapse will keep on happening. So viable femoral head area is very important. You drop from the lateral side, from the lateral edge of the necrotic area to the center. So you got this, so much of viable area here. And this can be rotated up. So an MRI can easily locate this type of lesions. So what is the site of the lesion? So that we saw about size and site is also very important in selecting a proximal femoral osteotomy. See the angle more than 240. So any angle more than 240 is an ideal. This is an MRI. So you take in coronal sagittal vein and get these angles. The K angle. Any K angle more than 240 is good for a conservative or a preserving femoral osteotomy. B lesions. You see the lesions which are in the weight bearing area, not good. Lesions which are more medially situated. You have got a good viable bone. So you can rotate the femoral head and get them. So these are the site and size of the lesion is also important. Trochanteric rotation osteotomy, classically described by Sujioka, 1978, has got best results under his hands. I don't know, Professor Mago will be able to put much light on this. The studies have come from Japan and Korea. They have got 100% success rate. This is not replicated in any other study. I don't know, Sir Professor Mago has to say that. Basically, we have got osteotomy lines, 2 osteotomy lines, and rotate this anteriorly so that the viable area comes under it. So I will show you some couple of cases that we have done here. A 42 years idiopathic AVN. He had a sectoral restriction of movements. Right is involved more than left. Cannot afford a total hip arthroplasty. Forced to give him a conservative modality of surgery, conservative surgeries. Did a bilateral core decompression, put him on oral calcium, vitamin D, lot of bisphosphonates for 16 weeks, alronate. This is the thing that we have followed. At 8 months follow-up, he has got pain-free motions, terminal restriction of motion. Even though radiograph shows an inadequate or unacceptable result, but patients will have good pain relief. That's the one. The radiography and the clinical pictures after conservative management usually do not correlate. So don't go by the radiography above. Another patient of 28 years, bilateral stage 2. Okay. Right side we did core decompression and gave him intralesional zoledronic acid. Right side, left side, we did a non-muscularized fibular graft for him. So that's the patient that I saw yesterday. He's got a good amount of hip abduction, good amount of hip rotations, even though X-rays look not good. So this is at the age of 8 months. At the end of 8 months follow-up, patient is quite happy. He doesn't have full range of movements, but he has got functional range of movements. So mind you, 40% of avian are idiopathic, involves young population, often bilateral and disabling in 70% of cases. Not to say it presents very late to you guys. Earliest, if you pick them early, you get best result. Small lesions have a good repair capacity. Medially located lesions will do well. Associated FI, ongoing steroid therapy, all probabilities all produce significantly lower results. Thank you for your patient hearing. Sir will present his techniques.
Thank you, Vasuki. Instead of Andhra, I made it in Mysore folder because you took me to Mysore. So most of the procedures have been covered by Professor Vasuki very well. The first advice which we give to the patient, be non-weight bearing. When there is posterior dislocation of the hip, we reduce that and we say, be non-weight bearing. Whenever you come across a case of avian symptomatic, we say, walk with a walker, don't put weight. So what do those osteotomies do? We have already spoken. Bring the healthy bone under the weight-bearing dome and watch the result. The result will be yours. But we do not have final answer to avascular necrosis. Akash has very well said. I have the first slide. Yeah, doctor. Stage 1, just drilling, 11 years follow-up, complete healing. I don't know how and why. You still see the drilling lines. Yes, these are the drilling lines. These. Repeat MRI after 11 years. I think core decompression works very well in the stage of edema or at the most stage 1, Fickett-Arlett. To me, classification by Fickett-Arlett is very simple and very easy. If at all I want to see if there is subchondral fracture, so MRI I think is a useful tool. Whenever I think of rotation osteotomies, a valgus or a varus, or particularly flexion type osteotomies, so I see what is the area involved and where all the subchondral fractures are there. Subchondral fracture means it is an invitation to collapse. So here I do other types of osteotomies. So pre-collapse. So multiple smaller tracks we have said, I think they work very well, but necrotic area is not removed. So debridement is very essential to promote further osteoblastic activity. And here you see, you have to excise and remove the necrotic bone. So excision of the necrotic bone and augmentation with bone graft techniques that favors the survival of the femoral head that has suffered from AVN. And it enhances the results of osteogenesis, and same is the result with the osteotomies. I think osteotomies are far better. So what is the reverse bone grafting? So this is the area of necrotic area. So put a guide wire here, put a mill. I will demonstrate you tomorrow if I get the tools. And in this mill, there is a big graft. So this white is the dead bone. So this is from the necrotic area. And this graft is from the trochanteric area. This is live. It carries with it the mesenchymal cells. So rich plasma and all those things. So when you debride this necrotic bone, so you can reverse this graft. Put the live bone in this area and put the dead bone towards the trochanteric area. So that is what has been doing. So this is the necrotic bone. In the mill itself, this is the necrotic bone, rotated through 180 degree. So here you find This is the graft, which is with the live, and this is with the dead. And if you anticipate on MRI that collapse can occur, there is subchondral fracture, I combine it with the flexion osteotomy or a varus osteotomy. I'll show you cases, and the results are good. You have debrided the bone, you have grafted it, which are almost live grafts, and you have also rotated the dead bone out of the weight-bearing area. So that combination is beautiful. So this is just, so this is what I was asking Dr. Praveen. This is the blade loop type. So we have with this cutter type of blade, we debride the necrotic bone, and you really feel that you are working in a stony area, in a very hard bone, necrotic bone. And then I take a curate also. Spine curates are available. Then I further curate it out, and then I fill it up with the grafts, the reverse graft. So this area is filled up. This area is well filled up. So this is the reverse bone graft, and if you feel like that the bone is weak, you can take half a ply here. You further strengthen it. So this is, you see, the whole of a live graft for this patient. So pain is immediately relieved post-operatively. Good range of motion you observe. Yes, rotation has come back, which was limited earlier. And adduction and abduction, all those movements return immediately post-operatively. You see here, this patient, I did bilateral, and he came to me from Jodhpur. He was 120 kg, 120 kg weight. Still doing very well, same procedure. Reverse bone grafting, no, this is the previous patient. And he is walking. I just give him a stick to, ये कैसे चलेगा यार, वीडियो है ये, how can you make it run? This is at my clinic, and it's not working because I have put it in my other and not in my computer, so this is not working. So most valuable in treating patients with stage 1 and stage 2, core decompression, bone grafting with debridement. But I make a big window here. This is a big mill type of area. So there is a danger of fracture subtrochanteric, as Dr. Vasuki was talking. So more chances when patient is above 40. So this patient was 75, I'm showing you. See here, this patient came with pain, and I realized, which was missed, that there is a stress fracture. So actually it was painful, and we found AV on this side also. So I just put 2 screws for that. He became pain-free. But on this side, I did the reverse bone grafting, and he had fracture after 4 weeks. But the trauma was major. He was walking with a walker, he was entering the bathroom, and the frame stuck against an obstacle in the bathroom, and he had a fall on the front. He bled from the nose. So it was, though he was osteoporotic, 75, but trauma was major. But definitely this bone was also weak, what I am talking. So he had a fracture here. So he had a fracture here, subtrochanteric. And I did a blade plate, THR with this. This is uniting, of course, both sides. Now it's working very well. So that is a stress area. If you take a large bill, that causes stress fracture of the subtrochanteric bone. A minor trauma can also have a fracture. So this is good follow-up. He's doing well. Now this is very interesting, you see. Dr. Vasuki, what do you find here? There's a collapse.
You find collapse, arthritis too.
Arthritis too. He was 65.
But fracture is good united.
Yes, the fracture was good united. Osteotomy is also good united. It is published in Injury Journal 2006. What kind of function he should have?
As far as X-ray is concerned, you will have limited function.
Yeah.
Flexion and abduction will be restricted.
Abduction. His abduction is more than. Not here, I cannot comment with this. Impingement can be there. Yeah. But I tell you, there is impingement. You see this. He has excellent range of function. After 3 months, he's 65 that time. I went to his house to make this picture. This is after 10 years. This is after, I think, for 13 years. See, he's sitting on this see the charpai caught in this house. Can you expect this kind of function in this, with this type of collapse? You see, he has no limp, no pain.
His X-ray only, sir.
Sir, I am repeating it. That's why I've shown it different. So, I challenge it, sir. He is the same patient. Nobody can challenge me. I am very honest that way.
I know that.
And I am not getting anything out of it. All those people with the lender rights, they are getting something from the company, I tell you. Paper after paper, paper after paper. Now they have started injecting lender rights right into the lesion. Because early cases are failed, they don't show failure. So nature is very great. Don't challenge the God, truth. And if I am able to do, see, he can, यार उसको चला दे यार, इसको थक कर दूँ ना तो तुमने मेरा ना सारा काम खराब कर दिया. I told them यार मेरे वीडियो बहुत सारे हैं चलेंगे नहीं. There is no limp, no pain. He can squat on toes and sit cross-legged position. So no, this slide is my teacher. I have learned from so many other cases with this collapse. And my concept is that subchondral bone is very strong. It is just covered with cartilage from the bearing surface. And nature is also great. Whenever there is a collapse, it does not mean that it's like a cut with a talwar. Some cartilage is still left. That forms the convertee. But excess shows you like the way I have shown you. So if you press a ball, football, or a balloon with this bulb, so there is a collapse in X-rays, but there is still balloon area left out, so that is the cartilage. So that retains the function. So osteotomy does wonders in such cases. Whenever there is a collapse or you anticipate a collapse and you find functions have been good in your follow-up studies, I have a follow-up of this patient till death, 15 years. So do an osteotomy. Bring a healthy bone under the weight-bearing dome. These arthroplasty surgeons will leave this world, I tell you. They are making a fool. Oh, fracture neck femur. Oh, Mataji, tere ko avian ho jayega. Tu na total hip karwa le. Our entire generation is spoiled. And I ask you a question, everybody. Where it is written that stage 1 will always proceed to stage 2, stage 2 will also proceed to stage 3 always, and stage 3 will also proceed to stage 4. Why are you doing THR? Process can stop anywhere. After nature is healing, so don't be mad after arthroplasty. Be mad for biological procedures. It may fail, do THR, I am not against THR. But nature is great. Nature heals the collapsed lesion also. So do an osteotomy in such cases, and my results are quite good. An intertrochanteric osteotomy can reverse the process of necrosis. What does osteotomy say? It activates the dormant mesenchymal cells. You talked of angiosystem. It causes revascularization. And it is because of this the fracture heals and the head gets revascularized. It's a bilateral procedure. And you see the literature, everybody is talking of THR, alendronates, and nobody is talking of osteotomy since 20 years. I am giving you an example of all such cases because of my experience of osteotomy in various conditions other than avian. And now I have started making use of avian in all these things. So valgus, varus, flexion, these are the various osteotomies. Flexion, then extension, valgus type, and this too also, you see this. This is a crescent sign, type 3. Fracture neck of femur. Of course, Even after trauma is different from even after steroids. Okay, I agree with it. You see, this is good. This is 2005. This is the recent sign you see here. But this much bone is intact. So I did the valgus osteotomy in this case and debridement. See, and put a fibula here. This is a fibula. And you see it is healed. Because part of the healthy bone came under the vertebrae zone. 2013 you see. This is the fibula which is healed. And this is the intact area. And here the cartilage gets its profusion from here, 385 weeks. And this you see CT after 10 years. The subchondral bone is irregular. It might have fractured, but bearing surface is good. The congruity of the joint is good. So why not an osteotomy? Combining the procedure with an osteotomy. See this? And he can spread. Both ways. This is the corridor of my hospital, Rohtak. This goes to Barrack ward. See this? 10 years. This is 13 years. Joint is good. There are some stresses because of valgization. This is still working after 20 years also. This is the area of, and there is mild collapse. There is a fracture here. You see, this is a fracture. You agree? I have done a valgus flexion osteotomy here with reverse bone grafting. See this same patient. Well, it is healed. Live grafts, 3 years, and we did a dynamic field study, and a gadolinium study. So, you see, this was the earlier area, necrotic. And with this, the vascular zones have appeared. You see, this green one, vascularity is appearing. Well, the radiologist told me, area is healing, and this is the vascular zone. Dye is taken up. It was not taken up earlier, but after remodeling and osteotomy, 3 years follow. At 3 years, it is reversed. So this is the reversed areas. And you see here, I show you wonder. This is the area or track where I did the debridement. So as I put my chisel, you see what is happening. The grafts are lifted from this area, white arrow shows, and that defect is filled up. And what are these cells? These are all mesenchymal cells, your so-called bloody stem cells, your platelet-rich plasma, everything is here. And it will heal. It has healed. It has healed. That is the reason that reverse grafting combined with osteotomy works wonders. You get all live cells. You don't have to go to laboratory. Yes, same, even 120 kg and excellent healing. See, excellent healing. He can walk post-operatively. He came to my clinic. They felicitated me. Yes, pain is there. Pain is not there. It is healed. Full range of motion. Others, Don Bosco, very small in CM. See this girl, I put fibula. There was no collapse. She comes to me from Kolkata every time when I call her. Excellent healing you see here. Only thing is, if your fibula is short, then it will not resist to collapse. If you seat your fibula just subchondrally, collapse will not occur. And by this time, some regeneration can occur. Wonders. It's excellent. And this boy, you see, he is now in custom department at Mumbai. Next time he's coming to me in March and I'm having his next X-ray. This is 2005 or 6 recent sign, you see. This is after 195 weeks. Fibula is short here, you see. And this whole area is collapsed. And this is impingement. See, after 300 weeks. Weight is being borne here. I don't know what is happening here. In lateral view, maybe there is some congruity because cartilage is very strong structure. That was my statement earlier. Some part of the cartilage is still left, which is giving him a good bearing surface. And you see here, except that he cannot sit cross-leg. Rotation is limited, external rotation is limited. This is his function, pain-free. He is married now. And so this is after 13 years. The patient X-ray may be looking bad, but functionally these patients are very good. So he was a child when I removed this screw and put a graft. Now this has been now more than 13 years. Now it is 15 years. This is 22, and he is married also. Anytime we have bought so much of time. So THR can be done whenever there is a reduced space of pain, reduced space and the patient has pain. So osteo means with your debridement and reverse bone grafting or bone grafting, if you do seriously, give you excellent result. Osteotomy may be more acceptable in younger age group than arthroplasty, and most patients in my series are between 18 to 33, and they are doing very well. See, this is, I did the subyoka osteotomy in this patient. But after 2.5 months, he had a fight with his brother. So he got on the wall and had a fall, and it is located here. Sometimes good results are not in my. You see, whole of the head is involved. So I rotated through 180 degree, no 120 degree. This is a girl, 21 years. She recently got married. So containment. This is varus osteotomy. If you do the varus osteotomy, you contain it, so it will revascularize. You see, this is revascularized, and these are 231 weeks, and this is after 20 years. See, he has got some shortening, but containment of the head, bringing some healthy bone under the weight bearing zone, gives you excellent results. And that is what I wanted to speak to you. Thank you very much. You see this thing, he came in from Nepal. So on this side, I did just drilling, or maybe reverse bone grafting. On this side, it was grade 3, so I did flexion osteotomy. You see here. Just see. In flexion, you are getting this, and this area is filled up with bone. And that is the graft which I achieved, and that is the plate. And here you see, I did a flexion osteotomy of about 20 degree. Rotated the head anteriorly. He was recently married, just 1 month. And you see here, the osteotomy is reverse bone graft on this side. This is flexion osteotomy, and I show you how is that. This is flexion, you see. So a wedge-based anteriorly was removed to cause flexion. So I mean, more anteversion in a way. So that healthy bone comes under the weight bearing dome, combined with valgus, and it worked very well. See, it worked very well. I further define it. See this. So this is the flexion that shows you the original one, and how a healthy bone has been brought under weight bearing dome. This is the healthy bone under weight bearing dome through flexion at the intertrochanteric level. See, this is how it was rotated, and this is good bone. And see results after 2 years. No limp in this patient. Now it is 3 years. He keeps on sending me. This is the osteotomy healing. You see, the prominence is reduced here, and neck is narrow because it has been rotated. And this is picture in my hospital, Max, and it has a good video. No limp at all. And I wish this continues pain-free. This is is some other patient. So many patients. So I will do various osteotomy here. Just see. So this bone is healthy. I think I'm the same. This bone is healthy. This girl, she is a dancer. This is a healthy bone. I did various, firstly on left side, then on right side. So these both are the osteotomies. Various osteotomies. The healthy bone is brought under the weight bearing dome. So this patient has been moved medially towards the fovea side. And see this. It has healed with bone. So from here I took the grafts. This area is debrided and the healthy grafts are placed here. And all this is in non-weight bearing area now. See this. It's beautiful healing. It's beautifully healing. The head has maintained its shape. It has brought out a very, very dome. And again she walks beautifully. Just 21. A dancer. Only thing I have told her, please don't dance. This girl is very happy after 3 years. This exercise she sent me on 1st November, you see. 3 years. This area is all healed. If this is healed, so this debrided area is also healed. And you see, when I put the blade, track, the grafts are lifted from here. And you see this healed area. You will not find in literature such cases. Dr. Basoki sir, you don't find such cases in literature. I'll publish it. Now they know me. Every publisher, including Swansevsky, James editor, knows there is some Maggu in India.
No, so that future generation know what it is.
Yes. I'm teaching and showing my results and learning from the future generation also. Don't be made after THR. Do THR when absolutely indicated. You can do a THR when osteotomy fails. When there is infection, you can still treat it. But once there is infection after THR, even God will not save. God will say, why did you go for THR? Thank you very much.
How do you?
Paresh, very nice. Keep asking.
So how do you decide when to do varus and when to do valgus? Is it the?
I just showed you that outside peripheral bone, which is non-weight bearing area, is very healthy.
Yeah. So the
so if you bring it down, so by doing a 20-degree varus, how does it matter? A patient has come to me from New Zealand. He had osteoarthrosis bilateral. He says, wherever I go, everybody says bloody metal inside, this side metal, this side metal. What is this metal? Madhu, I read your name, I have come to India. I said, okay. So package was for both the hips. So when I operated first hip, he was very happy. I said, see now, if you are satisfied with the result of this hip operated, you come to me after 3 months or 6 months or second hip. Otherwise go for THR. One should never be mad for THR. Osteotomy is work wonder. So the healthy bone is lying, when more of the healthy bone is lying outside the corner of the acetylum, keep it inside. Make varus about 20 degrees, only 20 degrees is enough. Bring healthy bone, I told you my concept, that even with the collapse, the function is excellent. Harris score 100 in those patients. So you can also have 100 Harris score if you bring healthy bone, which is uncovered, and cover it with the.
So like I've seen in your cases here, most of your valgus osteotomies, there has been osteophytes and excess bone growth adjacent to the acetabulum, whereas most of your varus osteotomies, they're healed with a spherical head.
Yeah, so the valgus osteotomy, they have follow-up of 20 years, 25 years, 18 years. The varus osteotomy have short follow-ups. Okay. But it is because of the stresses in valgus osteotomy, yes, stresses per unit area, that nature forms more bone in the form of osteophytes to increase the weight being dome and reduce the stresses per unit area, biomechanics you talk. That was Bombali taught us. Yes. So as per biomechanics, What is being formed is as by nature desire.
So in those cases, bilateral varus you have done, did they have any lurch or something? Badly. You showed one girl. You couldn't see the video, that's why I'm asking.
She walks beautifully.
Okay.
She walks beautifully. 3 years have passed.
So nice demonstrations.
One question. Why do you think, why do you think Sugioka and Korean surgeons got such good results and Western people got totally terrible results?
What Sugioka is doing and what I am preaching is the same thing. Only difference is that you are bringing a healthy bone by rotation through transtrochanteric osteotomy. I am doing it intertrochanteric osteotomy and then doing rotation. My procedure is very simple.
No sir, I am not saying that. Both the procedures are good. Why are Western people not getting good results?
They are not doing it. My first lecture, you listen to it. Very few surgeons are doing osteotomy. Most of the surgeons are loving with the companies of THR. Reason may be any, but they like to do THR. They say no. My patient must walk next day on foot. So THR is good. So he tried to emphasize it. We say, doesn't matter if our patient doesn't walk for 6 weeks. How does it matter to you? And if the head size is good after osteotomy, I ask him what will weight bearing.
Most of this
Most of things are company generated.
most of the Western literature, the osteotomy, the methodology is they do a capsulotomy.
Because they are showing 18% result.
10% result with Sugioka. If you
Sugioka.
observe the methodology of Western papers, observe the methodology of Sugioka, there is no capsulotomy done in Sugioka.
No, it's not done.
So whereas the Westerners to turn this, they do a capsulotomy. So probably that might have
Losing
damaged the
results.
results. That may be the issue.
Sir, to Mogu sir and all the senior faculty, many times in my limited years of experience with avian, sometimes the patient comes with a near complete collapse, a severe pain, and you almost plan to go for a THR or any medical management. But eventually, if because of social reasons or financial reasons, when they come back after 6 months or after a year, the head is collapsed, it's completely athletic, still they are pain-free. So, is there, my question is, should we intervene?
What are these androgens and all? Actually, they are painkillers. So one of patient came to me, operated by one of my colleagues who was fond of BTA. So I saw drilling had been done, and there was a lot of collapse, but there was no pain. So some research projects are being taken by Mittal et al. In AIMS. I asked them, yeah, there is so much of collapse, what are you doing? Boss, you are right. There is a collapse. These arendronates are very good painkillers. After some time, they will suffer again. He also said painkillers.
No, they definitely relieve the pain, sir, not the immediate follow-up. The one in the acute stage of collapse, when there is cartilage delamination or when there is
If you think that you cannot bring a healthy bone, or there is no other way of biological procedure which can raise or elevate the, you go for THR, this doesn't matter.
No, sir, the question is not about THR or conservative.
You said it right. Often what you see in X-ray, what you see with the patient is a hell of a difference. That's what we have observed. As Professor Maga has also put his hips which are collapsed and devastated, but he is squatting on the floor very nicely. So hip, what you see X-rays, what you see clinically, there's a sea of difference. Exactly, that's right. So when patient is painless, he will not accept totally orthoplasty or osteotomy also. Definitely. Let him demand. Let him demand.
When we have data of all those patients, there is a system in this country, research will come from there.
Yeah.
We are not keeping our own data. It's really very difficult.
They are very poor. Data collection.
Yes, you are right.
Very good in data manipulation.
When you don't have visuals,
Yes.
I do it with that. I've shown my practice also. You can't get it.
What about implant removal in this space? Is it necessary to implant removal or not necessary?
Implant removal, when you go abroad, rent a hospital, the first cases of implant removal, what are you removing it? 2 years have passed, sir. Actually, it is a money making. Biologically, they are right. Even after 40 years of osteotomy, there are hundreds of patients I have not removed the implant. But you should remove it. But what is your question?
Whether to remove the implant or not?
Unless the patient asks me, I have never removed it. And even he requests them, yeah, get it removed. Get it removed. He says,
probably
पहला ऑपरेशन बहुत मुश्किल से करवाया ये दूसरा.
Probably they are very afraid the implant could remove.
Our patients, you see, he will die. It is very difficult to convince him for surgery. So many cases of irreversible deteriorate. Sir, medicine se theek kar do. So some people sitting in Jaipur, Ayurveda, Ramdev Chelas, all those people, they keep on trying their medicines and keeps on showing its color.
Many fruit.
Lot of deterioration. Very difficult to convince patient. Implant, again I tell you, in a collapsed head, no, I'm talking carefully, don't remove the implant. It is giving some support. The moment you remove the implant, this will further collapse. So in a case of avascular necrosis, maintaining its shape, even if peace and sign is there, please don't remove the implant.
I think if you are done, we'll break for tea. Then come back.
On these topics, the hip dysplasia infections and
the previous slide once. I want to take a picture.
Yes.
Thank you, sir.
Yeah. So I'll just cover these on these subheadings. Okay. So whenever we treat any disorder or any condition, so we have to know what is there in our hands, which method we have to choose a treatment, whether it's conservative or operative. If it's operative, what kind of operative treatment we have. So similarly for hip preservation, so we have a proximal femur osteotomy. Okay. Then we have the recent concepts of safe surgical dislocation, which has opened up a big window of opportunity to treat a lot of these conditions. And we have the age-old techniques and the newer techniques of pelvis tabular osteotomies. So coming to the hip dysplasias, straightforward congenital hip dislocation, we all know the treatment of open adduction. But the problem is when you have a subtle dysplasia, a gradually progressing dysplasia which presents at a later age. Very often these go unrecognized and they present after walking age like 4 or 5 years or sometimes even in early adolescence. Okay. So look at this 4-year girl. So when you look at these 4 components, so there is instability as well as inadequate coverage. So the cartilage usually is good in these things, but there is incongruity. So there is no impingement and there is abductor function is insufficient. Okay. So the main things what you have to address here is get a good coverage, and we have to, once the coverage is done, means we reduce the hip, the abductor function gets restored. So if you look at these is what we have options, what we have to choose from these things to treat this particular hip disorder. So we can think of these 2 things. After, in addition to open adduction, we have to do osteotomy to produce a varus and also to shorten the femur and get a acetabular correction by reducing the acetabular index. Okay. So for this patient, so one can think of open reduction and femoral osteotomy, shortening as well as a varus osteotomy, and acetabular osteotomy too. So acetabular osteotomies are of 2 types: volume reducing or V-shaping or redirectional osteotomies. So in this case, because it's a skeletally immature child, we can think of a volume reducing osteotomy, either a Degas or a Pemberton's or even Salters. Okay. So according to the plan, this child had undergone open reduction femoral osteotomy as well as Degas osteotomy, and you can see the hip is well contained, the acetabular index is corrected. So the components of instability and inadequate coverage are addressed, and abductor lever function also will be restored once the hip is inside the joint. Okay. So this is another similar case. So these couple of cases are borrowed from Dr. Vidyasagar, my colleague from Hyderabad. So here bilateral staged open reduction was done. Along with that, a Pemberton osteotomy was done. And you can see on the extreme right side, all the components of the hip biomechanics are restored. It is contained, the Shenton's line is intact, the acetabular coverage is adequate, the abductor lever arm function is good. Okay, so this is what I was talking about, where the presentation is very late. Subtle hip dysplasias can present at a later age when they start complaining of groin pain. So, Srikanth was telling in the morning about C sign and the lateral hip pain. So, when they have these hip dysplasias, there is micromotion which is happening and the gluteal muscles gets tired very fast. That's when they start to develop lateral hip pain or anterior hip pain. So here you can see the Shenton's line is broken. I always look at a Shenton's line because that gives me how well the hip is aligned. Of course, the Shenton's line also depends on how we position the pelvis and the femur. So the acetabular, there is significant acetabular dysplasia on the right side, and there is lateralization, superlateral migration. The C angle is negative, and anterior also there is uncoverage. So if you look from what is deficient here, there is instability, inadequate coverage. There is some amount of incongruity between the acetabulum and the femoral head, and of course there is insufficient abductor function. So we have to correct all these components. Okay. So when you do the pre-op planning, so these are X-ray with neutral limbs in neutral position. So this was the maximum abduction possible. So if you want to plan a varus osteotomy to contain this hip, you have to do an abduction X-ray to see whether it is contained or not. So here it is not completely getting seated, though the Shenton's line is restored, but the amount of abduction required is quite significant. And still there is acetabular dysplasia. Okay. So varus osteotomy is alone is not an option in this child. Okay. So look at this X-ray maximum flexion abduction. You can see the hip is well seated inside and it is covered, but acetabulum is still upsloping. So for this, when we look at the options, of course, safe surgical displacement is not an option. And varus osteotomy, I don't think is ideal here because we have to do significant varus osteotomy and still you are left with a dysplastic acetabulum. So better for this would be to consider a redirectional osteotomy like a triple osteotomy. So this child has undergone a triple osteotomy and you can see how the head is, the acetabulum is covered over the femoral head. Okay. So this is at 6 weeks. So if you look at what are the issues that particular hip has and what are the options you have, then you can decide a treatment plan. So coming to the post-infection sequelae. So this is one condition which needs maximum customization because the effect of infection in the septic arthritis sequelae are huge. You can see here different kinds of sequelae of the septic arthritis. So that's why I always stress whenever you have a doubt of septic arthritis, do not delay in draining that hip joint. As soon as you suspect a hip joint, get relevant investigation. Don't put the baby on continuous IV antibiotics. Ultimately, the infection will settle, but even the bacteria may die. But the inflammatory cytokines can cause significant cartilage damage and can damage the hip joint. So do not wait for that to resolve only with antibiotics. You have to drain it. Okay, look at this 4.5 years boy. The parents refused surgery when I've seen this child in neonatal period. So they came at 4.5 years, and you can see the sequelae of the septic hip on the right side. So there was shortening, limb, and difficulty in sitting on the floor. And you can see that the proximal femur epiphysis and the physis is not growing properly. The neck is quite small. The trochanter is growing normally and it is overriding. So there is instability and inadequate coverage. And most of these septic sequelae, it is not just the abnormal bone formation. There's a lot of scarring and fibrosis. And the cartilage also is not healthy. So even after reconstruction, we don't know how these children respond. And there is insufficient abductor function. So if you look at our armamentarium again, so we are left with an option of open reduction and proximal femur osteotomy. So accordingly, this child, I did a lot of scar tissue release before I could reduce the joint, and I had to shorten the femur to get the femur leg into the socket, and there's a lot of anteversions who had to do a retroversion osteotomy. So this is immediately after this spica removal, after almost 2.5 months. That's why you can see the pelvis is tilted in this abduction contracture. Okay. So I don't have the latest follow-up. Latest follow-up was just about 2-3 weeks back. So in spite of, usually it might look like this now, but usually these kids, they have a potential, they have high potential for remodeling, and usually they tend to go on to heal well. So this another child who presented late in the neonatal period. We still did an arthrotomy and lavage. Probably we could limit the extent of damage, but not completely. So this child was born at 11 months of age with concern of shortening of the limb and limitation of hip abduction. So this is what I expected. I thought I'll do an open reduction, the hip is subluxed like this. Okay, but the interim finding was like that. Okay, because clinically it was stable. I was not able to correlate why it was like that. I thought it might be fibrosis, which is preventing the hip from migrating proximally. But when I opened the joint, the proximal femur was like this. Okay, you can see there that circled portion, and you can see the arthrogram. I have drawn an outline of the femur leg. It was like a bilobed, deformed and flattened head. So the head on the medial side was like a tongue-shaped protrusion. So in spite of extensive release, I was not able to push the head inside. So what I had to do was had to shave off that inferior beam. Only then I could reduce the volume of the head. It's like head reduction surgery. Then after that I can put the head inside. And this is the post-op X-ray. So that's why I said a lot of these post-septic sequelae needs a lot of customization. So this is a 9 years boy presented with limb and restriction of mobility. Srikanth might be remembering this case. We operated in Hyderabad. It's almost in 2010 or something. So you can see the shape of the proximal femur. Almost there is no head. The head is, no neck. The head is almost smeared against the shaft and the trochanter is overriding. Okay. So these are all the things which we have to address in this boy. There is instability and inadequate coverage, incongruity. There is impingement of the trochanter, inefficient abductor function. All these things have to be addressed in this boy. So what we did was, so what we have option is to do a safe surgical dislocation and reshape the head, do a relative neck lengthening and proximal femur osteotomy. So the concept of relative neck lengthening was not still that popular when I did this surgery. So what I did was that time a moisture osteotomy. I did a safe surgical dislocation approach and did a moisture neck lengthening osteotomy. I used a pre-bent LCP which was bent on table because I couldn't access the blade plate as Dr. Margo sir. And many times it's difficult to get a pediatric blade plates. And pediatric hip plates are available, but those are very expensive. So this is how you can see how well the child is remodeling after the surgery. So the child's hip has a potential, high potential for remodeling and accommodating and reshaping. So you always have to do whatever maximum possible to get the hip inside and get it into the acetabulum and restore the biomechanics. So and this is at 17 years after the surgery, when the 17 years of age, 7 years after the surgery, he had some impingement symptoms, but otherwise, if with repeat surgery, we can take off that bump, and I think he will probably, his hip will last for almost entire his lifetime. Okay, now coming to the other pediatric hip disorder, the Perthes syndrome. So this 11.5 years boy presented in stage 2, Elizabeth term, stage 2 disease. So he came with symptoms of restriction of movement, difficulty in squatting and sitting on the floor. So this was a very relatively stiff hip. You can see that when I am trying to get an abduction view, the entire pelvis is getting tilted. So there is no abduction. So we all know that for Perthes, one of the standard treatments is varus derotation osteotomy. But what I want to say is, you clinically assess, under anesthesia you assess whether there is an adequate abduction. If there is no abduction, that's a definite, absolute contraindication to do a varus derotation osteotomy. If you do a force abduction, varus osteotomy, it will cause impingement of the head against the edge of the acetabulum, and it can lead to a stiff hip, adduction deformity subsequently. So considering this relative stiff hip and suspecting a hinge abduction, and already the child is 11.5 years. So if I do a varus osteotomy in this boy at this age, the remodeling may not happen to that extent. So considering this, I planned for a shelf acetabular procedure. Okay. So this is an immediate post-op picture of a shelf procedure. So there is adequate lateral as well as anterior coverage. And this 2 months post-op, the graft is well incorporated, the head is contained. The only disadvantage of shelf is it's a fibrocartilage on the top. Whereas in a varus osteotomy, you are giving a hyaline cartilage, the head is under the acetabular. But what we feel is, if we protect the head until it is healed, it will not get deformed too much. Okay? And you can see this has a really good outcome, and the excess graft usually gets resolved on its own. You are symptom free, so he is able to do all his activities. He came for follow-up just 4-5 days back. He has subtle limp, that's because of the shortening, which is about 1.1 centimeter. Had I done a varus osteotomy, we would have ended up in a shortening of almost 2 to 3 centimeters. And they say in this child would have ended up in a stiff hip. So we have to do a lot of customization. So this is another 13-year girl with very painful and stiff hip. It's an adolescent perthes. They present almost like an avian of adult avian. There's a lot of adduction deformity. Adduction deformity is because of the lateral bump, and the head has no room for it to abduct and come to a neutral position. You can see the pelvic tilt, and it's a very painful condition. So what we have here, inadequate coverage, there is incongruity, and the articular cartilage is defective. There is impingement and insufficient abductor. All 4 components have to be addressed here. So what I chose was an option of safe surgical dislocation to remove the bump, because I didn't want to do any osteotomy here. So I just did a safe surgical dislocation. I removed the bump, what was impinging. So the moment I did that, the head was automatically inside the acetabulum. And you can see here, the femoral head and the acetabulum is bilobed. Okay. In addition to doing the osteochondroplasty, also did a relative neck lengthening that restored the abductor mechanism. I mean the articular trochanteric distance. So you can see at 4 years post-op, she only had limp, okay, because of some amount of shortening. Otherwise, you can see a bilobed acetabulum and bilobed femoral head has remodeled so well. So as we have seen in earlier presentation, time gives us a lot of things, the nature to heal. So we have to respect nature and follow the nature. So another condition, slipped capital femorolysis. Of late, this condition is becoming very much prevalent in our country because of obesity and bad lifestyle. So any child who presents with a knee pain in an adolescent age group, always screen for the hip and get both the views of the hip, AP as well as frog-leg lateral. So 15 years obese boy with an acute, stable and moderate slip. He presented with symptoms of pain, anterior hip pain and difficulty in sitting in a chair. This is probably because of the anterior impingement and outgoing gait because of the slip. So what happens in slip? There is retroversion because the femoral head has gone, slip posteriorly. There is a functional coxavara because the head is down, and there is impingement because the slip part of the head goes down and the neck comes up and impinges against the edge of the acetabulum. So what do we have option here? Proximal femoral osteotomy, safe surgical dislocation and acetabular osteotomy. Can somebody say what can we do here? What option can we choose here? It's an acute, stable, moderate slip. Can we do in situ pinning? Yeah, in situ is a gold standard. It's very much accepted. Okay, in situ it's like playing safe to prevent further progression. And there are a lot of papers which say that in situ pinning is quite safe. Okay. Yeah, so adding bumpectomy is an added advantage because straight away we are removing that impingement. So in situ pinning and bumpectomy is quite safe. You can make a small anterior approach and you can straight away will be on the neck and you can resect the bump. Okay. So these are the options. So other option is capital realignment. You do a safe surgical dislocation and realign the slip part of the femoral head. Okay, so in this boy, the parents were not willing for the risk involved in the capital realignment. So I did an anterior approach, bumpectomy and in situ pinning. So you can see that I have taken off the bump anteriorly and did a pinning in situ. So this is the result. So you can see that all 4 parameters. He has a good cartilage on the top. The head is stable and it is in the socket. Adequate impingement-free motion, and is a good abductor function. So all the components which are necessary for good biomechanics of the hip are restored in this boy. So he went on to do well. So another boy, 12 years, acute stable slip capital femoral epiphysis, and you can see compared to the previous case, the degree of slip is more in this boy. So what can we consider for this boy? Again. Yeah, so as the degree of slip increases, you almost have to start on the anterior aspect of the neck. Okay, because to get the direction of the screw in the center of that, we have to start almost on the anterior aspect of the neck. So that can be another source of impingement. So one option is to do a bumpectomy and anterior bumpectomy through anterior approach and do a in situ pinning. Other option is to do of course, in situ pinning is still an option. So if anybody given an option, which is the best option you can think? Anyone? So safe surgical is always the best because it restores the complete anatomy, but there is a risk involved and there is steep learning curve. Unless somebody has done adequate safe surgical dislocations and has experience of treating this, do not attempt this. So you are always safe doing a in situ pinning. Okay. So anyway, this patient I have done because the parents gave consent, I have done a capital realignment surgery. And you can see the normal anatomy has been restored here, and the head neck offset is restored, and child went on to heal well. This is at 4 months post-op. You can see that the proximal femoral epiphysis has healed. Okay. So another 13 years boy, chronic stable slip. We can see it is it's almost like a healed slip, I can say. But you can see large bump anteriorly, which is causing retroversion. The external rotation. You can see the limb is external rotated. This is because of the slip. The limb is external rotated. But here, main concern was outgoing. It was almost like walking like this, and he had difficulty even in sitting in a chair because of the large anterior bump. The moment he sits in a chair or flexes the hip to more than 90 degrees, it was causing pain. So this was my plan. Okay. So the best option here to do is a safe surgical dislocation, do a relative neck lengthening, and restore the articular trochanteric distance, and remove the bump as marked there. That's what I did. You can see that head there, the bump at the head neck junction, the arrow where it is pointing, and you can see the screw head there. Before doing a safe surgical dislocation, I put a screw in situ fixation to make sure the head does not slip further and it is stable. So once, actually many of these you don't even need to do a dislocation. You just need to expose the head neck junction and take off the bump. You can see here, I am trying to recreate the head neck junction, offset at the head neck junction. So this is the result, and you can see anteriorly there is no bump. And the moment you do this, their external rotation goes off and their impingement goes off, and they are quite happy. Okay, this is probably about 6 months post-op. I don't remember exactly, but he was doing quite well. So okay, this is another spectrum of a healed SCFE sequelae. Limb outgoing pain and difficulty in squatting, all because of impingement. So for this boy, the degree of slip was quite severe. You can see in the AP view on the bottom left side, it was quite severe. So I thought of combining the procedure of proximal femur osteotomy as well as a safe surgical dislocation to take off the bump. Okay. So this is what I have done. I have done a flexion, valgus, and antiverting osteotomy for this boy. So another boy,
you can see how deformed the proximal femur are. The trochanters are high reading almost at the edge of the acetabulum, and you can see a tongue-shaped projections of the head. So his main symptoms are restriction of motion, again difficulty in squatting and sitting on the floor. So this is as a pre-op evaluation. I got a CT done to see what's happening here, and you can see like tongue-shaped projections on both sides. Still, I don't know what is the cause of this. Whether it's some sort of a hip dysplasia or it's a post-septic sequelae. It is quite symmetrical on both the sides. But the head is well inside the acetabulum. The coverage is good. Okay. Only problem is impingement and high riding trochanter. So probably some insult to the proximal femur growth plate, which has resulted in this kind of a deformity. So what would one do in this? Head reduction is not an option here. So what is causing the problem here? The tongue projection there. Okay, so we have to take off that. And what is abnormal here? High reading trochanter. So if you address those two issues, I think he will do well. Okay. So if you look at the armamentarium, so I thought of doing a safe surgical dislocation and addressing all the problems in one surgery. Okay. So I did an osteochondroplasty and relative neck lengthening, and you can see on the lateral views the tongue shape projection has been removed. Probably I should have done a more relative neck lengthening, especially on the right hip. But intra-op I felt that the articulotrochanteric distance, the tip of the trochanter was at the center of the head. So that's what made me stop at that level. Maybe if I think retrospectively, I thought I should have done more relative neck lengthening. Okay, so this another girl. I had treated this elder sister of this girl for a skeletal dysplasia with a forearm deformity. She presented with pain in both hips, which increases on walking. So this is a typical of hip dysplasia. They walk for some distance. It's something like a spinal canal stenosis. Okay, they walk for some distance. They develop radiating pain in the lower limbs. They sit for some time. They get relieved. Similarly, in a hip dysplasia, they walk for some distance. Their abductor muscles get tired and they get pain. And also component of the instability. Okay. So here the problems are instability and inadequate coverage, insufficient abductor function, and some amount of incongruity. So as a part of pre-op planning, so this was the pre-op planning, we got an abduction interpretation view to see whether it can be contained with the varus osteotomy or we need to do a acetabulum procedure. So once this was done, we need to decide. So what can be done for this child? I'll go back to the previous X-ray. So one option is that we have to do a acetabulum procedure because there's a yes, sir. We have yes. So acetabulum procedure has to be done for this child. May not with the varus osteotomy. I think once we do a acetabulum procedure, redirectional osteotomy, we don't need to do any acetabulum procedure because if you look at the proximal femur, the articular trochanteric distance is good, the neck shaft angle is good. Its main problem, primary problem is in the hip, in the acetabulum.
Can shelf also help?
Shelf problem is too much more than almost. The only thing is, so if you have good cartilage in the acetabulum, with the redirectional osteotomy, if you can get that normal acetabular cartilage onto the femoral head, that will be a normal joint. Whereas shelf, we are giving a fibro cartilage.
On the left, it will be successful. On
Yeah.
the right side, other side.
Right side.
There is,
On the left side, there are already arthritic changes. Maybe it's not clear on this slide. On the left side, there are already arthritic changes. So I discussed this case with, because I was having little doubt whether to go ahead with only varus or liquid acetabulum procedure. So I discussed this case with Dr. Prasad Gurnemi. So he said, according to his planning, he said left hip is already arthritic. So he said better to preserve the right hip and focus on the right hip now, and later on do the address the left hip. Okay. So accordingly, she underwent a GANS osteotomy. This was again done by Dr. Prasad, not by me. So he did a GANS osteotomy, and on the right side she is pain-free. but you can see on the left side it's already arthritic. So probably.
Bone for hands is very less actually.
Pardon, sir?
For a hands osteotomy.
Yes, sir.
The bone on the posterior column should be good enough, good stock.
Yes.
Because you have to scrape the posterior column, most of it. And
Yes.
also in the middle of it,
Yes.
you rotate.
Correct.
Here the osteotomy, of course, there is in the mobilization velocity, but I think when bone is less,
Yeah, sometimes what happens,
osteotomy may be useful.
there can be a global dysplasia. Both anterior and posterior walls can be deficient. So usually what happens in hip dysplasia, anterior wall is deficient and there's anterolateral subluxation. But in some cases, she has some underlying skeletal dysplasia like her elder sister. Both the walls are somewhat deficient. So whatever best could be done to salvage the tostal, this is probably buying time. Maybe she will require a future replacement depending on her.
He has done the superior cut, and
Yes.
then he has, put it on the head of the femur.
Yes.
Anteriorly, superiorly and anteriorly.
Yes.
Anterior coverage is also there.
Yes. Yes.
And nothing on this side.
No, this is already arthritic. He said if the cartilage is gone, there's not much role for triple osteotomy or a Gans osteotomy. So this is another bouncer which came to me. This is a child with a neuromuscular problem. There's some sort of a spastic cerebral palsy. He was ambulant, but he was brought for limp and significant shortening and difficulty in sitting. So I feel proud. I don't know whether it's a pathological fracture which has healed or maybe infection sequelae. I don't know, because most of these CP children, they would have had some ICU admissions when they were neonates or infants. So I thought it might be a post-infection sequelae. But initially when I first saw it, I thought it must be a pathological fracture which has united, maybe SPC or something, which has healed in a varus. I thought it was a straightforward. Does it look straightforward? Or what can be done for this? Yeah, he's ambulant. So the problem is, it is well covered, but there is significant varus. And yes, I thought it's a straightforward valgus osteotomy, and I went casually. Then I was in soup. It was a mess. It was so difficult. What I thought was a simple procedure. There's a lot of deficiency of the acetabulum. If I was doing more valgus, it was unstable. So I I could say, without proper preparation, we can end up in problems like this. And probably I didn't get a CT or something in this child as a part of pre-op evaluation. So that is one of the reasons because of which I didn't do a proper pre-op planning. So I somehow sort of just played safe and came out. Okay, because I didn't want the hip to get out. I didn't want the child to have another problem. There's a lot of retroversion and there's a lot of varus. It's almost a combination of congenital coxa and a combination of scoopy. So it was
What is the age of this child?
It's around 15, sir. 12 years.
12 years.
12 years. He was a spastic CP, but he was ambulant. Ambulant with support. So I just want to emphasize that good planning is very much important. Not every case is a straightforward case. So that was the reason why I put up this case. So as I said, we have to connect all the dots and do a proper assessment. So we have to address all the 4 components of hip pathology to restore the normal biomechanics. Okay. So we have to think of what are all the options we have, not only hip, in all other conditions, what are the options we have to address that particular issue, and put it on a paper and decide which is the best option. Okay. So for hip, coming to hip, the aims of preservation are to get a good cartilage on the top of the femoral head, a stable head in the socket, an adequate impingement-free motion, and good abductor function. So once these are all in place, a patient, we can expect a near normal hip function. Thank you.
Is there any difference between the lateral protractor osteotomy in adults and in the pediatric population?
the greater trochanteric osteotomy. No, not only in safe surgical dislocation, whenever you are doing a greater trochanteric osteotomy, is there any difference the way we do it in adults and in children? Like, is there any growth disturbance to the GT apophysis? Like, how do you avoid it?
GT apophysis, not significant growth disturbance will be there because it's mainly by growth by the opposition growth. Okay, so even when we want to fuse and put a screw and drill, it still keeps growing. So there's not much significant difference. And we don't want that to grow because the reason why you are getting it down is to restore the articular trochanteric distance. We want it down, we don't want it to go up.
The osteotomy is through the physis or medial to the physis or lateral to the physis?
It is through the physis, the safe surgical dislocation cut. We take about, it's an horizontal cut.
Okay.
Thank you, Dr. Harish. Sir, we'll put up the X-ray that we have operated now. We'll have a discussion and then close the session. So we'll just put up the X-rays that we finished our live demo. Have discussion and then close the session.
I did discuss about idiopathic chondrolysis. That is one painful condition which still doesn't have a solution. But a lot of them require to 6 months minimum for them to get some sort of a result.
Is safe surgical dislocation safe?
In what? In?
Is surgical dislocation safe without?
Yeah, of course. It is. In chondrolysis or in general you ask?
In general.
Yeah, it is safe.
Can you enlarge the view? Enlarge. Zoom it. Earlier you were showing here, this is the pre-operative. So what we miss something, because when you get a good X-ray, then so many findings you are able to see. You see here, there is a fracture line here, pseudo fracture here also. It seems here also. It means it was a osteomalacic fracture, metabolic bone disorder, and it was not healing because of the pathology as well as the shearing forces, as well as its junction, and anyhow, it did require a surgical intervention. Besides, now you go through the metabolic profile and put this patient vitamin D3 also. Now here you see the top of trochanter is at the level of the center of the head of the femur on the normal side. So what we have done here also, the top of the trochanter is at the level of the center of the head of the femur. So this patient is not going to have a gluteal lurch, it will have a normal gait. This patient is going to have a normal gait. The neck is also lengthened, you see here. If you compare this side, there is a relative neck lengthening, and here we have kept the graft. So relative neck lengthening will be there because this graft will heal here. The fracture side is horizontalized and is buttressed from below also. You see, this was a Y osteotomy which I demonstrated, and this beak is buttressed in this fracture side. It is buttressing. If you see the level of the lesser trochanter, it seems there is some shortening. This is at the level of the ischial velocity on this side. And here is the lesser trochanter, but we are slightly medialized. Slightly there is medialization. No, it is not medialization. If you see this cortex and this cortex, they are in line. This cortex is here, and you see the piriformis fossa, and so it is also in continuity here. But anatomically, it seems there could be some shortening of about 1 centimeter. Maybe the fracture ends are absorbed or other reasons, but the trochanteric level of lesser trochanter is slightly higher on this side as compared to this. or maybe this hole is lesser trochanter, osteotomy is above trochanter, so this hole is, or this is more in internal rotation, that may also be a possibility. But seeing the level of this and this, it seems there is no appreciable or significant limb length discrepancy. It's all. But definitely I have come across this feature which went unnoticed because we did not have the whole pelvic X-ray, and it was bone was dense. She must have been given something, I don't know the reason. Was she eating something? Why the bone was dense? Difficult to take it out. No avian, the chances are less here of the avian.
When I was taken, there is no AV in this patient. When I also did not have any.
So on the whole, I think it is reasonably well done.
Also, did not show any fractures that you are mentioning about they are all okay. Metabolic workup also done on this patient. They are all okay.
No, yes, this is a fracture. This is a fracture.
I think he's seen an MR scan. I think he's seen an MR scan. The bone was so sclerotic when you were hammering it inside and taking it out.
Yes, it was difficult handling and taking out.
So this lady was advised a hip replacement, given an estimate of 3 lakh rupees. She couldn't afford, she came in. Hip was, he was advised a hip replacement, she was given an estimate of 3 lakhs. Estimate paper is there with her. That's the
What is age?
Age is 34. Lateral view, beta.
Some trauma in the past.
Could be, don't know.
There is a tri-radiate pelvis.
Could be.
See the rim.
Like this.
But I have osteomalacia.
That I am asking.
Osteomalacia in childhood or osteomalacia in adulthood?
Osteomalacia in
Adulthood. Could be. That's the lateral view. So what to see on lateral view, sir? I don't appreciate.
It's not a good lateral view.
Of course.
But you have seen the spear cortex, you have to see the inferior cortex, you have to see the top of the center, you have to see the osteotomy sites, all are okay. All are okay. So this is also placed at a distance from the subcontinental bone. The joint is okay, you see the calcar is okay. It is buttocks from below also, you see here, this is buttocks. This is also good. And you see, there is not much of angulation, cortex by cortex. And here also, okay, this is fine.
If this patient were to go for a hip replacement after the osteotomy, she develops an arthritis.
Is it easy to do a replacement after this?
Is it easy to remove this plate?
Yes. The passage of time and healing.
Because it was so difficult to remove that chisel which is seated inside. You have to hammer it out.
He was having less of force. The hammer was also light hammer.
His boy was hammering like.
And he was afraid of me.
Of course.
So, that's what he
If you had scolded him, he would have been on you.